So today, we'll discuss basic life support as a mandate ng ating health institution and even health dole, particularly first aid. And this is quite a vantage point. Kasi sa resiliency campaign ng ating bansa, pinapaigting natin ngayon ang tibay natin para pag may mga sakuna ay nakakatugon ang bawat isa, hindi lang ang gobyerno. But of course, if you're working in a private entity or a private hospital, kasama kayo doon because it's an all-hands approach when it comes to creating resiliency program. The ugly story that we're facing now, ladies and gentlemen, is it's not the war in China and Taiwan or the Ukraine war or the takeover of AI or another pandemic. No? But there is what the World Health Organization has termed, tinatawag nilang global scare. Ano yan? Itong tinatawag nilang global scare, ito yung dahilan kung bakit tumaas ang mortality at morbidity ng tao sa mundo. At ang dahilan doon ay cardiovascular. So, kahit ipunin ko yung namatay sa Aleppo, Syria, Aleppo, Ukraine, Marawi, hindi kayang tumbasan ang namamatay. No? Ipunin ko, ilang years na gera yon. Ukraine is more than a year na. Partidahan ko lang kayo ng 5 araw. Ang population ng 5 araw namatay dahil sa kadahilanan ng sakit sa puso at sa vessels. Tapatan ka lang ng 5 days versus itong nangyari sa Aleppo, sa Marawi. Yung mga gera namatay doon. So it's a global scare, ladies and gentlemen. And I will scare you furthermore. Bumabata na ngayon ang nadadali. O, ayan ha. And there are modifiable traits and non-modifiable traits. Yung non-modifiable, 3. Una, edad. Siyempre, pag edaran ka na, medyo dadapuan ka na, stiffen na yung inyong artery. Kakaroon tayo ng vascular problem. Pangalawa, yung gender. So, nakita nila, according to study, na ang lalaki ay prone sa myocardial infarction para sa babae. Dahil siguro, ang hormone ng lalaki, testosterone, is an active hormone. Parang ang tawag namin sa anthropology, warring hormone. Ang alam niya, gyera. So, subject siya sa wear and tear. Pangatlo, hereditary. Pag nasa lahi mo, wala na tayong magawa. Doon tayo lalaro sa modifiable. Something we can modify. So, ano yan? Number 1, hypertension. Siyempre, pag mataas ang alta pressure mo, redundancy. Pag may alta pressure ka, pag sinabing alta, salitang Espanyol, alto, meaning mataas. Alta pressure ka, i-control natin. So, depende, isang guni natin sa doktor kung para ma-check tayo, pwede tayo mag-holter para makita natin what part of the day siya tumataas para mabigyan ng saktong gamot. Pangalawa, and or to it's either meron ka and or hypercholesterolemia. Ayan. Siyempre, depende. Mag-statin tayo or kung kahit fibrates. So, depende sa doktor din. Paano niya titingnan? Then, hyperglycemia, yung mga diabetes. Control natin. Kasi siyempre, pag nataas ang sugar, it destroys the inner lining of your vessels also. And other organs na tamaan niya, like the kidney, mata mo, retina. Ano pa? Smoking. Naku, Diyos mio. Oh, siguro dito sa audience ko, baka meron, no? Hindi na kailangan ng, I don't have to elaborate. Na ano pa? Obesity. Sedentary lifestyle. Ito, wala akong solusyon kasi ito sakit ko rin. Stress. Kung ayaw nyo ma-stress kayo, huwag kayong manood ng salamin paggising nyo sa umaga para hindi kayo ma-stress. So ito, we can modify. When we do not modify, then it becomes a pandemic, no? Although we don't use pandemic on that, na wala na tayong halos solusyon. Yan yung numero uno sa buong mundo. Hindi accident and violence and war. Yan ang numero unong pumapatay, kumikitil ng buhay. At hindi kayang lampasan. Kaya sabi ng WHO, global scare siya. Okay. So I'm starting your day with that kind of bad news so that kayo, healthcare practitioners, huwag kayong basta-basta maging magaling tayo sa CPR because ang drive ng medicine ngayon ay prevention. Parang kung sa disaster, ang tawag risk reduction. So magre-risk reduction tayo para natin gawa ng paraan. Lalo na ngayon, pinauso sa new normal yung tinatawag na healthy lifestyle, yung wellness. Parang sa company where I'm working sa Energy Development Corporation, meron kami mga wellness program, mga zumba-zumba, gano'n, or mental wellness, kung anong exercises or what, no? Dapat gano'n kaakibat na. I had 2 conferences I attended where I'm speaker. Nakikita ko na incorporated nga sa evolution ng company. Nagkaroon ng mga daily morning exercises. Like in Yokohama, yung Japanese company sa Clark. So when I was teaching there, nagulat ako na in the morning, meron silang stretching, no? In the afternoon, stretching ulit. Bakit ayaw natin gayahin? So we have to create an avenue of wellness para naman kahit papano, huwag nang tumataas siya, maplatuman lang kasi baka hindi na natin mapababa yan. Just this morning, I was invited for a conference last night. So, libre hotel. So, galing ako sa Seda, kauwi ko lang. Nagulat ako sa pagkain. So, kagabi, grabe pagkain. Ngayon naman, grabe naman pagkain. Doon na lang ako sa fruits, yun ang kinain ko. Of course, I took egg because I have to teach today and tomorrow. I need also some sort of energy. I need to be concerned with my health also. Because I don't want to be part of the statistics of the things I told you a while ago. Now, BLS is the program, no, where we want to settle it somewhere along the way. Doon sa reactive part of it. Kanina, the short introduction I had is a proactive sana kung magawa natin. But basic life support is simply the mechanical part of what to do, how do we intervene. So what do we want to learn? First is we have to describe what basic life support, being a concocted term ng American Heart. So marami nang sumunod. Red Cross uses the word BLS, ASI, and every time di ka naari in the world. Pero naunang na-concoct ko yan sa American Heart Association. Then tingnan natin yung chain of survival kasi bago na. Dalawa po ang chain of survival, isang in-hospital cardiac arrest, saka out-of-hospital cardiac arrest, tapos basic life support, vis-a-vis, face-to-face with COVID program, pro-COVID protocols. Ano yung mga skills station na matutunan natin sa basic life support. And then, for those who will be taking ACLS, the bridge program of basic life support towards ACLS. So BLS is an intervention not only on emergency but on other things na hindi pa talaga not on mainly on cardiac arrest. So pwedeng sa choking, although it's an emergency, pwedeng sa agonal breathing, and lately merong inintroduce na isa pa. I'll tell you later. So bagong battery of basic life support. And it talks about a little algorithm on how do we intervene with any unconscious individual. So hindi natin alam bakit naging unconscious siya, may pulso, walang pulso, tugunan natin yun. So yun po yung program ng basic life support. And that main 2 populations adult and child, demarcation of 8 years old. Pero sa BLS kasi, 3 population, adult, child, infant. Pag sinabing infant, 1 year below. Pag sinabing child, 8 years to 1 year. So, yan po yung ating main kasi. So, we address to the algorithm or to the situation whether the patient has pulse or no pulse, or the patient is having airway obstruction. And lastly, dinagdag nila if the patient is under substance abuse, particularly opiates, under opiates. So it is intervention na gagawin ng isang personnel na na-train on BLS. So kaya tayo binibigyan ng certification, other institutions minsan may ID pa, to formalize na, oh, I'm a basic life support provider. Particularly yung strictly AHA. Sa AHA, strictly they have an ID. So ang buhay ng ID at certificate ay 2 years. So according to AHA, ILCOR standard yun. Now, the scope is, let's learn the protocol, particularly the 2022 interim guideline. Hindi ko na isulat dito, pero naisama ko dito. So meron pong interim guidelines no 2022. Then, paano ko-compress, paano ang AED operation, yung pag-employ natin ng automated external defibrillator, paano ginagawa yung foreign body airway obstruction management, paano gagamit ng rescue breathing. Ang pauso natin ngayon ay gagamit ng bag valve mask na mayroong HEPA filter. So imagine, meron akong bag valve mask na patent ng isang military bag valve mask, pero hindi ko pa nakabitan ng HEPA filter. And of course, paano ginagawa yung naloxone induction. Now, basic life support is a mandatory requirement when you want to take advanced cardiovascular life support. In other courses, hindi siya mandatory, pero kailangan alam mo ang BLS kasi mahuhulog pa rin sa BLS in case mag-a-arrest. So whether you are taking advanced trauma life support, by the way, yung ATLS, pang doctor lang po yan. Ang pang nurse and EMT or paramedic, ang kinukuha ay PHTLS or pre-hospital trauma life support and international trauma life support, ITLS. Pwede rin ang doktor kumuha niya. Parang ako, meron akong PHTLS dati, tapos nag-ITLS ako under Japan. Tapos meron din PARPIDIA, kaya ang ating ACLS course is only for adult, kasi pang PIDIA, ang tawag ay Pulse Pediatric Advanced Life Support. Pag neonate naman, neonatal resuscitation program. Meron din tayong management of obstetric emergency and trauma, basic and advanced disaster life support, advanced medical life support, and wilderness advanced life support. So marami pong mga advanced life support programs. And quite a number of these ay tinuturo sa WIPAP. Now, what do we expect to get in the package of BLS? So anim siya ngayon. I-discuss natin briefly ang chain of survival, compression mechanics, foreign body airway obstruction management, paano yung choking, and then how to intervene sa agonal breathing by performing rescue breathing using bag valve mask. Hindi na uso ngayon yung nagma-mouth to mouth, hindi rin uso yung mask, mouth to mask. So talagang medyo distansya na because of COVID. And then AED, kasama paano i-operate, although hindi naman rocket science at may pagkakamali ginawa karamihan sa atin sa health sector kasi lahat nasanay tayo AED ng AED. So kung lang inawin ngayon, bago iusad ko yung presentation, na tayo po dapat ay hindi nag-AED mainly. Tayo po ay doctor and nurses. Ang ating pong ginagawa ay manual defibrillation po, hindi po tayo nag-AED. Kung mag-automated tayo, nakakabit sa manual, yung tawag na manual override. Ang AED, Automated External Defibrillator, ay ginawa at inimbento para sa mga laymen. Hindi na po tayo laymen. Gusto kong klaruhin yon. Kasi dito nagkakamali ng pag-intindi. Kaya pa, na-train tayo, tapos ay, kailangan may AED. I-in-order ka ngayon AED. Isipin mo, nasa hospital ka, nag-AED ka. Hindi po, ang AED po, pang lay people. Tayo po nagmamanual. Either we use pads or we use paddles. Okay, and the last battery of it is the naloxone. Pag-pronounce po niyan is naloxone, hindi po naloxone. Dati ako kasi siyempre taga Mindanao ako, Bisaya. Naloxone ako ng naloxone. Pag ng mga counterparts ko ng mga foreigners, laging narc, it's either they use the word narcan. Ayaw ko naman gumamit ng narc kasi yung narc sa atin parang narcotics. No? So, okay, drive narc. Pag sinabing drive narc, you have to give Narcan. Narcan is the brand name of naloxone. So, mag-generic tayo. So, pag-pronunciation is naloxone. So, magugulat kayo, hala, may gamot na pala ang BLS. Okay? So, mainly tatlo ang BLS, gamot binibigay sa BLS. Oxygen. Pwede ka magbigay ng, kung nagduda ka na hypoglycemic, pwede ka magbigay ng oral hypoglycemic, ilalagay sa buccal mucosa. At so, ngayon, naloxone induction. And sorry pala, 3+1. Yung +1 ay any medicine galing sa pasyente na alam niya iniinom, i-assist mo lang. For example, chest pain. I-assist mo siya. Paano ibigay yung aspirin kung nag-aspirin siya or nag-nitroglycerin. Although sa Pilipinas, hindi tayo magamit ng nitroglycerin. Kunwari, ito, yung ginagamit ng chest pain, yung mononitrate or dinitrate, isodil. So, depende. Pero yung pasyente, alam niya yung gamot, paano iniinom, assist mo lang siya. So, pwede po tayo magbigay doon sa ethics ng basic life support. Pero kung ikaw, doktor ka, siyempre, bigay ka. Nurse ka na alam mo naman ano yung gamot na pwede natin ibigay as long as patients meds. So, yan po. Okay? So, ang ituturo ko is mainly BLS siya na hindi ko pwedeng gamitin pagka-doktor ko. BLS lang. So, kasi usually, karamihan sa doctors, among doctors, okay, compress. Kasi ang doctor is sa medical jurisprudence na pag-aralan natin, ang tawag sa kanya is captain of the ship. No? Ibig sabihin, siya yung sinusundan. So, there will be nurses or fellow doctors, depende kung sinong senior. So, yung pinaka-senior, habang nag-perform ng BLS, usually hindi siya mag-CPR. Iutos niya yan. You, CPR, you, ganito, airway ka, you, ganito. Dito sa BLS, kung mag-face-to-face sana tayo itong live, wala po ritong, kahit director ka ng ospital, pag nag-take ka ng BLS, magsi-CPR ka talaga. Parang gano'n. Kung kailangan mong lumuhod sa semento, wala akong pakialam kahit presidente ka ng Pilipinas, if you will take BLS, luluhod ka talaga sa semento, magsi-CPR ka talaga. Because the course requires you to do so. Maglalagay ka talaga ng AED, kahit sino ka pang Herodes na malaki rango. Once you undertake the course package, you will do it live and in color. What's the requirement? I mean, ikaw, physically, you have to do that. Now, the number 2 item, no? So, natin si BLS, na-describe natin. So, hindi tayo pwedeng umusad hanggat di natin maintindihan ano ang chain of survival. Kasi dito tayo kukuha ano yung sequence of the story. Ang storyline, pag manood kayo ng movie, there are very good storylines of movie para makuha natin what's the climax of the movie. So, meron, unless may mag-anti-climax ka doon sa dulo, depende kung anong cadence. No? But usually, there's a storyline in everything so that you can create a very good, kung movie man yan or kung anong gusto mong mangyari. Ganon din dito. There are things na we cannot violate. Susundin natin ito. Since you are all inside the hospital, ang gagamitin natin ay itong nasa itaas. Okay? Kasi unless meron kayong ambulance pool, minsan sasakay kayo sa ambulance, so pre-hospital na or out of hospital. Doon, no? Sa Pilipinas, medyo wala pa tayong batas para sa mga pre-hospital care providers. No? Hindi ganun katapang. Despite the fact na maraming problema ang Pilipinas sa field. So, yun yung training ko. I'm trained on addressing injuries and, all the chaos outside the hospital. So, yun ako. I'm not the guy you can see inside the hospital. So, hindi siya course dito sa Pilipinas. So, I got it when I was in abroad. Although, sa rotation ko inside the hospital, para masanay ako sa critical care, pero out of hospital ang aking work environment. So, pansinin nyo sa in-hospital, pinakauna is we have to recognize and prevent. So pansinin ninyo, matagal ng kampanya ng medicine to. Dito tayo naglalaan ng lakas upang sa gayon ay ma-prevent natin yung mga morbidity and mortality sa kadahilanan ng cardiac saka sa vessel niya. Then when it comes to a patient with a positive case na nagkaroon siya ng cardiac arrest, assuming, then we should know how to call for emergency response. Dati, activate EMS. Tinanggal na po yung emergency medical services kasi hindi lahat sa mundo, kasama ang Pilipinas, ay merong structured law on pre-hospital care. Marami pa tayong ambulansya, nagpo-produce tayo ng EMT, nagpapadala tayo ng emergency medical technicians sa abroad. Pero ang Pilipinas, the sad story is wala siyang pre-hospital care law. Kulang. Kung may magsabi sa inyong meron, hindi siya well-structured. So they are lying. No? Hindi siya saglit. Sorry for the interruption. Now, once there's a positive, after you assess the patient has no pulse, we perform very good CPR. No? Yung tinatawag na high quality CPR, mainly yung high quality CPR, the compression style, kailangan push hard, push fast at 100 to 120 with adequate recall. Number 2, 3, avoid interruption. Although bago na ngayon, pero yun lang yung key players mo, key points. Hyperventilation, saka na natin, although hindi yan ma-employ dito, initially kasi kahit ang emphasize ngayon ng ACLS is cover the ventilation pakialaman muna kasi nga para hindi kumalat si COVID. Pero doon pa rin tayo sa compression mechanics as kailangan kasi in order for your oxygen to be distributed to the blood, kailangan compression talaga. Then, of course, one of the greatest inventions of man is a defibrillator. Aakyat ng 80+% ang chances mabuhay ang tao. So, din-defibrillate natin. Since itong BLS ay dinesign initially para sa mga tao outside of the hospital, kaya uso-uso yung word na AED, Automated External Defibrillator. Dadala natin sa ambulansya hanggang sa ospital yung ating post-ACLS care or post-advanced post-cardiac arrest care. At ang dinagdag ngayon, no, ito, recovery. Kasi nakita nila nang hindi nila dinagdag ang recovery, ang pasyente walang tinatawag na PSG. Anong PSG? Primary support group. Pag uwi sa bahay, pinapakain na naman ng mga matataba, hindi religiously taken ang medicine kasi hindi nagda-alarm, hindi cooperative, yung ating community, nahihirapan ng pasyente kasi kunwari post-stroke siya, kailangan niya ng wheelchair, walang rampa ng wheelchair, hirap na hirap siya. So nai-stress yung tao, nagkasakit ulit, bumalik ulit ako sa simula. Ngayon, ang pinapalakas ng community natin, particularly ng ILCOR sa KAHA, is recovery must be like dito sa una ko nakikita ni kurso ko, palakasin natin to at ito para mabawasan natin itong nangyayari sa gitna. So, isang pasyente na may cardiac problem, post-cardiac arrest or status post na galing sa ospital, na bypass or what, kailangan yung environment niya ay hindi siya magkaroon ng komplikasyon. So, yun lang yun. But briefly, I'll introduce you into the out of hospital. Ang pagkakaiba lang po, hindi naman kilala yung pasyente kung sino yung bumulagta sa daan. So, wala po tayong prevention. Dito, how to activate, perform CPR, then defibrillate, tapos advanced resource sa loob ng ambulansya, pwedeng nasa helicopter ka, sa land ambulance, or sa barko or rescue boat. So, post-ACLS care and of course recovery. So, yung emphasis ngayon, kung merong exam, anong ini-emphasize ng chain of survival, pinakabago niya, na link, no? Naging 6 links na yan. Balang araw, baka naging 7 na yun. No? Kung meron ng AI, Artificial Intelligence intervention, or for whatever reason, merong bagong pangyayari sa larangan ng medisina, being a dynamic science by itself, well, pwedeng humaba pa yung link. So, ganun po ang natin. May pagkakaiba lang sa bata. Sa in-hospital, pareho. Ang adult sa pedia, ang pagkakaiba ay sa out of hospital. Although wala, hindi ganong encourage ang defibrillator kasi karamihan pong arrest ng bata ay respiratory over cardiac in origin. Pero meron na pong defibrillator. Kahapon, anong isang araw, someone approached me, gusto niya akong sponsoran ng defibrillator, tapos merong pidya mode. Uso na po ngayon. So pag open mo ng machine, unit okay. Unit okay. Check for adult or pedya patients, parang gano'n. I-pedya mode mo siya, mag-a-adjust siya ngayon ng juice. Yan. So, baka madagdagan to, pero mapansin niyo, sabihin niyo, bakit unfair? Sa out of hospital, walang preventive doon sa adult. Bakit sa bata? Merong prevention. Okay, linawin ko po ito ha. Hindi po ito basta ma-explain ng medical science, pero ma-explain po ito ng social anthropology. Ang bata between an adult and child patient, parang ako, totoo yan sa testimony. Pag nakatayo dyan isang bata at adult at parehong na disgrasya, ang bata mas lalamat sa brain ko. Mas masakit siya. I will put effort on the bata kumpara sa adult. Which is very common. I cannot explain amongst people na mas maawa. Magsuntukan niya. Merong isang adult, sapakin niya isang adult. Parang grabe naman. Pero isang adult, sapakin yung bata, mas maiinis ka eh. Parang gano'n. Kasi tiningnan natin na ang bata ay isa sa mga tinatawag na vulnerable part of our society. Katulad yun ng mga katutubo, matatanda, persons with disability. No? By the way, bawal magsabi ng PWD. Ha? Pag nakita kayo ng PWD, bawal magsabi PWD. Kompletohin niyo po, person with disability or DAP, differently abled person. Okay? Para gusto ko lang, sakto kayo, nasa siyensya at ethics kayo pag nagsalita. Pag nakita kayo na may kapansanan, person with disability, say it completely, or differently abled person. Huwag ka mag-DAP, pero pwede naman yung DAP kasi hindi pa sanay ang Pilipino. Ano yung DAP? Development Academy of the Philippines, parang gano'n. So, you can, pinakamaganda ngayon is differently abled person. So, yan ha. Then we call them blind, not visually challenged. We call them deaf. Dati, ayaw ng deaf. Sabihin natin, hearing with hearing impairment. So wag sabihin impairment. Mas okay yung word na deaf. Binalik nila, mas acceptable siya. So, BLS in the whole package with ACLS in bridging it to ACLS, it's called the BLS primary. So, una is situation awareness. Anong nangyari? Bakit siya bumagsak? And then assess responsiveness. So, meron tayong kakaibang pag-assess ng responsiveness ngayon. Then activate emergency response. Pero pag nasa loob ka ng hospital, hindi na po nag-activate ng emergency response. Ang ina-activate nyo po ay code blue. Ngayon, alam ko sa mga nakikinig sa akin, hindi karamihan ay gumagamit ng word na code blue. Ang code blue po ay majority ng hospitals. Kapag merong cardiac arrest, ang tawag, kinocode po yan. Pag merong, kunwari, fire sa loob ng hospital, kinocode. Pag merong spinal trauma na pumasok sa hospital, kinocode po yan. So, depende ano sa code. Karamihan pag heart is code blue. Bakit ayaw nilang gabihin ang code red? Karamihan pong gumagamit ng code red ay fire incident po. So, in-out na si code red. Baka maisip nyo. Kaya bahala kayo kung ano. But I'm telling you, pag cardiac arrest, majority, even US hospitals, ginagamit nila code blue. So, kung ikaw ay na-train sa basic life support hanggang sa ACLS, tapos tatayo yung hospital mo ng interventional team for cardiac arrest, you can use the code blue team. Ibig sabihin, pag member ka sa code blue team, ina-address nyo lang is cardiac arrest. Halimbawa, bigyan ko kayo. Karamihan ng member sa code blue team, ACLS na talaga yan. So ikaw ay na-assign sa male surgical ward. May nag-code blue sa ER. Mag-a-announce po yan sa PA system. Code blue, emergency room, bed number 2. Code Blue, emergency room bed number 2. Pag wala kang ginagawa na critical or crucial sa main surgical ward, re-responde ka po kasi agreement yan sa buong ospital. So kahit ilan kayo, kung wari 20 piraso kayo na train sa ACLS, assuming, pupunta kayo. Pag hindi kayo kailangan, balik kayo sa ward niyo. Pero pagdating nun, kulasa, ikaw mag-ano, ikaw mag-sip compress, yun ang job mo. O ikaw ang electrical therapy, ikaw yung magdi-defibrillate. So ganyan po ang nangyayari. So kaya nakagamit tayo ng cold blue, ayoko yung hindi natin maintindihan. Ano yung cold blue na yan? So nililinaw ko sa inyo, yan po yung cardiac team, cardiac arrest. And then you can cover the patient before you start CPR, dalawa po. Sa out of hospital, cover the mask. Sa loob ng hospital, dalawa. It's either you cover it with the non-rebreather mask or you cover it with what we call this? Bagval mask. Para pag nag-compress, kasi ngayon may delay po tayo. Hindi po tayo pwede mag-compress na walang cover ang mukha. Ang mouth and nose. Kasi pag nag-compress ako, maganda yung compress ko, liparan ko yung aerosolized ano doon. So, kinocoverin yan para bawat compress natatrap, hindi nagliliparan, or else kung COVID positive yan, dilaglag tayo lahat. Now, if you have to note why we have to employ or intervene right away, because we have a time-bound consideration. Ito po ay hindi pang Pilipinas. Kaya may 10 minutes sila na legroom. Tayo po, Pilipinas, 7 to 8 minutes po ang legroom natin. Kasi when we go beyond 8 minutes, mahirap na po buhay ng tao. So ito, 0 to 1 minute cardiac irritability, agree pa rin tayo, even sa tropical. 0 to 3 minutes, medyo kaya pa, depende sa fitness level ng tao. Pag 3 to 5 minutes, brain damage possible na po. Ito yung wala kang binibigay, you don't do CPR. Kita mo brain damage starts at 3 to 5 minutes. From 5 to 8 minutes, klarong-klaro na may brain damage na. Kaya huwag na natin palampasin, wala tayong ginagawa. Kaya isa yun sa tinuturo sa halos karamihang tao, hindi lang healthcare practitioner, na they should learn first aid and basic life support even sa workplace. Kaya siya naging institutionalized, ginawang batas ng ating Department of Labor and Employment na ang mga nagtatrabaho sa ganitong lugar ay kailangan merong training sa ganito. Pero para idipit natin itong tinatawag na golden moments na nagka-cardiac arrest. So if you see in this picture again, karamihang heart attack, karamihang cardiac arrest ay ventricular fibrillation. So ito po yung forma niya. No? Hindi po flatline. So 95% BF, ventricular fibrillation. Pag wala kang ginawa, magpa-flatline yan. So coarse BF, coarse ventricular fibrillation, maging fine BF hanggang flatline. Patay ang tao. So ito, nag-arrest siya, cardiac arrest, pero diniretso mo defibrillator. Meron daw chances. 2. So depende sa age category, umakyat even hanggang 2 to 5 yan. Dito sa fibrillation, dito sa arrest na merong nag-CPR pero late defibrillation, tumaas siya into 12 to 16. Depende rin sa age category. So hindi na totoo tong statistics pero wala akong makita ganito. Dito na-employ ang galing. Tumaas po siya into 40. Hindi po 20 yan, tumaas sa 40. Pero may age bracket. Ang age bracket dito is hindi natin pinapalampas ng 55. No? Pero na-employ mo lahat hanggang post-cardiac arrest care, umakyat po with defibrillation, umakyat po yan ng almost ng 80, around 80. 82 yata. Depende rin, basta huwag lumampas ng age 50. So isipin mo, isa sa napakagaling na na-invento ng tao is the defibrillator. Because it counteracts the fibrillating heart. Kasi ang fibrillating heart, wala na siyang hemodynamics. Pag pinabayaan mo yan, mapapagod yung puso kasi kung sa Bisaya, nakikirig-kirig yung puso niya. No? Now, what is the interim guideline? I'm sorry. Interim guideline. So, i-introduce ko yung interim guideline. Ang emphasize ng interim guideline of 2022 is, importante po bago ka mag-BLS, naka level 3 or 4 ka, no? Yung mga N95, tapos naka-cover sa level 4, no? Merong katulad dito sa mata ko, may protection sa mata. So ito pong salamin sa mata ko, hindi ko ito, may sira ako sa mata, nasanay na ako, na meron akong salamin, just to, parang, kunwari may trauma, hindi ako matalsikan ng dugo, parang way of life ko na to. So, don't PPE, hindi pwede walang PPE kasi COVID, tapos limit personnel. Dati kasi ang ideal 6 no, sa ACLS. Ngayon, binaba nila 4 to 5. Consider using mechanical CPR devices, yung tinatawag na tamper, yung oxygen powered, yung nilalagay mo lang, na hindi ka nag-CPR, ang nagsi-CPR, yung machine. No? Pinakamagandang product may ganun is Zone. Of course, hindi pwede sa infant, wala kang magawa kasi merong height requirement, no? Para ma-achieve na yung 2 inches to 2.4 inches depth, no? Particularly sa adult. So, kailangan may height and weight criteria. Tapos, itong pang-apat na item is consider everyone to be COVID positive. I mean, consider the case to be COVID positive. Kaya lalim mo ina-emphasize sa safety induction before conducting code. Code ka sa pasyente na, okay, don't PPE. Magkukuman ka na. Ngayon, ito ngayon yung, although compression tayo, pero kailangan po mauuna muna na natabunan ang airway niya, itong bunganga ilong, no? ng gamit ng gadget like the bag valve mask or bag mask valve na merong HEPA filter bago ka mag-compress para sinasalo doon. Kung nag-ACLS tayo, kailangan naka-advance airway ka agad. Tapos, merong panahon bago nag-pandemic na pag-intubate, habang nagko-compress, nag-intubate. Ngayon, balik ulit sa pinakaluma, hinto bago mag-intubate. Okay? Mandatory na ating BMV, bag mask valve, or BVM, bag mask, ay merong HEPA filter attachment. Okay? Tapos, for adults, consider passive oxygenation with non-rebreather mask para nakatabo na. Non-rebreather, pakitaan ko kay mamaya. Okay. So, yan po isa ACLS. Yan po yung interim guideline. So, ito yung breakdown, the granular issue ng interim guideline, yung reduce provider risk, no, sa ating mga responders. Kailangan sakto yung PPE. Tapos, ito yung mga COVID-19 adjustments. No? Initiate chest compression without delay or interruption while wearing appropriate PPE. And at the same time, bago ka mag-initiate ng chest compression, kailangan may nakakabit na kung wala pang bag valve mask, ay nakakabit yung non-rebreather mask para nasa salo niya. So yan yung mga emphasis which I will do a demo later. Okay, so ito yung interim guideline na binigay ko lang sa inyo. You can ask for this presentation naman kay Ma'am Joy. Okay. Now, this is the new, kung hindi nyo pa nakita to, ito na po yung pinakabago. Ipapakita ko saan nagkakaiba. Ikukumpara ko sa luma. Okay. Ito yung luma. Tingnan nyo ha. Ito yung luma. Ito yung bago. Ang bago ay 3. So, BLS for adult cardiac arrest, for suspected or confirmed COVID-19. Itong pangalawa, pediatric single rescuer. Tapos next, pediatric 2 or more rescuer. Although hindi natin pakialaman gano'n si pediatric kasi under pulse yan. So mainly dito tayo. So pansinin natin para mapalaki ko. Okay. Bitawan ko muna yan. Punta tayo doon. Gusto ko lang ma-emphasize. Okay. palakihin ko siya para makita natin saan ang mga tumbok ng 2022. O ha, 2022 tayo ha. So kung anong mga alam mo dito sa WIPAM, lagi tayong updated. Nakita ko yung turo sa, I will not mention the agency. Hindi pa sila ganun eh. Okay. Dati, situation awareness. Ngayon po, hindi ka pwedeng umawak. Pinakaunang kasi sa algorithm is limit personal unknown PPE. Kapag mag-exam tayo sa yan na po yan ang magiging patakaran. So don't PPE and limit personal. Victim is unresponsive, shout for nearby help, activate emergency response kung out of hospital ka. Pag nasa hospital ka, activate code blue. Pero dito, get AED and emergency equipment, no? Pag or AED pag ambulance or out of hospital. Pero sa hospital, case to case basis. So defib lang, no? Defib. Okay, crash card. Ang crash card po ay the whole assembly na mayroong defibrillator sa ibaba as itaas. At andun yung mga paano lang po tayo, mute lang po. So the whole assembly nandun sa ibaba. Yung ibang hospital naman, pag medyo well equipped, hindi na po kailangan magbitbit kasi merong gamit. No? Katulad nung na-ICU yung boss ko, although namatay na siya, he's a very good friend of mine. Per bed, kompleto. Now, we assess if there is, we check for pulse, at the same time checking for breathing. Pero may distansya, i-demo ko paano ginagawa yan. Now, if there's normal breathing and merong pulse, i-observe natin, nakalagay dito, monitor until emergency responders arrive. Kung anong dahilan, bakit nahilo yung tao? Baka heat exhaustion, kung marunong kayo tumingin ng heat exhaustion, hindi heat stroke ha. Nako, uso sa Pilipinas, pag may nahimatay doon, heat stroke agad. Okay, kukorek ko po kayo ha. Hindi po heat stroke yun. Ang heat stroke po, mayroon pong buhayin. Ang pasyente unconscious, either nagsisisure or unconscious na po at wala na pong pawis, pag hinawakan nyo, mainit na po. At kung titingnan nyo ang sa loob ng katawan, kung kaya nyo pumasok sa loob ng katawan, may EODs na po siya, EODS, and organ damage. Naawa naman ako sa Pilipinas, fellow doctors pa, mga specialist pa, lagi nagagamit ng heat stroke. Namatay doon, nag-cardiac arrest, dahil nasa gitna ng init, ang diagnosis heat stroke. Hindi po. Ang heat stroke, hindi ka po kaagad mamamatay. Namatay po yan cardiac arrest due to heat insult. Kakamali po tayo mag-diagnose. So, medyo matapang ako magsalita sa inyo kasi po wala po tayong environmental medicine sa wilderness medicine dito sa Pilipinas. Naturo lang po yan kung ikaw nag-IM or what naturo. Yan po yung in-depth specialty ko. Nag-aral po talaga ako ng environmental medicine. Kaya kasi ang aking specialty isa ay wilderness saka expedition medicine. So, ika nga home court ko yun. That's my home court. Paano mag-manage ng hypothermia, lalo nang umakit kami sa Everest, and understanding heat illnesses, snake bite, anything na nangyayari sa paligid, yun po yung aking specialty. So yun ang training. Kaya naawa naman ako dito, tapos minsan napapublish pa sa ibang bansa, gawin tayo. Hindi ko naman ina-undermine, pero hindi mo talaga siya linya. Kasi karamihang doktor, nagsimula tayo sa medical school all over the country, sa medical school natin, hindi naman tayo dinala sa labas para lumuhod doon mag-CPR So wala tayong ganon. No? So ang pre-hospital care is totally a different discipline by itself. At minsan na-oversee ng ating mga fellow doctors na akala nila pag nasa ambulansya, madali. Hindi po. Meron tayong tinatawag na vertical acceleration or horizontal acceleration na ka-apekto sa internal sa ng tao, nagkakaroon siya ng barotrauma or velocity trauma na meron pong mga ganong consideration na ka-apekto po yun sa tao. Kung medivac ko pa, meron akong tinatawag sa physics na Boyle's law, the inversely proportional na aspekto ng volume versus pressure. na hindi naman tinuturo sa medical school. So hindi po ganun kadali ang pre-hospital care. Kaya minsan, kinokorek ko, huwag kayo magamit ng heat stroke. Ang masaklap doon, yung government agency natin, laging ginagamit yung DOH na ginagamit yung word na heat stroke. Heat exhaustion lang po. Ang heat stroke, pinakamalala na heat exhaustion na hindi natugunan. So, I'm not here to, I'm not carrying any insult at all. I just want to correct because we are all people of science. Para naman marespeto tayo ng mundo, kailangan magsalita tayo laging tama. Kasi bawal po magkamali sa larangan ng siyensya ng medisina. Kasi kung nagkamali tayo, may namamatay na tao. No? Yan yung difference ng job natin. Kaya gusto ko sa mga malilit na bagay na correct tayo. Okay, ito yung in-emphasize ngayon sa interim guideline. Provide rescue breathing using BVM, bag mask or bag mask bag, BMV. Okay? Masarap tayong gumamit ng ambu bag. It's just okay. With filter and tight seal. Remember this, ladies and gentlemen, naka-bold pa siya at naka-underline. Kita niyo na? Yan ang emphasize. Pag hindi pa ito nakasama sa inyong BLS, kung saan nyo natutunan yung BLS niyo, hindi po updated. Ito na po yung updated ngayon. And whether we like it or not, ang medical science should be updated and upgraded. Number 2, bigay ka ng isang blow na around, kung sa adult body, katulad ko, mga 600cc siguro ako, yung laman ng aking, yung tidal volume, no? So yun lang po ibigay mo. So sa tidal volume, alam mo dapat matansya mo na 600. May mga bag valve mask ngayon na naka-Bluetooth doon sa machine niyo na habang nagbibigay ako 1,000, 2,000, 3,000, 4,000, 5,000, pagbigay ko. Bawat bigay ko, nakikita doon ilang ml. Kung ganun ang machine niyo. No? So, ang tawag doon yung ZOL. No? Napakagandang machine. Okay? Tapos, activate emergency response, no? Or code blue. Tapos, rescue breathing kung kung okay naman ang i-assist natin until the patient loses the hemodynamics or yung cardiac arrest na talaga, then we go into CPR. Baka naman kasi respiratory depression, halimbawa na opioid overdose ka, kailangan naloxone ka. Dati walang naloxone. Kasi ito ladies and gentlemen, to tell you honestly, although hindi uso dito sa Pilipinas, yung opioid, alam nyo bakit? Mahal po yun. Ang nasa Pilipinas, nakakatawa, no? Ang ating ginamit pag adik-adik ka, ang ginagamit mo ay shabu. Yung shabu po ay 4 months, stimulant. Parang lamat. Wala sa ayos yun. Gusto mo talaga mga cocaine, mga opiates talaga. No? Morphine, isang opioid derivative. Na-overdose ka, no amount of CPR, kahit pinakamagaling ka pa mag-CPR at may defibrillation ka, hanggat may opiate ka sa katawan mo, wala yan. Kailangan i-reverse mo siya. Yan, okay? So, pababa naman, halos pareho lang din sa dati. So, pagbaba, by this time, in all scenarios, emergency response system or backup is activated. So, dumating na-activate na, yung iyong CPR, tingnan mo begin cycles of 30 compressions and 2 breathe. Pero kung hindi pwede mangyari, gusto ko i-correct. Pwede kang mag-all compression. Halimbawa, nasa isang maliit na klinika lang o hospital, understaffed kayo. Paano yung 30 is to 2? Hindi mo talaga magagawa yun. So, ang gawin mo lang, lagyan mo lang siya ng non-rebreather mask, mabilis tapos 15 liters per minute ang flow rate, CPR ka lang continuous. Ang delay po dyan ay 3. Pag nag-arrest ang pasyente, inside your ward, particularly yung mga regular wards lang, kunwari, psychiatric ward or yung mga regular wards lang, hindi talaga yung mga intensive units, no? Intensive care units. Magdi-delay ka ng 3. Number 1, yung inyong bed, ibabagsak mo yun. May 1 second, 2 seconds delay ka. Lalo na pag hindi automated. Mano-mano siya yung gagawin mo yung parang may kalso na gano'n, mga gano'n. Tapos yung paasin mo, plakak, gano'n, mga luma. Hindi katulad ngayon na naka-hydraulic sa automated, pag pindot mo si ang bed kusang, gagawin siya. Okay? That's one thing, delay. Number 2, delay. Cardiac board. Kukuha ka pang cardiac board, suksok mo yung cardiac board, delay yon. Kakain ka, kung snappy ka, kaya mo within 4 seconds. Kung nag-solo flight ka, so delay. Third delay mo is maglagay ka ng non-rebreather mask. Pag naglagay ka ng non-rebreather mask, kailangan ang flow rate mo is 15 liters. Now, I have a problem in this country. May mga ospital na wala silang emergency oxygen line. Ang meron lang is a medical oxygen. Yung medical oxygen may humidifier. Ang pinakamataas po natin flow rate dyan is 10. Ang 15 po ay nakadirect po yun sa spout. Sa spout. No? At makikita mo may 15. Para sa isang cardiac arrest, according to EBM, evidence-based medicine, para maganda oxygenation to the brain, maka-achieve ako ng 90+% of FiO2, non-rebreather mask, kailangan 15 liters per minute. Magkaklaro tayo dyan. Ayaw na ayaw ko makakita na nagsi-CPR ka, nakunan ka pang video, tapos ang pasyente ay naka-nasal cannula. So, kailangan naka-non-rebreather mask. Kasi kung nag-ISO tayo or what, at ikaw nagsi-CPR ka, tapos nakalagay ay nasal cannula, nalagay sa internet, katawa-tawa na naman ng Pilipino. So, all arresting patients, non-rebreather mask. Pag naka-non-rebreather mask, 15 liters per minute. Yan ang ine-emphasize ngayon. Magklaro tayo. Ngayon, may tanong sa akin ngayon, kasi hindi naman lahat ng hospital natin high-tech. O, hindi paglaban nyo, maglagay kayo ng tangke dyan, kumuha kayo ng regulator na walang na emergency oxygen. Kasi ang pagkakaiba lang naman isang medical oxygen sa emergency oxygen ay yung merong humidifier. O, may isang oxygen na wala kang humidifier, pakitaan ko na lang kayo mamaya para sa mga taong hindi nakakaintindi ng emergency oxygen. Hindi naman siya rocket science. Pero maraming hindi gumagamit ng gano'n. So, ayan na. Ito yung emphasis ngayon. Bag valve mask device. Gusto kong linawin din, ang taong nasa airway ay airway lang siya. Hindi siya pwedeng pumalit para mag-compress. Yan. Kasama yan sa mga interim guideline. Airway lang talaga siya para pag mina-contaminate siya lang yun. No, hindi pa ikot-ikot. No? Ang nag-iikot kasi every 2 minutes, ang emphasis ng 2020 American Heart, ang emphasis nila, ang iikot ay ang nagko-compress at ang nag-electrical therapy. Hindi kayo sanay gumamit ng word electrical therapy. Yan po yung nag-ooperate ng defibrillator. Ngayon po, mamaya na lang. Tanungin niyo ako, please ask me, paano ang tama na mag-BLS? Anong tama na tao? Ilang tama na tao? 3? 4? So, i-discuss ko pag 3 versus 4 versus 5. No? Pero dahil limit tayo, medyo i-explain ko yung 3. Sa BLS, minimum is 3. Sa ACLS, ACLS ideal is 4. 4. No? Ideal is 5. The allowed is 4. So 4 to 5 sa ACLS, 3 sa BLS mandatory. Hindi pwedeng dalawa. Bakit? Pag nagdalawa ka, hihimatayin yung magsi-CPR. Now, nandyan si AED or defibrillator, no? Kung hindi si AED kasi hospital tayo, kabit natin, pwedeng manually check the rhythm, pwedeng by AED. So meron po tayong command ang AED. Ang AED, pag kinabit mo, pag in-on mo yan, bago mo siya gagamitin, i-on mo siya para magbibigay siya ng instruction sa'yo. So dalawa po ang AED para maintindihan natin siya. Makinig sa voice prompt, in English, baka naman kinuha yung AED, made in Japan, nagninihongo doon, or Korean, nagko-Koreano, or Arabic, nag-Arabic, wala tayong maintindihan. So sa AED, una mo nang gamitin, tapos unit okay, apply patch, merong depende sa AED yan, merong unit okay, check responsiveness. So ako nagsi-CPR, no? I-shortcut ko na lang, isabihin ko na lang yung AED, baka makalimutan mo eh. Ang AED ay depende po sa branch. Marami pong branch ang AED. So, depende rin sa voice prompt. Pero merong voice prompt, ang pagkakapareho lahat ng AED ay yung pagtunog ng metronome. Yung tut, 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 tut. Yan po, doon ka pa sumasabay mag-compress. Sa 2020, ang AED kailangan na po program yan, nare-reprogram. Kailangan sumabay siya sa 2020 or else, strictly 100 siya. Ang metronome, yung 100 metronome niya per minute yun. Ngayon, 120 na po. So, mas bibilis siya. So, anong susundin natin sa AED? So, nag-CPR na ako. Biglang dumating si AED. Baka magkalituhan tayo, ha? Sasabihin ng AED, inon mo yung AED, nag-CPR ako, I want you to imagine, I'm doing compression right now, people. Suddenly, the AED arrives, and then they put on the AED, and the AED gives advice like this. Unit, okay. Check responsiveness. Alam nga naman, hinto ako para mag-check responsiveness. Hindi na po ako hinto doon. Hindi ko po susundin si AED doon. Open the patient's chest. I-open. Ano yun? Siguro kung close, pwedeng iuutos mo. I-open mo na ba? Baka ano. Or, siyempre, pag naglagay kang AED, naka-open ang chest, no? Call for help. Huwag ka na mag-call for help. Natapos na eh. Kanina, nung in-assess mo yung pasyente, nag-activate ka na ng code blue. Siguro, nagbabaan pa lang yung mga code blue mo. CPR ka lang. Start compression. Pag start compression, lahat ng AED magbibitaw po ng sound na metronome. Yung pip, 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 depende. Tit, 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 susundin mo lang yun. Hindi ka na masisintonado kung kumakanta ka, tama na yung rhythm mo. No? Yung pag metronome count niya, good for 2 minutes yun. So 2 minutes ka ngayon. Plus, nag-head start ka na ng 2 minutes. May 4 minutes ka ng compression. Oh. Biglang after 2 minutes, sisigaw si AED. Analyzing. Bitaw ka. Kasi, tayo ay electrically charged. Ganon din yung pasyente. Pag nilagay doon, malilito si AED magbasa. No? So, bitaw ka. Ngayon, makikita mo, anong nakikita ni AED? Pwede nakakita siya na shockable rhythm. Kunwari, sasabihin ng AED, shock advice, stand clear. Ibig sabihin, isi-shock mo yun kasi shockable rhythm. So, dahil sa ospital tayo, magkukuman ka. 3 commands po yun. Tingnan mo sarili mo na hindi ka nakalapat sa pasyente. 1, I'm clear. Tingin ka sa airway, na kailangan sa airway, tingnan mo, pinatay ang airway. Patay. Isisiro mo, from 15 liters, isisiro mo talaga. Kailangan ikaw ang nagka-count, titingnan mo na nakasiro. Therefore, ang nakatingin sa zero, 3. Si airway guy, ikaw na electrical therapist, at yung team leader, kung may team leader na kayo, nakatingin 0. Bago kasi sigaw na clear. So, 1, I'm clear. 2, you're clear. Tingin sa airway. Sigaw siya clear. 3, everybody's clear. Pindot doon sa may lightning or may heart. Pag pindot mo, gaganon yung pasyente. Glug, glug. AED yan. Sisigaw si AED. Shock given. Check. For pulse. Pag sinabing check for pulse, mag-check ka ng pulse. May ganung AED. Pero kung wala, kung ang AED, ang command niya, shock given. Continue CPR, CPR ka. Pip, 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 sabayan mo. So, ganun po. Pero pag shock noon, ganito po ang patakaran ng 2020 AHA guideline. Habang nagkukuman ako, 1, I'm clear. Electrical therapist ako, 2, you're clear. 3, everybody's clear. Clear. Pag shock doon, yung ako, ang magsashock doon, habang ang magkukuman doon, sorry ganito, kasi ang electrical therapy, kung ito ang pasyente, dapat hindi sila magkapareho ng linya. Si electrical therapy laging nasa left side. Ideally, ang bed natin dapat, we call it the floating. Ibig sabihin, hindi nakagilid sa tawag ito, sa wall. Para ang mga emergency staff ay nakaikot. Ang ating bed ay hindi nakadikit yung ulo kasi paano siya mag-airway. So, ang ideal hospital bed po ay mayroong lugar. May headroom, side by side na ikutan ng pasyente. Yan po yung ideal. Okay. Ideally, ang electrical therapist must be on the left. Okay? So kung linawin yun, left side. Ang compression is right side. Ganyan po ang chatrix no. Ngayon, dahil trade naman tong dalawa, ang mag-chat ito, okay? One I'm clear? Do you clear? Itong si compression, tatakbo na doon. Okay, tatakbo na siya. Three, everybody's clear. Pag clear, pag pindot, bitawan na niya, takbo na siya sa kabila. Ang AED nagkukuman pa yun. Shock given, check responsiveness. Ang mag-check ng responsiveness, yung bagong electrical therapist na nanggaling sa compression check niya. Or check for pulse. Pero pag sinabing yung CPR, yung nag-chat siya na ngayon mag-CPR. Yung galing ng CPR, pahinga niya yun. Siya ngayon ang nakaabang lang doon para mag-manipulate ng defibrillator. Ganyan po yung chatrix. Okay? Para ang kalat ng COVID ay hindi dramatic. Si airway, maintain lang siya doon, hindi siya pwedeng ikot-ikot. Mamaya tuturuan ko kayo even sa ventilation saan nakalagay ang electric fan or yung positive pressure ventilation. No? Intake para sa room ninyo para hindi meron aircon tayo pero kailangan meron kayong outlet ng hangin kasi pag na-trap yung hangin doon, kakalat unless meron kayong internal na mga HEPA filters na malalaki pang room talaga or negative room style yung style nyo, yung inyong setup, walang problema. Pero typical hospital natin, lagi kang merong intake na hangin, tapos may outlet, may corridor kayo sa hangin para hindi natatrap yung microparticulates. What if the rhythm being read by the AED is non-shockable? Sa ganito pa rin ang command, CPR ka. CPR ako, no? CPR. Hoop, 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 hoop. Analyzing, bitaw ako. Analyze siya. Non-shockable. No shock advice. Continue CPR. Ayan. So, continue ka CPR. Until kung ano na mag-ACLS na tayo. So, yan lang po ang basic life support plan. Okay? So, hindi siya rocket science. Yan yung 2022 interim guideline for the basic life support of the American Heart Association. Ginawa natin simple. So, pag PIDYA naman, same style, walang pinagkaiba, except single rescuer na dagdagan ng witness sudden arrest ba or collapse. Pag na-witness mo, yes, ang gawin mo muna, activate emergency response, takbo ka muna. Kung hindi pa nagawa dito, kung hindi mo nagawa dito sa bungad, takbo ka muna, then balikan mo siya to start CPR. Okay? So, halos walang pinagkaiba. Tapos may pediatric mo. Ang pediatric mo lang yung AED pag nag-AED tayo. So, kailan masasabi natin bata? Pag more than 1 year old hanggang 8 years old. Sir, hindi ko natanong cardiac arrest eh. Paano ko matanong kung anong edad? Okay, ganito po. Yan ha, huwag tayong matalanta kaagad. Kung hindi natin alam ang edad at wala tayong witness na may kamag-anak or what, kung anong edad niya, kung ano na lang sa paningin niya. Kung sa paningin niyo 8 years old, kung tingin niyo 8 years old below, o the child mo. Pag 8 years old up, the adult BLS configuration. Nakita niyo, uy, child-looking guy. O di, mukhang 8 years old. O di yun ang BLS ninyo on the child algorithm. Yan. So, tanongin niyo na lang kung witness versus non-witness arrest. Okay? So, yan, no? Activate emergency response muna, tawagin muna, bago mag-start ng CPR. Pero again, bago mag-start ng CPR, kailangan may bag valve mask na ka-cover bago tayo mag-compress. Ngayon, dito naman sa 2 or more, same procedure, yung dalawang nagresponde, kailangan naka-BBM. Ang pagkakaiba lang dito ay sa PEDSA between single or 2 ay hindi naka-emphasize ang naloxone intoxication or abuse. Kasi wala naman siguro bata na nag-adik-adik ng ano. So hindi yun lang yung pagkakaiba. So dito sa 2 or more rescuer, makita natin, no breathing, no circulation, pareho lang sa adult ang style, except wala akong naloxone issue. Ngayon, sa kabol siya, same style. Okay? Ang juice niya, hanggang ma-perform ko yung pulse or pediatric advanced life support, naka-adjust lang to pediatric mode. So mga 2 joules per kilogram. Okay. Now, this is the old one, which sinama ko lang para ma-compare ninyo na mas grabe na emphasis ng 2022 interim guideline. Okay. Ito rin yung dati, karamihan, part sa luma, between adult and child. Ito yung before 2022. So this is the 2020. Ito yung before 2015. Before 20, that's 2018. Ito yung 2015 and below. Or 2010 and below. Halos walang pinagkaiba. Sa ano lang, sa bilis lang talaga ng compression. So this is what happens between adult, child, and infant. So halos na banggit ko kanina, ang pagkakaiba lang dito, pag child and infant, witness collapse siya. Yun lang yung ano natin, yun namang adjustments. Okay? Anyway, the file is there for you to review. Ito yung luma naman. Now, the role of its rescuer, ito yung sa luma. Kanina nabanggit ko na pag mag-actual ako, although nag-iisang tao na ako, mag-i-emphasize lang ako ng what to do. No? Then, ang na-add natin sa 2020, other than sa interim guideline, bago nagkaroon ng interim guideline, ay nag-add po ang 2020 ng ganito. So, para lang makita niyo lang saan hinugot si 2022 interim guideline. So, alam niyo kasi, nang na-release yung si 2020, BLS, no mention of COVID. Wala siya. Kasi, para ipaalala ko sa inyo, 2020 siya ni-release, 2020 siya, pero ginawa po yan, pinaka-max na bago na-compile yan ay 2018. The last, siguro, run noon is early 2019. Kaya wala pang COVID. Pag ni-release mo yan, 2020 guidelines, kaya magulat kayo walang COVID. Kaya siningit lang nila to. Hindi sa page, pwede parang, pag bumili ka ng libro nila, isiningit to. Yan. And this is how we do it, no? Yung compression mechanics, no? Sa COVID-19 na to. Ito yung mga infographics nila. Now, this is what happens kapag nag-compress ka at humihinto. Kaya inuso yung all hands CPR or tinawag na CCR, cardiocerebral resuscitation. So, pag maganda ang compression mo to 2 to 2.4 inches, umaabot po ako ng 140 to 160 millimeters of mercury. When I have that kind of pressure that's running around intravascularly, I will be oxygenating the brain, which is our main purpose. Kaya ang tawag sa kanya, cardio-cerebral resuscitation. Kasi actually, ang gusto mong ma-resuscitate ay yung brain, no? It's the brain. Because if you cannot resuscitate the brain, wala nang purpose resuscitate. Wala na yung resuscitate. Patay na yung brain. Because the brain is, yan ang ating cornerstone or the totem pole of survival. So isipin nyo, dati, hindi talaga ako advocate. Since 2010, marami pong naiinis sa akin kasi hindi ako advocate humihinto, nagbibigay ng hinga. Hindi ako ganun. Kasi sa kasagayton sa physiology, doctor kayo, familiar kayo, what I'm telling you, ganong ang gayton. Para ma-oxygenate talaga ang brain, kailangan may pumapasok na pressure, yung hemodynamic. Ngayon, huminto ako. Doon sa alveolar level, pag huminto, ako mag-compress, hindi tumatakbo ang dugo doon sa capillary. Dito ito, titinan yung capillary. I don't know kung meron akong drawing. Wala. Sige, walang drawing. Baka kasi, baka may iba dito hindi mag-ACLS. Pinapakita ko sa ACLS. Ito po ay capillary. Ito po ay alveolus. Yung alveolus ay napaligiran ng capillary. Pag buhay tayo, ang dugo tumatakbo around the alveolus, doon sa capillary bed. Ang oxygen galing sa environment na na-inhale ko, which is 21%. Anong ibig sabihin 21%? Anong law sa physics? We call it the total gas law. Sige nga, dapat matikas tayo. Kung gusto natin world class ang Pilipino, magaling dapat sa physics. Because physics is the science that will help you understand the world. Everything happening around people is physics. Pag magaling kayo sa physics, tumingin kayo sa mundo, maning-mani ang mundo sa iyo. Parang kukuha mo na kaagad eh. Hindi mahirap intindihin ang mundo because everything moves according to the law of physics. O yun. Walang mag-chat. It's the total gas law, meaning the partial pressure of oxygen plus the partial pressure of nitrogen plus the partial pressure of other gases, inert gases, is 100%, which is the gas within this at sea level na in relation to the 760 millimeters of mercury. Okay? So when you go up there, mag-a-adjust yung gas. When you go under the sea, mag-a-adjust, mako-compress yung gas. But it's still the same gas law until ma-disintegrate siya. So may total gas law, okay? Walang nakasagot. Ang tawag po doon Daltons. So ngayon, sa Daltons law, no, oxygen lang yung aalis sa capillary. Oxygen lang. Ang nitrogen, di po sasama yun. So, kailangan nag-move. Habang nag-move, si oxygen galing sa alveolus ay papasok sa capillary by virtue of passive diffusion. The movement of particles from an area of higher concentration to an area of lower concentration, passing to a permeable membrane of that solute, passing to a permeable membrane, hanggang ma-achieve nila ang equilibrium. No energy requirement. So, yun po yun. So, kusang papasok dito ang iyong oxygen. Dito naman sa capillary, kasi ginamit na yung blood, maraming carbon dioxide. Lalabas din siya, same principle, passive diffusion pa rin. Movement of particles from an area of higher concentration. So nagpapalitan lang po, ganito po, oxygen, carbon dioxide, nagpalitan sila. And everything happens without you thinking about. Pag may COVID ka, hindi po nagpapalitan kasi sa loob ng alveolus mo may fluid. Ang tawag po doon pulmonary edema. Pag umakyat ka sa high altitude, mabilisan, because of Boyle's law, hindi mo na-regulate, nagkakaroon ka ng high altitude pulmonary edema, hindi rin magpapalitan. Doon ang tao nahihirapan huminga at namamatay siya. Kaya tinatanggal natin yung edema para magkaroon ako ng surface area for the absorption for the diffusion of oxygen to the capillary and for the removal of carbon dioxide doon sa blood. So palitan. So isipin mo, ang requirement kailangan humihinga ka at ang dugo ay tumatakbo. O ganito ngayon sa ladies and gentlemen. Cardiac arrest ka, huminto. Walang palitan ng oxygen. CPR ka, takbo ulit. Bigla akong huminto para magbigay ng hangin. Tingnan niyo ako ha, tingnan niyo sa video. Huminto ako. Bigay akong hangin, kunwari mautumat. Nagpalitan ba? Wala. Kaya 2010, hindi na ako naniniwala ng rescue breathing per se. Hindi ako naniniwala magbigay ng breathing. Maniniwala ako kapag dalawa kayo at meron just to jumpstart the heart, jumpstart the lungs, to expand. Bigyan ng oxygen, yun, pwede akong huminto. 1, 2, 3, 30, boom, yun, pag dalawa. Pero pag solo ka lang, pinakamaganda po ay all compression. Para, tingnan nyo to dito agad sa slide. Tingnan nyo, para wala akong ganito. Wala akong spaces, wala akong gaps. Tuloy-tuloy oxygenation to the brain. If the brain is oxygenated, kahit walang oxygen support, 21%, it can already help my brain get oxygen. So, may mataas ang chances mabuhay ako. Kaya according to Arizona at saka Badger County, ang taas ng survival ng all compression kumpara sa naghihinto-hinto ka at nagbigay ng mouth-to-mouth. Okay. Now, let's go into choking. So, ang choking po, i-demo ko, pag-isahin ko lahat ng demo mo. Dalawa lang po yan. May tinatawag na mild obstruction, at saka severe obstruction. Dati tinatawag na mild obstruction with poor air entry and good air entry. Merong tinatawag na total obstruction. Pero ngayon, mild obstruction na lang, dinalawa na lang nila. So sa severe obstruction, pwedeng halos wala ka na makuha na sound. Tapos sobrang nipis na kasi sobrang liit na yung gaganoon siya parang whiz na kakaiba. Hirap siya mag-cough kasi hindi siya maka-inhale. Inhale bago mag-cough, kailangan maipunan mo ng hangin and then you burst it out. Ganon. Hirap siya gawin here. So mild obstruction, you can still encourage coughing. So I'll teach you how to do that. I-demo ko na lang mamaya. Tapos, ikaklaro ko sa inyo, sino ba sinusunod ninyo? Yung Red Cross or yung American Heart Association? Kasi meron po tinatawag na backslapping. No? Backslapping. So, hindi po tinuturo yan ng AHA. Sino ba susundin natin? Si ARC or si AHA? Umulit. Okay. So, i-demo ko na lang yung mamaya. Then we go into naloxone. Naloxone is a drug. Actually, categorized under ALS drug in case you want to reverse opioid. No? Katulad ko, meron akong morphine, baka ma-overdrive ako ng morphine, magkakaroon ako ng respiratory depression sa pasyente. May pang-kontra akong Narcan. Kailan ko binibigay ang morphine? All those in the days of old, ginagamit sa pain, pero ngayon may ibang mga pain management. Ginagamit namin siya for acute coronary syndrome na nakita namin sa isip. So, MONA po, ang first treatment namin, morphine, oxygen, nitroglycerin, aspirin. Assuming na abuse ko, so meron akong Narcan. Pero magugulat kayo ngayon, binibigay na siya na sa isang basic life support provider. So, ito ay hindi IV, binibigay ito as atomizer. Although dito sa slide, wala kayong marinig na atomizer, but we call it atomizer kasi pag binuga mo siya, it creates a mist. So, dalawa po ang ating brand name. Merong Narcan at saka Cloxado. To be honest with you, ang nagamit ko pa lang po ay Narcan, hindi pa ako nakasubok ng Cloxado. I have to be honest. Mataas ang dosage prep ng Cloxado kasi nakaka-8 sila. Si Narcan, nag-start siya ng 2 to 4. Okay? So, indicated siya for the treatment of opioid overdose, no? Magkakaroon ng central and respiratory depression. Tapos, sa US, pag ginagamitan natin, not necessarily arresting, pero nahilong-talilong, hirap makahinga kasi respiratory depression, hindi ba totally nag-arrest ng tao? Nire-respondihan ng EMS. Pero sa mga ganong kaso po, kailangan may pulis. Kasi pag nagbigay ka po ng Narcan, tinanggal mo yung epekto ng opioid sa katawan, sapakin ka pa or baka barilin ka ng addict. Bakit? Hirap po silang kumuha ng opioid para maging addict. Binasag mo yung trip nila. Bigyan mo ng Narcan, ni-reverse mo. No? So that, they will not be very happy with that. Okay? So paano natin ginagawa? One spray delivered, depende sa left or right nostril. So kung Narcan, 4 mg of Nalox, yan po ang forma natin. Tingnan nyo. Kaya tinawag namin atomizer kasi sobrang liit. The mist is the mist becomes atomized. Yan. So yan, pindutin mo yan. So may driver cells. So sa ilong lang po. Para mapunta sa turbinates at ma-absorb. So ganito ang forma ha. Tingnan nyo. I hope you can understand. Mata, ito yung ilong, ito yung nostril, pasok doon, ganyan kalalim, spray mo sa loob. So, assuming the patient is arresting, mas pag nabigay mo yan, mas tataas ang margin of survival niya kasi ma-reverse yung respiratory depression. Kesa walang ganyan, hirap mong i-reverse, hindi mo talaga mabuhay ang pasyente. Now, 2 to 3 minutes, kung gusto mong mag-additional, nasa iyo, pero you can call medical control. Tawag ka sa doktor, sir, can I drive to? Naka-drive na ako 3 minutes ago. Sinabi, ano pa ba, sir, patient, not responding to it. We're still doing, we're performing CPR right now. En route to the hospital, we are 10 minutes out of the hospital on your location. Nakapag-defibrillate na kami ng twice sa CPR, no changes pa rin. Find BF on screen. So, driving again, sir. Okay, go. Drive for it and Narcan. Ganyan, no? Over the radio. Okay. So, there is a dosage modification. No? Nung reversal of respiratory depression by partial agonist or mixed agonist or antagonist. Halimbawa, ito minsan ginagamit na to. Kinukuha mo na to pag ACLS-10 na ano. Yung buprenorphine, ewan ko kung meron dito, or pentazocine, may be incomplete and require higher doses of Nalox or repeated administration. So ito malalakas. Ibig sabihin, yung binding sites nila sa receptor, matindi. No? Kaya kailangan mong sige bigyan para hinahinay ma-reverse mo yung epekto ng respiratory depression. So, depende yan sa medical control, again, for additional, or sa tinatawag na PPG ninyo, yung policies and procedure guidelines in intervening to a case. Meron din akong ginawa, okay? I'm gonna give you a break bago tayo mag-practical. Meron din akong ginawa kasi pag nag-aral kayo sa Philippine Heart Association, tuturuan kayo ng 5C. Okay, 5C, yung check for responsiveness, call for help, check for responsiveness, call for help, cover the patient's mouth and nose, compress, connect to AED. 5. So, nang ginawa nila yung 5 po, kasabay sa ginawa ko, 10C din po ako. Ako, 10 yung C. Hindi ko sinabing ano sila, mas matindi ako. Hindi po. In-emphasize ko lang talaga ang out of hospital requirement. Okay? Para ayoko may mamiss ako. So, bitiwan mo kung 10C of CPR. Again, this is for out of hospital. Okay? Number 1C, people, consider everyone to be COVID positive. Ganun lang. Pag nakita kang bumulagta na tao dyan sa daan, aha, baka COVID to. So, huwag kang kumumpiyansa. Number 2, check in. Huwag kang basta tumulong sa tao kasi una, buti tayo kung nurses or doctors tayo na may PRCID, medyo may tapang. Pero tandaan ninyo, pag ituturo natin to sa lay people, we have to remember that there is no good Samaritan law in this country. When you hold the patient in the streets or wherever outside of hospital, you will be on your own people. At malakas na kaso yan pag nagkamali ka. No good Samaritan law. So, kailangan magpa-abiso ka. Ang tawag doon, check-in. Ang word na check-in ay ginagamit namin sa ICS or Incident Command System. Kunwari, external help ako, mag-abiso ko, oy, ako si Dr. Esguera, meron akong ganitong skill, gusto ko tumulong. I have to check in para ma-utilize ako doon sa disaster zone. So, ginamit ko lang siya to satisfy my seat. You check in sa community. Sir, sa rescue pa ko or nurse o doctor pa ko, baka po makatulong. Ha? The word is maybe I can help. Baka po makatulong. Yan. Check in. And at the same time, yan o, check in. Signify ko sa mga tao. Then, crowd control. So, itong crowd control, pwedeng pangatlo o pwedeng latter part, depende kung may crowd. So, wag po tayong pumayag na dikit-dikit yung crowd na osyosero. Ang mga Pilipino osyosero yan. So, didikit-dikit yan. No? So, mag-crowd control po. Pwede niyo pong utusan na, sir, pwede pa ayos sa traffic. Yan. Para wala tayong, para meron kang pinakamagandang sir, bigyan niyo po akong hangin. Mas naiintindihan nila para lumayo. Bigyan hangin. Kasi baka mag-super spreader ako. Like here in, anong AU po? Australia? What? Like here in AU. What's AU? Di basta mag-offer lang tumulong. May I know what's AU? Australia. So you're in Australia. Wow. So sorry guys, I'm really sorry. Are there people here who cannot understand full Tagalog? So I have to say English kasi meron tayong, baka may foreigner. Because I have 2 dozens of English. Okay. Yeah, well, of course, but it's not as strict as Middle East country. Yeah. Lalo na Saudi Arabia. Talagang, you'll be in big trouble. With your kind heart and you offer help, then you'll be in big trouble. Dito sa Pilipinas, okay lang din. Pero wala pa tayong good Samaritan. Sabi ko sa iyo, mahina eh. Pinatawag po ako ng Malacanang more than a month ago. And I discussed to them big issues. Why we are so, backwardish. Because of some regulations we cannot approve somewhere in the Senate, in the Congress, or what. But anyhow, balik ako dito. Crowd control, baka naman dyan sa crowd mga osyosero, may COVID, o isipin mo, tumulong na ako sa kapwa, nagka-COVID pa ako because of super spreading incident. So number 3, crowd control. Number 4, check hazard. So, bakit bumulagta yung tao dyan? Nasa gasaan, nasa gitna ng highway. Eh, di wag ka dyan mag-assess sa highway, mag-CPR sa highway, baka masagasaan ka rin. Or nakuryente, baka makuryente ka. Or nag-cyanide poisoning yan, baka ma-poison. Okay, so check hazard. Kung nasa outdoors ka, maganda sana kung in relation sa pasyente, kung meron kang nakitang nakuha mo saan galing ang hangin, maganda tatama ang hangin sa likod mo. Para kung in case mag-CPR ka, yung hangin ay palayo sa iyo. Ang tawag ko dyan, upwind, downwind principle. Then, check for responsiveness. Okay, tingnan nyo ako ha. Tingin kayo sa video. Pag nag-check po tayo ng responsiveness, ang tinuro ko sa atin ng AHA ay ganito. Dalawa. Ngayon po, sa patakaran ngayon, huwag na po dalawa. Kung nasa left side ako, left side ko parang mas malayo. Mamaya ipag-demo ko yan. Pangalawa, pag nag-check po responsiveness, huwag lang po kayo mag-tap. Bigyan nyo po ng trapezius pins. Talod nyo, no? Medyo obvious lang to. Huwag naman ganunin. Ganun lang. Bakit? Kasi pag sampalin niya or mag-sternal rub kayo, ang sternal rub hindi allowed sa 2015 American Heart Association. Sampalin niyo kung whatever you would like to do to execute just to establish, elicit response of the patient. Nako, makuhanan kayo ng video, mati-technical kayo dyan. So, trapezius pins, masakit pa yan. Pag gawin nyo sa sarili nyo, hindi kayo masaktan. Pero let somebody do that to you, masakit po yung trapezius pin. Pero hindi halata po siya nakurot. So, na-check po responsiveness, assuming the patient is unresponsive, then call for help. Whether it's 911, 119, I don't know, 999, or parang ako, hindi pa ako nag-911 kasi mabagal po siya pag hindi sa Manila tumawag. Takes time. Sinubukan ko na po yan. So, diretso ako tatawag sa tropa ko ng 16016. Mga direct na fire truck assistance, EMS assistance ng mga volunteers. Yan. Then, kung nasa out of hospital, kasi wala ka namang oxygen non-orbital mask, you cover it, the nose and the mouth, cover, bago ka mag-CPR. Pero pag walang cervical spine involvement, ilayo mo yung head, i-tilt mo. Ang totoong tao na arresting, isang tao na unconscious, hindi po yan matuwid pag nasa lupa, nasa pavement. It's either gaganon siya or nakaganon. Yan po yung tinatawag na dead weight. Hindi po, pag nakaganon yan, huwag niyong galawin, gising yan. Hindi pwedeng ganun ang tao. Pag isang tao walang malay ganun yan. O ganun. Okay? So, kung nandito ka banda, di ganun mo. Palayo. Para yung buga ng hangin, palayo sa'yo. Okay. So, yan tilting the head or moving the head. Not the word tilt is wrong. So, moving the head away from you. Then, compress chest, no? Tamang sakto, the sternum area, of 120 per minute or 240 for 2 minutes. Tapos hinto 2 minutes, check for responsiveness or pulse, tuloy ulit. All compression, no rescue breath. Then, kung may AED, connect to AED and listen to voice prompt. Ngayon, pang 10, ginamit ko yung word na case evacuation. Case evacuation ay military term for medevac not using any ambulance unit. Pag gumamit ako ng isang ambulance unit na military, ang tawag tactical evacuation. Ginamit ko yung word na case evacuation to satisfy my C. Pangalawa, uso sa COVID, wala pong ambulansya. Nangyari po yan sa akin. If you look at this picture, ako po ito. Alas 3 po, na-disgrasya po sa motor yan. I-stabilize namin. May pulis akong kasama. May mga responder akong kasama. Grabe na Grabe na ang cadence to call for an ambulance. No ambulance came in. Bakit? Nung kasagsagan nun, this is 2020, I think, 2020. Kasagsagan ng COVID. Or 2021, kalimutan pa. Basta kasagsagan ng COVID. Karamihang ambulansya ay nakadedicate sa COVID. So, walang kakarga. Kaya, nagkomandir kami ng sasakyan, niload namin para dalhin sa ospital. Ang tawag po dyan, case evacuation, case evac. Para sa kaso na i-load mo sa hindi talaga ambulance. So, 10 siya. 10. Consider everyone to be COVID positive. Number 2, diba? 2 is check it, signify kung sino ka. 3, crowd control kung maraming osyosero. 4, check for responsiveness. Assuming patient is unconscious, call for help. 6, cover the mouth and nose. 7, compression. Kulang ako isa. Saglit, kulang ako. COVID, consider ba na COVID positive? Check in. When you check in, crowd control muna. Check for hazards. And situational awareness. Check patient's responsiveness. Call for help. Cover face, mouth. Cover mouth, nose. Compress, connect to AED, case evacuation. Ayan. 10C po. So, the interim guideline is what we are trying to do right now in 2022. So, ito ay 2020. Ngayon, isa sa sinasama nito sa BLS as a way forward, gusto nilang i-include na ang stroke. Sa stroke naman, ang ituturo ko lang is Cincinnati Pre-Hospital Stroke Scale, which is the FAST. Pero ito adjusted, kaya tawag B-FAST. Ano yung B? Suddenly there is loss of balance. Ano pa ang B? Suddenly there is brain fogging. Hindi siya nakalimutan, di alam, biglaan. Suddenly, B pa rin, there is behavioral change. Parang, kinakosa mo, parang wala sa ayos, nakasimangot lang, yung pala, may tama na. Doon, may bumara o sumama. Then E, blurring of vision, eyes. F, facial asymmetry. Ito guys, and or, hindi pwede mag-exist lahat. So, and or. And or, A, arm and leg weakness on one side. And or, slurring of speech. Pag makakita kayong ganyan, out of hospital kayo, please, bring it to the hospital. Yun yung last, yung time. Mabilisan. Pero pag nakita kayo sa loob ng hospital mismo nangyari, activate your stroke team. Sir, pre-hospital case pero nakitaan mo, ikaw out of nowhere, freak reason, na stroke siya mismo sa hospital, report it to your stroke team. Not a code blue team, but your own stroke team. Okay? So ganyan lang ang ating assembly for stroke. So this is a patient we transferred status epilepticus from Dumaguete papuntang Manila. Now, what is, ito kasi pang ACLS, what is the ideal setup? So, dati, 1, 2, 3, 4, 5, ngayon po, for BLS is 3. BLS lang, airway, compression, saka defibrillator, ha? 3 lang. Sinong team leader? The one. Anyone, basta amongst the defibrillator compressor guy. Until the team arrives. Pag sinabing ideal, no, yan yung minimum 3 playing coach. Ang playing coach or Jaworski style is 3. Ang team leader is either the defibrillator guy or the compressor. Pero ideally, ang leader mo nasa paa habang nag-escalate pa. Pero since minimal lang ang tao for BLS, okay na yung 3. Pag may 4 ka, yung team leader, lagay mo sa paa. Walang IV kasi basic pa lang tayo. Okay, so, when to stop CPR? Kapag merong spontaneous circulation yan. No? So, tandaan nyo lang yung mnemonics na stops. There is spontaneous return of breathing and circulation. Then, ano pa? Kapag merong transfer to higher level of care, kunwari nagkataon, no? EMT ka, emergency medical technician, basic, dumating si paramedic, ay, endorse mo. Hindi pwedeng ikaw. Nurse ka, dumating si doctor, endorse mo. Doctor ER ka, dumating si cardiovascular surgeon, hindi endorse mo. So, meron tayong tiers of intervention. Tapos, operator is exhausted. No? Nakakahiya po ito, pero pwedeng mangyari. Lumaylay ka kasi mahina ka, siguro hindi ka nag-exercise, may bisyo ka, nag-CPR ka, straight, ikaw yung hinimatay, nako, you will be the talk of the town for the next 6 months. Hinimatay ng CPR, kahiya yan. So please, wellness amongst doctors and nurses. Okay, then P, physician's advice, of course, captain of the ship in legal med, kung anong utos ng doktor, sundin natin. And the last, scene becomes unsafe. Anong pangyayari ito? Halimbawa, biglang may nagbarilan sa loob ng ospital, nag-mass shooting or nasusunog, stop CPR. Drug the patient. Kung hindi mo makaya i-drug ng patient, run away. Wala tayong magawa. No? So, ganyan po, when to stop CPR. Now, What if there are issues like you break a rib? So meron tayong Article 12, Paragraph 4 sa Revised Penal Code. Any person while performing lawful act with due care causes an injury by mere accident without fault or intention of causing it. Makakalusot ka po. Basta sakto lang. Sakto. Pero pinamaganda rito, ikaw ay nurse or doctor, merong dating. Kung ikaw ay layperson, kailangan na merong kang certificate na nakapag-train. Kasi para saklaw ka dito, kailangan kasi dito sa tao ay train ka para ma-emphasize yung lawful act with due care. Yan. Remember, 85 to 90% of arresting patients will show ventricular fibrillation. Pinakita ko yung written kanina. So this guy had arrest. The funny thing is, nasa middle siya ng mga tao, na maraming tao supposed to be rescuer, kinunan lang siya ng video. So nagtuturo po ako, pinatawag ako, nag-CPR ako, nag-defibrillate ng buhay namin, I defibrillated twice, nabuhay po namin. Kinasuhan po niya ako kasi nangitim yung dibdib. Pero hindi na puso yung kaso. But this is a one good story. Paano ka makabuhay ng tao na meron kang defibrillator. So dito nagko-command ako on defibrillating the patient. Ayan. Kaya nakataas ang kamay niya. So that's all for your didactics of basic life support. Any question, people? May tanong ba? Si Ma'am Giselle may tanong? Si Dane, may tanong ba si Dane? Catherine, Nico, Chris, don't be ashamed. When I facilitate, uh, uh, of course, no, ganito, pag na-invite ako, I allow people to commit mistake kasi dito lang naman tayo natututo na mag-commit tayo ng mistake and we learn from it. Kesa sa hindi mo alam, tapos hindi na correct. So, mas naniniwala ko sa tao na nagkakamali at kinorek niya. Siya yung dalhin ko sa giyera. Because this guy, he will know how to fight or no, it's gonna go with me in the front line because he or she will know what to do. Kasi natuto siya sa pagkakamali. Question? Yes, April. Wala. It's either you fully understood or you fully understand it or you never understood it. All or none law.
Doc, excuse po.
Yep.
Doc, pag kunwari na-establish po na opioid overdose, pwede po ba mag-proceed na agad sa pagbigay ng naloxone? And then
Yeah. Maganda, start compressing kung cardiac arrest or start bagging kung respiratory depression. Start ka na while you are preparing kasi depende on hand anong meron ka. No? Kasi pwedeng na-establish mo, assuming, well, you can drive. Pero you don't compromise the vitals na halimbawa, cardiac arrest, na-delay ka. When you can start already. So habang kasi I presume you are all in PPE naman. Now, if you are so cautious enough, you don't want aerosolize because there's a stranger in front of you kung ambulance operations ka, press cut. So, hinto mo na, drive ka muna. Isang buga na yan, meron kang 4 mgs or kung Croxado, 8 mgs. Sige. Oxygen, start compression. So, depende case-to-case basis yan. Okay? So, depende sa availability ng drug mo. Kasi ako, ang drugs ko, nasa hard case eh. So, puk. Tapos kunin ko, ang regulated drugs ko, may another case, no? Halo. Buti sana kung memorize mo ba sa daming drugs, hanapin mo pa. Although yung atomizer, sorry with the word, I call it atomizer, kuhang-kuha mo naman. Pwede, depende. Kung dalawa kayo, start compression kasi nakatanga sa'yo. Compress ka muna. Stop. Pag sinabi stop, tanggal na mas, lagay mo sa ilong. Okay, compress. Yan. While I'm preparing my ambu bag. Stop. Shift to ambu bag. 15 liters per minute. Compress. Compress ulit. 30 is 2 na. Pero pag nag-solo flight ka, case-to-case basis yon. Halimbawa, drive ka muna, start ka compression. Kung nag-solo ka lang, lagyan mo lang ng non-rebreather mask para hindi nagliparan. So, better na nabigay mo para meron kang mode na meron kang ano na nagre-reverse. Kasi kahit anong good CPR mo, pag hindi siya na-reverse, hindi mo mabubuhay yan. Yeah.
Thank you po.
Sure. Tanong ko si Ansari, is this your family name or first name?
Family name po, Doc.
Ma'am, meron na kayong ganun, atomizer dyan sa Australia? Where are you in Australia, by the way? I hope you won't mind.
Sa Brisbane po, Doc.
Oh, nag-aral po ako dyan, 2008 sa Laverton, malapit sa Melbourne. Military familiarization. Tapos, pasyalan ko Melbourne every weekend. Tapos, after that, nag-aral ako sa katabi ng Sydney sa Mosman, sa Royal Australian Navy. Royal Australian Navy, nag-aral ako doon ng submarine medicine.
Bago pa din po kasi ako dito, Doc eh.
That's good.
Wala pang 1 month.
I hope you won't mind. What's your first name?
And Noralia po, Doc.
Okay. How old are you?
26.
Kung okay sa'yo, apply ka ng military. Mabilis ang citizenship mo, mabilis mo makuha ang mga pamilya mo. Apply ka. Well, don't be afraid. Wala namang gera yung Australia. Wala pang gera ngayon. Kasi pag mabilis ka, pag nag-apply ka sa military, naging military ka, pag pwede ka mag-military nurse later on, makuha mo yung licensing. Mabilis ang citizenship, makukuha mo pa family mo mabilis. I don't know what's your height. Depende sa height mo rin. Tingnan mo baka
5 lang ako, Doc.
subukan mo lang. Try mo. Baka pwede sa Navy, pwede dito. Tingnan mo. Pag sa Navy ka, pwede ka mag-Navy Corpsman initially. Medic sa Navy, no? Kung sa Army, medic kasi.
Yes.
There's no harm in trying. You just inquire.
Opo.
Thank
you, Doc.
You have like husband?
Single, Doc. Nurse sa Pinas. Estudyante dito.
Are you student there? Akala ko you're working.
Ika-convert ko pa po yung ano ko, Doc. At nagpa-file pa ako ng NCLEX ko for
That's good.
para dito. Yeah.
Pumunta ka sa mall, sa Brisbane, maghanap ka ng mga recruitment ng military. Para hindi pansinin yung height mo, RAN ka, Royal Australian Navy.
Sige, Doc. Thank you sa info, Doc.
Nakapasok ka, mabilis ang citizenship. Then you can get your family. Australia is a nice place. Kumpara ko sa US, maligalig na ang US. Okay, pero Brisbane is a very wonderful city. Of course, bias talaga ako sa Melbourne. Melbourne is one of the most wonderful cities in the whole world. Brisbane is okay. Ang Sydney, medyo maligalig na ang Sydney family. Tapos sa Perth, medyo konting mainit. Lalo na sa Alice Springs, lalong mainit. Brisbane, tama lang. Pero sa Melbourne, ma-enjoy mo yung weather. We call it the 4 seasons in one day. You have the 4 seasons in one day.
Oo nga, Doc. Grabe yung season dito. Grabe yung weather. Biglang magbabago.
Taga saan ka sa atin?
Before, tumira ako sa QC.
But what province do you come from?
Quezon City po. Province, Mindanao.
You're from Mindanao?
Yes.
Where in Mindanao?
Dipolog.
Bisaya o Ilonggo?
Bisaya.
Sige, that's good. Good luck out there. Enjoy your
Thank
stay.
you, Doc. Thank you, Doc.
New Zealand is so wonderful. Nag-aral din ako mountaineering. New Zealand. Very lovely place.
Thank you, Doc.
Yes. Okay, kung walang tanong, I'll just prepare my kits. You can have your break, bathroom break, and what, and siguro around 12 to 15 minutes because I'm gonna prepare things para i-demo ko. Okay? So kung hindi kayo di kayo nakaisip anong itatanong, if you have no question as of this moment, then perhaps while eating your banana Q or your ginataan or your Filipino, no? Whatever. If something pops out in your mind, just can ask me. I'll try my best to answer them. Okay? So, no? Okay. Sige, break muna while I prepare my demo materials.
Hello po, good morning po. For your attendance po, kindly send your name po na mag-a-appear po sa certificates and IDs niyo po. Also, pakilagay din po yung training po na in-enroll niyo po. Magsisend po ako ng example sa meeting chat po. Thank you po.
Right now, I'll just open one. I'll open another video for an angle. So we'll do the practical part of it. So one, I'll start with airway obstruction. So usually ang pasyente, ang airway obstruction, the book tells us there's a universal sign like this. Sa lahat ng experience ko, minsan lumahawak, pero the worst one is hahawak sa'yo. Hawak siya. Ang tawag ko doon, sense of doom. Sense of doom. No? Pakiramdam niya, mamamatay na siya. So there are two things there. One, if the patient is still standing, be on the side of the patient, assuming to stand. Be on the side to facilitate coughing. Facilitate coughing. Sir, ma'am, facilitate coughing. Sir, sige, upo po. Slow, hinay. Sige lang, hinay. Inhale and then cough. Yeah, cough. Okay? If suddenly the patient will have difficulty, itong lips niya nag-fail, naging bluish. Hirap na, tapos tridor, no? Gumagano na. Then you have to prepare for an abdominal thrust. So, nakatayo ang pasyente, ang gawin mo lang ay pupunta ka sa likod at ang position mo, ready ka lang na, sir, saglit, ano lang ha, sige, subukan mo tubo. Pag wala, hawakan mo, ang paa mo ay nasa gitna. Ito ay nakatayo pa. Prepare mo, baka bumagsak na to. So kung nakatayo siya, ang paa mo dapat nandito sa gitna. Ito, tingnan mo. Ang point doon nasa gitna, in case mawalan siya ng malay, slide lang siya, slide mo lang. Slide. No? Paatras ka para hindi kayo dalawang bumagsak. Kasi pag ang paa ko ay nasa side, tapos pabigat, sa sayaw yan, babagsak kayo dalawa, hindi nakakahiya. No? So, the style there is always put your feet in between the put your foot in between the feet of the patient. So habang upo siya, nakatayo, kung kaya naman, nakaganon siya, gawa ka ng snap knuckling. You have to create something like this. Dito sa seapoid process, one finger breadth below, gawa kang ganito, and then you have to create an abdominal thrust. No? It's called Heimlich, but books right now are not using the word Heimlich. They're using abdominal thrust. Papunta sa scapula niya. Therefore, ganun. Paakyat, papunta sa scapula. 1, 2, 3, 4, 5. Sir, slowly inhale. Kaya, another thrust. 1, 2, hanggang ma-expel niya. Pag na-expel yan, no, patient is not yet okay, please advise the patient to go to the hospital. kasi baka na injure yung upper larynx or larynx area kung medyo kakaiba yung obstruction. Pwede mag-laryngospasm. Pag-uwi sa bahay, mag-respiratory arrest yan. So encourage natin lahat nang natanggalan natin ng obstruction to go to the hospital. Case-to-case basis, kung mababaw lang naman, hindi naman talaga na anong pasyente, nakaluwa ka agad. Well, depende. Kung medyo confident ka na he's okay. But if you doubt, better send it to the hospital. Baka may ibang complication na. Now, what if the patient, sabang ginagawa mo, wala, tapos nawala na malay, nahiga mo. Then, all you have to do is check for responsiveness na. Doon na tayo sa BLS program. So, sir, yan, no? Ngayon, pag nag-check ka na sa BLS, okay, if, gusto ko makita niyo, pag nag-check kayo sa responsiveness, pag tapik, kita niyo sa side ko, nasa right side ako ng pasyente, right ang gagamitin ko. Pag ang pasyente mo ay pre-hospital care, galing sa labas, wag ka magdalawa kasi pag nagdalawa, malapit ako sa distance ng kanyang mouth and nose. So, right to right or left to left. So, yan. Sir, pag wala, trapezius pins. Patient is unconscious, call for help. Sir, pasuyo naman ako. Pero dahil healthcare provider ka, hawak ka sa pulso, carotid pulse, sigaw ka, sir, pasuyo naman ikaw, patawag ng ambulansya or tanod, balikan niyo po ako. Ganun. Pero pag sa ospital, unconscious, guys, activate code blue, bed number 1. Activate code blue, bed number 1. So makikita mo, tapos ngayon, pindot, bagsak ang lagay ng cardiac board, hindi na lagay ng cardiac board. Okay? Kung dalawa kayo, habang inaayos, kinukuha pa, check for pulse, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000. No pulse. Bago ka mag-start ng compression, 15 liters per minute ka muna, non-rebreather mask. Okay? Makikita mo yung non-rebreather mask. May dalawa siyang one-way valve para pag nag-inhale siya, ang makukuha niyang hangin galing sa reservoir. At pag nag-exhale siya, lalabas doon sa one-way valve, left and right. So ilagay mo muna to, no? Lagay mo dyan, bilisan, and then 15 liters per minute, and then start compression. Okay? So, ang compression speed, 1, 2, 3, 4. Ganyan ang speed, ha? Para abot ako ng 120. I don't care if you are interlacing. I don't care if you do like top-bottom position. I don't care if there is like a wrist hold like this. As long as you compress it at 2 inches and the speed is 120, it's just fine. So sa hospital, depende case-to-case basis kung mataas, matagad ang maglagay ka ng footstool. Kasi importante, ang katawan ang sumasayaw. Pag sinabi kong katawan sumasayaw, dito, tingnan niyo dito sa kanilang slides. Katawan sumasayaw. No? Shoulder, ganun talaga. Okay? Ganyan. So, hindi pwedeng jerking. Hindi pwedeng nakaganong ka, wala kang leverage na maganda ang compression. Yes. So, kailangan dito. Now, what if maglagay tayo ng defibrillator? May interruption ba? So, there's a sample of defibrillator. Yun. So, this is a training defib out AED. So, dalawang klaseng defib. Ang isang, pag ganyan mo, sisigaw siya na unit okay, or meron siyang on and off. So, yung on and off button, siya magsasabi, unit okay. Tapos, new brands of AED ay meron ng pediatric mode. Sisigaw siya, pediatric mode. Yan. So, ilagay mo yung sa katawan ng tao. Kaya hindi ko na lang kulitin, sayang to. So, makikita naman kasi meron siyang picture. Katulad dito, Zol AED patch, no? So, meron siyang picture. So, habang nagko-compress, may nagko-compress dito, huwag mo siyang pahintuin, hayaan mo lang. Tuloy-tuloy ka lang maglagay ng patch. Unless kung Zol, meron siyang sensor. Yung tinatawag na compression sensor. Lagay mo lang yung compression sensor, angat lang yung kamay niya. Yan. So, mangyayari, ang posisyon, meron siyang apex, sternum. So familiar. So, itong Zol, ay meron siyang sensor. So, itong sensor, pag dinidiin mo yan, dinidiin mo yung sensor, nalalaman ng sensor pag nadidiinan mo siya ng maigit, hindi. Pag hindi, mababaw yun. Sisisigaw ang sensor na push harder. Tapos mabagal ka, push faster. So, yun yung maganda. No? Ang Zol ang may ganon. Yung iba, wala. Or you are on your own and doing it. Ngayon, stubborn ka talaga, mabagal ka, push faster, hindi ka sumusunod, dadagdagan na niya ngayon. Push faster, stupid. Ganon niya. Pero lang. Wala. So, tuloy ka until habang nagko-compress ka, may marinig kang pip, 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 pip. Ganon. Sasabayan mo yan. Pag sinabing analyzing, bitaw. Shock advice, stand clear. Itong ibang EED, pumupula yan. Yung merong shock na kidlat, it's either kidlat or heart, karamihan dyan kulay red. So, bago ka mag-shock, huwag ka mag-shock, di ka nag-chant pag may kasama ka. Chant ka ngayon. One and clear. Tingnan mo na hindi ka nakatouch sa patient. Tingin sa airway, to your clear. So, patay ka agad si oxygen. 3, everybody's clear. Sisigaw yung mga nasa baligid. Clear. So, pindot kang shock. Boom! Gagana na pasyente. Shock given. Check for pulse. Pwede ganon. Or, continue CPR. So, gagawin mo lang siya. Diretso. Okay? So, hindi siya rocket science. Meron siyang voice prop, meron siyang picture. And it's not too hard because this one, it's not really hard because this is designed for lay people. Now, I'll go into airway. This is where doctors and nurses commit error. Okay, airway tayo. Paano nagkakamali ang nurses and doctors? So, mayroon akong bag valve mask. Ano si bag valve mask? Inilabas, ayun. So, si bag mask, so, huwag kayong gumamit ng bag valve mask na walang reservoir. Useless. Hindi kayo makaka-deliver ng 90% FiO2. So, dito sa gitna, merong nilalagay na HEPA filter. Bago ito. So, wala akong HEPA filter. Nakalimutan ko bumili. So, bago yan. Ngayon, pag nag-bag valve mask kayo, kailangan ito nakakabit sa 15 liters per minute. Okay? So, ang hawak natin ganito. Tatanggalin tayo ito. Ilipat ko lang ito para makita niyo. Ito sa laptop ko. Hawak. So, dito ako sa ulunan ng pasyente. Okay, dito sa isa. Kita niyo na. Hawak. Ang pagkakamali ng iba ay tinatong lang. Tapos bag. Ganyan lang. 1,000, 2,000, 3,000, 4,000, 5,000, or 6,000. Mali po yun. Kailangan pag nag-bag valve mask tayo, gawa ka ng 3, C and E. C and E. Dito, ang E, sa bony part of your mandible, huwag sa gitna, hindi makakahinga yan dito. At ang C will do the seal. So ito, C and E and hyperextend. Unless the patient has cervical, then mag-jaw thrust maneuver ako. Although hindi payag ang AHA sa Silix maneuver, pero sa wilderness medicine, nagsi-Silix maneuver pa rin kami. Okay? So, let me sit down kasi wala akong ano. Yung aking hospital bed nasa kabilang bahay. So, ganun lang ako. So, pag nag-CANI ka, hyperextend, magsasara ang aking esophagus. Sasara ang aking esophagus by virtue na pag I do hyperextension, the cartilaginous part, no, which is the cricoid cartilage and the thyroid cartilage, I will move posteriorly. If it moves posteriorly, ipitin niya ang esophagus against the anterior part of the cervical spine. So, ang cervical spine ay matigas. So, pag ito ngayon si cricoid and thyroid cartilage, inipit sa pag nag-hyperextend, inipit ngayon si esophagus, may ipit si esophagus, ito si cervical spine. Malalak si esophagus. Kung naka-hyperextend, pag hindi naka-hyperextend, nakaganyan, ang hangin, pag nag-deliver ako, pupunta sa tiyan at pupunta sa lungs. So, hindi maganda. You don't want the air to be delivered to the stomach kasi magkakaroon ka insufflation. Or pwedeng bumalik yon, susuka, mag-aspirate ang tao. So, I want you to listen to me right now. Those who are listening to me right now, tumingala kayo. Tingala kayo ngayon. Okay? Tingala lahat. Tingala. Pag tingala nyo, hinga lang kayo. Inhale, exhale. Tingala ha. Hyperextend talaga ha. Inhale, exhale. Ngayon, lumunok kayo. So ngayon, nakita niyo pag lumunok kayo, hindi kayo makalunok. Yan ang testimony na sarado ang inyong esophagus. So lahat kayo pag nag-ambubaging kayo or nagbaging kayo, kailangan ng hyperextend. Meron tayong mga cardiac board, katulad sa cardiac board ko, nakalimutan ko lang ibaba kasi nasa kabilang bahay, palipat-lipat. Na pag nilagay mo, naka-hyperextend ka agad ang ulo. Pag wala kayong ganong cardiac board, mano-mano, kayo talaga mag head tilt, chin lift or neck lift. Neck lift, head tilt, neck lift. Tapos, lagay ito, kabit, merong tumatakbong hangin at 15 liters per minute. Okay, nag-CPR, lagay lang. Bago mag-CPR, pag meron tayong bag, una muna ang bag at ang hangin ay lumalabas bago mag-start ng CPR. Para ang aerosol matatrap dito at dumadaan sa HEPA filter. So, tuloy-tuloy CPR. Sa ngayon, in hospital tayo, 30:2. 1, 2, 3, 4, 6, 7, 8, 9, 30. 1, 2. Okay? Tuloy-tuloy. Ngayon, nag-iisa ka lang. Bago ka mag-CPR, non-rebreather mask lang. Huwag kang, after 30, punta ka dito, bigay ka ng oxygen. Hindi po. Kahit in-hospital ka, huwag mong gawin. Pag nag-solo flight ka. Solo flight ka, all compression ka lang, basta may non-rebreather mask, para maganda yung recoil. Pag recoil mo, maganda yung hangin na pumapasok, nasa 90%, ang chances of survival, tumataas. Pangalawa, yung aerosolize, hindi lilipad at malanghap. But dalawa kayo, 30:2. Don't start CPR without this, according to the interim guideline, and without this. In the absence of such, of 2 to 2, simply cover it with mask para ang aerosolized object ay matrap dyan. Ganun lang ang ating 2022 interim guideline for BLS. Kung hindi nyo pa pinapractice, yan ang sinasabi ko sa inyo, yan ang susundin natin. Again, in the absence of a cervical involvement, cervical spine injury, head tilting. Pag meron, simply jaw thrust. Pero pag nag-jaw thrust ka, dapat 2 tao ang nag-ooperate ng bagging. So, nag-iisa ka, yan. Pag nasa side ka, walang problema. Ganon pa rin, side. Kahit kabilang side, itong kabila. As long as hyperextend. Kung nasa streets kayo, katulad sa amin, may tinatawag na tie locking. Ang tie locking is nasa, kunwari sa asfalto, sa semento siya, neck lift, head tilt, bago ako ipitin ko ng aking thigh ang tao. Naka-tilt na. And then, ganun pa rin. 1,000, 2,000, 3,000, 4,000, 5,000. 1,000, 2,000, 3,000, 4,000, 5,000. So, ganun lang ang ating intervention mechanics sa positive pressure ventilation. Okay? So, yun lang yung sakop sa interim guidelines. Now, pagdating natin sa infant, sa bata, same pa rin, no? Pero pwedeng isa ang compress. Pagdating sa infant, kung hirap siyang, meron tayong maliit na bag, ambu bag, pero pagka mag-anak, walang problema, pwede tayo mag-mouth to mouth. No? Pag choking sa bata, medyo baby kasi siya, mahirap talaga. Ito, hindi sa leeg, dito. Okay, pinakauna, kung may platform ka, thrust 5, 1, 2, 3, 4, 5, mabilis dito, sa chin, sa mentum. Mentum, kuha, lagay sa platform, lagay dito sa lap mo, back slap. Ang back slapping mo, scapula to scapula, 2, 4, 5. Ang tawag niyan, 5 by 5. 5 thrust, 5 blows. Balik, thrust, until the object is dislodged and you can scoop it out. Do not scoop like a blind sweep. Okay? Kasi baka biglang mag-seizure yan, dali yung daliri mo doon sa loob. Or, lalong madiin yung material sa loob, yung nag-lodge ng material. Now, paano kung buntis? Pag buntis ka, na mayroong obstruction, hindi naman buntis, isipin nila buntis. So, nasa likod ako. Okay, and I'm gonna do abdominal thrust. Pag I'm gonna do abdominal thrust, kasi buntis siya, isipin niyo buntis yun. Ganoin ko lang para ma-imagine buntis siya. Okay. So, there's no abdominal thrust. Ang tawag doon, chest thrust. Dito kasi chest, okay, iganon to, hindi to, mangingitim yan. Ito, iganon mo. Yan na. Itong parang protuberance dito, ito siya. Yan, ganon. In between the dodo. Tarin ko Tarin ko. Okay, in between the dodo, and then dito, 1, 2, 3, 4, 5, and until the patient becomes unconscious, lie the patient down, check responsiveness. If no responsiveness, call for help, and start CPR. Aggressive CPR dito kasi may baby sa loob na hinabol natin. So, dalawa ang binubuhay mo. Okay, so ganun lang. So, dito ka chest thrust. You do not do abdominal thrust because that's very impossible. So, chest thrust lang until the patient's obstruction is dislodged. Now, going to AED, meron tayong 2 kinds of pads. Dito ay continuous na merong sensor, merong separated. Ilagay sa sternum, hiwalay sila. So I don't care. Sa hospital, I don't encourage AED. Ang in-encourage ko ay manual defibrillation. So sa manual, bumabalik na rin tayo ngayon sa paddle. So okay lang yan, paddle. Still basic life support. Pero sa basic life support, ideally, AED. Pero merong manual override. Kasi ang karamihang mga AEDs, defibrillator ngayon sa hospital, dalawa, AED with manual override. So, ang ginagamit natin, although kinuha na kasi sa akin yung soul, sayang. problema kapag pads, yung impedance niya, yung lalim ng idudulot na lalo na pag mataba yung pasyente, ay hindi katulad kapag may paddles kasi nadidiinan ko at around 20 pounds, 15 to 20 pounds. So nakakatulong sa impedance. So ganun ang ating style. Bigay ka, boom, fire ka. So depende lang yon kung meron kang manual. But I encourage sa hospital manual tayo. Para mas maganda kasi pag manual, malalaro mo yung manual dati. Lalo na pag ang pasyente hindi arresting, matutunan nyo sa ACLS mamaya, ano lang siya, kapag ang pasyente ay, what we call this, meron siyang tachyarrhythmia na you need to synchronize cardioversion. So, hindi nagagawa ng AED yan. Cardioversion, hindi nagagawa. Kung sobrang brady because of a heart block, hindi rin siya pacing. So, kaya hindi tayo pwede sa AED. Kasi hospital na tayo, we are supposed to be the definitive care. Again, baka kasi nagkamali kayo, puro AED, tapos i-order nyo AED, nakakatawa po yun. Kasi again, AED is designed for lay people, not for professionals like us. Okay, so kailangan pag nag-order tayo ng gamit, alam niya. I don't care what. Meron nga ngayon mga magagandang brand eh. China, yung may German technology ginawa sa China. My brand. Ganda siya. Na gamit ko sa Turkey. Kalimutan ko lang. Merong sa akin na live AED. Iiwan sa akin. So very good machine. Ang maganda sa kanya, may pediatric mode. Pwede pang bata. I'm even requesting for a manual eh. Sana may mag-sponsor ng manual. Maganda talaga manual. So, ganun. So, the issue of BLS is still 4. Although, ang emphasis ngayon ay 5. So, number 1, adequate PPE ka muna. Lalo na in-hospital, strictly. Adequate PPE. Wala na silang pakialam sa compression. Andun pa rin si compression, pero tinaasan nila ang tinatawag na safety factor, particularly sa responder. Kasi baka magkabiglaan kayo, lalo na sa abroad kayo, tapos irarally kayo ng tanong, what's the first protocol, the first new program for basic life support? So, first is the protection, don't PPE. Appropriate. Pangalawa, secure the airway of the patient. Meaning, huwag kayo mag-start ng CPR na walang cover. So, pwedeng mask versus non-rebreather mask. Sa mga taong hindi nakakaintindi ng non-rebreather mask, yan ang non-rebreather mask. This is adult. So, meron siyang valve na one way. Pag nag-exhale ang pasyente, lumalabas dito sa gilid, left and right. Tapos, yung release nito is 15 liters per minute doon sa emergency oxygen. Or, a bag valve mask. Ngayon, dalawa. Pangatlo, push hard, push fast, 120 per minute. Adequate recoil, avoid interruption. Yan lang yung pinaka-effective way of basic life support. Kahit pa ikaw ay advanced provider, invasive ka, nasa ICU ka. When you cannot perform very good BLS, goodbye si ALS mo. No? Kailangan magaling ka sa basic life support. There's a Japanese doctrine. Huwag mong isipin yung mga elite maneuvers or mga advanced. Galingan mo lang basic mo. Makukuha mo na yung advance. Pag mahusay ka, madali ang take-off ng advanced intervention pag napakalaging ng basic. And we have to do it properly. Particularly yung sinabi kong bagging. So, wag humawak dito sa gilid. Itong brim ng bone to. Diyan yung 3. Still. Yan. Okay? Huwag dito. Kasi pag dito, hindi makaya ang pasyente, pinatay mo. Gilid ka. Laging bone to bone lang yan. Para sa good seal. Yan. Nakikita ko na huli ko. Alam ko, pag wala, hindi naturuan to sa emergency. Ganyan na nga. See. para tight seal. Itong tatlo, tight seal dapat para wala kang leak. Para ang hangin pupunta ng hangin directly to the lungs. Tapos kung maganda naman ang head tilting mo, automatically it will go to the lungs. Okay? Again, I don't care what brand do you use or you use in AED, but the recent brands must have PEDJA. On and off, PEDJA mode. Once shock advice, ito yung pinipindot. 1 and clear, 2 yung clear, clear, 3 and clear, clear. Pindot. Shock given. Continue CPR. Okay? So, yan ang ating automated external defibrillator. Yung pusa ko, malapit sa akin. So, any question? Question? Pungit mo. Pungit. Any question? You can use, hindi ko mahanap yun eh. Kaya medyo natagalan ng kanina. I was looking for airway adjunct. Hindi ko alam kung sino humiram sa akin. Bubukas na naman ang airway adjunct. Kasi, dapat I will teach it in ACLS. Paano nilalagay yung airway adjunct. Yung nasopharyngeal saka oropharyngeal. In case. So, actually, program ng ACLS nila nilalagay from basic to advanced. Pero usually ako sa BLS, tinuturo ko na. Problem ko, hinahanap ko kanina. I don't know where the, hanap naman ako ng bubuksan kong gamit. So, you have, Joy, meron ba sila exam?
Yes po, Doc. Meron po.
So, you will have your exam with Ma'am Joy to check things out. If you can't really devise your questions to me, well, you can just send email and then wala akong email. Or Facebook, kung may Facebook kayo, Ted Everest Doc Esguera. Ano ba ang ano ko doon? Hindi ko alam ano yung tingnan ko. Hindi ko alam kung ano ang profile picture. Yung profile picture ko, yung nasa Turkey ako na interview ng CNN. Ayan. So, you can ask me there questions. Baka kasi mag-friend request kayo, medyo sorry ha, kasi 5,000 na yung puno na siya. So you can just, raise your questions there and I'll answer them. So if you don't have any question, 2 issues. Number 1, you will take your exam. Number 2, you will, for those who will be taking ACLS, will start at 1 o'clock para makita nyo how it's the bridge of BLS to ACLS. Because if you want to consummate your effectivity as lifesaver, iba talaga pag ACLS ka. Yung margin of confidence mo in saving lives tumaas. No? Kesa sa plain BLS lang. Kasi siyempre iba na rin yung merong chemical intervention. Like giving drugs like epinephrine, lidocaine, amiodarone, and giving IV. Yan. Kasi pag oras nag-IV ka na, hindi na siya BLS. Kahit pa sa inyo, basic na lang yung IV. Pero ang category ng ACLS is the IV. Yan ang starting point. Pero ngayon, halos sabay si IV saka si airway. Dati, all ay ma-contain. So, all the best on your exam. Sana payagan ako ni Ma'am Joy next time. Meron din akong exam from my end. Gawa ko ng exam para enjoy. So see you at 1 o'clock. Habang nag-exam kayo, there will be some sort of a, what do you call this? Video. It's not really updated pa. Pero for the most part, ganun ang approach. Ganun ang dynamics. Ang wala lang is yung doning ng for COVID. Kaya yun lang, at saka yung speed ng rate ng compression. Other than that, halos pareho lang. Okay? So see you this 1 o'clock and good luck.
Jason! Jason, can you hear me? Oh no.
911, what's the address of the emergency?
Press 50 Wheeler Road, Oakdale.
LFA Station 1, Medic 5, possible cardiac arrest, 50 Wheeler Road, across Villard.
And is he breathing?
No, he's not breathing. Please help.
Hello po. Nasa meeting chat na po yung link ng exam. You can take your exam na po while watching the video. Thank you po.
LFA engine 105 en route to 50 Wheeler Road.
Copy engine 1 en route to 50 Wheeler. Update on patient, 60-year-old male. Bystander CPR is in progress.
Copy. CPR in progress.
Go ahead and set your phone down, put me on speaker.
Hold on.
Okay, can you hear me?
Yes.
Okay, let's get him flat on his back. I'm going to tell you how to do CPR. Okay, I want you to put one hand on top of the other, right in the center of his chest.
Okay.
We're going to pump the chest hard and fast, at least 2 times per second and 2 inches deep. We're going to do this 600 times or until help can take over.
Okay.
This is the pace that I want you to do. It's 1, 2, 3, 4.
Dispatch.
1, 2,
LFA
3,
Command 2 en route. I'm mobile and nearby. ETA 1 minute.
Cardiac arrest is the loss of the heart's ability to pump blood through the body. The most dramatic occurrence, sudden cardiac arrest, can happen anywhere with little or no warning. Victims unexpectedly collapse. Breathing stops. Sudden cardiac arrest occurs when the normal electrical impulses in the heart suddenly become disorganized. Normal mechanical contraction of the heart muscle is lost, and a chaotic quivering condition known as ventricular fibrillation can occur. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen.
Fire department! In here! We're in here! Hurry!
Okay, let me in here.
Okay, thank you.
Sir, are you okay?
Confirm cardiac arrest.
Cardiopulmonary resuscitation, or CPR, is the immediate treatment for a suspected cardiac arrest. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions and rescue breaths. However, CPR alone is not enough.
1, 2, 3, 4, 5, 6.
The most
7.
effective way to end fibrillation is defibrillation, using a defibrillator and electrode pads adhered to the chest. A controlled electrical shock is sent through the heart to stop ventricular fibrillation, allowing the heart's normal electrical activity to return and restore the normal pumping action of the heart. Successful defibrillation is highly dependent on how quickly a shock can be delivered. For each minute in cardiac arrest, the chance of surviving goes down by about 10%. After as few as 10 minutes, survival is unlikely. An automated external defibrillator, or AED, is a portable, computerized device that is simple to operate. The use of AEDs by emergency responders and other healthcare personnel allows defibrillation to occur much earlier than before. Turning on an AED is as simple as pushing a power button.
1, 2,
Once
3,
on,
4,
an
5,
AED
6,
provides voice instructions to guide an operator through its use.
Apply pads to patient's bare chest.
19, 20, 21, 22.
An AED automatically analyzes the heart rhythm to determine if a shock is needed.
Stay clear of patient. Analyzing.
If a shock is advised by the AED,
Shock advised.
Everyone clear?
Stay
the
clear of
operator
shock
clears the person
now.
and pushes a button to deliver the shock.
Shock delivered. Begin
Immediate
CPR.
high-quality CPR and early defibrillation with an AED can double or even triple the likelihood for survival. Most cardiac arrests occur outside of a hospital. Most of those occur in the home. The chain of survival is often used to describe the best approach for treating cardiac arrest. Each link in the chain is essential for a person to survive. If a single link is weak or missing, the chances for survival are greatly reduced. The greatest chance for survival exists when all the links are strong. The chain of survival for cardiac arrests outside of a hospital consists of 5 interdependent links: early recognition of cardiac arrest and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. Cardiac arrest inside a hospital usually occurs when a known medical condition worsens. The chain of survival inside a hospital reflects how resuscitation fits into the overall picture of medical care: monitoring, prevention, and treatment of pre-arrest conditions, early recognition of cardiac arrest, and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, and effective post-cardiac arrest care.
Engine 2312, dispatch.
Engine 2312.
I have an update on patient condition. Caller reports patient was caught in a fallen tree and submerged for several minutes. The patient is now out of the water, and we're attempting to get bystander CPR initiated now.
Copy, dispatch. Engine 2312. On scene now.
Copy 2312 on scene.
He got caught up on a strainer. I just got him out.
Sir, can you hear me?
Unlike sudden cardiac arrest, in which the heart is the primary problem,
No pulse.
cardiac arrest can also be the end result of a blocked airway or loss of breathing. This is known as secondary cardiac arrest.
Apply pads to patient's bare chest.
Problems such as hazardous breathing conditions in a confined space, drowning, and drug overdoses are all causes of secondary cardiac arrest. With no incoming oxygen, the heart progressively becomes weaker until signs of life become difficult or impossible to assess.
Stay clear of patient. Analyzing. Stay clear of patient. No shock advised. Begin CPR.
Medic 849, engine 2312.
If the heart is simply too weak to create obvious signs of life,
Cardiac arrest.
immediate
No shocking
CPR
rise,
with an emphasis on effective rescue breaths may be the only chance to restore them. The abuse of opioid drugs is a serious and growing health problem. Increasing prescriptions for opioid pain relievers such as hydrocodone and oxycodone have made them more commonly available. The increased availability and use of heroin, a highly addictive opioid, is also contributing to the problem. As a result, overdoses and deaths from prescription opioids and heroin have risen dramatically. Opioids taken in excess can depress and stop breathing. Opioid overdose is a common cause of secondary cardiac arrest. Suspicion of opioid use may present itself through questioning of bystanders or by observation of the person and location in which she was found. Naloxone, also known as Narcan, is a medication that can temporarily reverse the life-threatening effects of opioids. It's easy to administer, either through an auto-injector device or through an aerosol that is sprayed into the nose. Initiate and establish BLS care prior to using naloxone for suspected opioid overdose.
Can you hear me? Hello? Hello?
Command, this is Engine 105.
This command, go ahead.
We have a child in cardiac arrest at our location. We need a medic unit right away.
Copy that.
Children are more likely than adults to experience secondary cardiac arrest due to an airway or breathing problem. When describing age groups in relation to CPR, an infant is younger than 1 year of age. A child is 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. A person is considered an adult after the onset of puberty. The chain of survival for children and infants emphasizes prevention and giving effective rescue breaths as part of CPR. Prevention of airway and breathing emergencies. Early CPR with an emphasis on effective rescue breaths, and if needed, defibrillation with an AED. Prompt activation of the emergency response protocol for the setting. Effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. The quality of CPR matters. Higher quality CPR performance is directly related to an improved chance of survival. There are two key elements of high-performance CPR: high-quality CPR skills and a more efficient team approach to resuscitation. CPR skills can vary greatly depending on a person's experience, practice, and physical ability. It is normal for there to be a gap between perfect skills and what you can actually perform. An important goal is to narrow that gap as much as possible. High-quality CPR skills include beginning CPR compressions within 10 seconds of determining cardiac arrest, compressing fast at a rate of 100 to 120 times per minute, compressing hard at least 2 inches on an adult and at least 1/3 the depth of the chest for children and infants, allowing for complete chest recoil at the top of each compression, minimizing interruptions to compressions, giving effective rescue breaths that create a visible chest rise, and avoiding excessive air on rescue breaths. CPR feedback devices that measure skill performance in real time can be used to optimize CPR. High-quality skills are only part of high-performance CPR. Orchestrating the actions of a resuscitation through a team approach, much like a pit crew in a car race, can significantly improve the care being provided. An effective team approach has clearly defined roles, uses clear and effective communication, allows multiple treatment actions to occur at the same time, maintains high-quality CPR by allowing team members to switch places when tired and minimizes overall interruption times. The only way to develop a high-performance CPR approach is through ongoing commitment and practice. CPR skills can deteriorate significantly in as little as 3 months. Shorter, more frequent, scenario-based retraining sessions are reasonable for maintaining skills for individuals likely to respond to a cardiac arrest. Emergency situations often present hazards to your safety and health.
He's over there. He was mixing chemicals and fell.
Okay.
Your personal safety is the highest priority, even before the safety of an ill or injured person.
Go and get hazmat on. Tell them we got 1 man down. There's an unknown chemical.
Putting yourself in danger to help someone can make the situation worse. Always pause for a moment before approaching. Look for obvious hazards. Consider the possibility of hidden dangers. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. When caring for someone, you can be exposed to blood or other potentially infectious body fluids. While the risk of contracting a disease is very low, you must take measures to reduce exposure. The most common infection bloodborne diseases and pathogens include hepatitis B, hepatitis C, and HIV, the virus that causes AIDS. Standard precautions is a set of protective practices used when providing care, whether or not an infection is suspected. Personal protective equipment, or PPE, describes protective barriers worn to prevent exposure to infectious diseases. Reducing exposure lowers the chance of infection. Disposable gloves are the most commonly used barrier. Make sure they are readily available and always use them. To prevent direct contact, use a CPR mask with a one-way valve when giving rescue breaths or a bag mask device to prevent direct mouth-to-mouth contact. Unprotected mouth-to-mouth rescue breaths should not be given by emergency response personnel. BLS providers and the locations in which they work vary. So does the way in which they activate a response for higher levels of care. Activation is typically defined by emergency response protocol. A BLS provider or member of a workplace emergency response team may radio a centralized communication person to contact EMS, or the provider may call EMS directly. An EMS provider may request help from advanced care providers or inform other incoming responders about the details of the situation found. Inside a hospital, a floor nurse may call a code to which a resuscitation team with appropriate equipment will respond. To be an effective BLS provider, you must understand your local protocols on how to call for additional help. The quality of CPR skills can be improved during practice with the use of a real-time feedback device that measures things such as compression depth, compression rate, and overall timing. Real-time feedback allows a user to make ongoing adjustments to maintain and reinforce high-quality skills. The Loop learning system is designed for CPR skill practice. The Loop feedback device is placed directly on a mannequin chest. Compressions are done normally on top of the device. A Loop software program allows a user to set up timed sessions in which the Loop system provides real-time visual and recorded measurement of chest compression rate and depth. Compression rate can be easily seen at the top of the screen. Adjust your compression rate to keep it in the green area. Compression depth is measured across the bottom of the screen. Compression spikes that are green indicate a compression that is ideal. Red spikes indicate a compression that is too shallow. Watch your performance in real time on a computer screen and make adjustments as necessary. The Loop software also records your performance and allows for overall review after finishing a session. There are basic CPR skills used to provide the most effective approach to cardiac arrest. These include high-quality chest compressions, high-quality rescue breaths using a CPR mask or bag mask device, use of an automated external defibrillator, and checking for life-threatening emergencies using a BLS assessment. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. To perform proper compressions, the person needs to be positioned on his or her back on a flat, firm surface. Kneel close to the side of the person. Place the heel of one hand on the center of the chest on the lower half of the breastbone. Place the heel of your other hand on top of and parallel to the first. Bring your body up and over the chest so your shoulders are directly above your hands. Bending at the waist, use your upper body weight to push straight down to a depth of at least 2 inches. Lift your weight and allow the chest to fully return to its normal position. Move immediately into the downstroke of the next compression. Focus on high-quality techniques. Compress deeply more than 2 inches. It is likely you will not compress deep enough. While injury could occur from deeper compressions, do not let the fear of this affect compression depth. Compress fast, between 100 and 120 times per minute. Do not let a higher compression speed result in a shallower compression depth. Do not lean on the chest between compressions. Blood pressure is created and maintained with ongoing compressions. When compressions stop, pressure is quickly lost and has to be slowly built up again. Allow the chest wall to fully recoil or rebound at the top of each compression. Minimize interruptions when doing compressions. When compressing properly, you may hear and feel changes in the chest wall. This is normal. Forceful external chest compressions may cause chest injury, but are critical if the person is to survive. Reassess your hand positioning and continue compressions. As an alternative approach, you can grasp the wrist of one hand with the other when it is difficult to compress with the heels of both hands. To perform chest compressions on a child, position the child face up on a flat, firm surface. Place the heel of one hand on the lower half of the breastbone, just above the point where the ribs meet. Using upper body weight, compress at least 1/3 the depth of the chest, or about 2 inches. Lift your weight and allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. Compressions on a larger child can be tiring. If needed, use 2 hands to perform compressions. To perform chest compressions on an infant, position the infant face up on a flat, firm surface. Place 2 fingertips on the breastbone just below the nipple line. Compress at least 1/3 the depth of the infant's chest, or about 1 1/2 inches. Allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. When doing chest compressions with 2 or more providers, encircle the sides of the chest with your hands and use your thumb tips to compress the lower third of the breastbone. Rescue breaths are artificial breaths given to someone who is not breathing. They are given by blowing air into the mouth to inflate the lungs. The air you breathe contains about 21% oxygen. Your exhaled air still contains between 16% and 17% oxygen. This exhaled oxygen is enough to support someone's life. To give rescue breaths, you need to make sure there is an open airway. The airway is the only path for getting air into the lungs. An unresponsive person can lose muscle tone. If flat on his or her back, The base of the tongue can relax and obstruct the airway. This is the most common cause of a blocked airway. The tongue is attached to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat and opens the airway. You can open a person's airway by using the head tilt chin lift technique. Place one hand on the forehead. Place the fingertips of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. Before using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it upward and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. A bag mask device allows rescuers to provide rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by two. From above the head, place the mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bag slowly enough to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, a person will not survive regardless of injury. When the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered. Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care. The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. activate the emergency response protocol for your setting and get an AED.
Heather? Heather, breathe! Heather! Heather, breathe, please!
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, can you hear me? Ma'am, can you hear me?
A person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch, P37, can you advise EMS this is a possible overdose? She's not breathing but has a carotid pulse. I'm gonna start rescue breathing.
Copy P37, possible overdose, rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm gonna keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak to adequately move blood forward. Signs of poor blood perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
Let me take over for you.
How long has he been down? Just a few minutes.
Sir, are you all right? One, two, three, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
Stay clear of patient. Analyzing. Shock advised.
Everybody clear?
Clear.
Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3.
Immediate high-quality CPR and defibrillation with an AED can double or even triple the chance for survival from sudden cardiac arrest. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This person is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. Allow the AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear
make
of
sure you are
patient.
not touching the person before delivering the
Deliver
shock.
shock now. Shock delivered.
Immediately after a shock is delivered, resume CPR, starting with compressions. Voice instructions and additional analysis by the AED will guide you through further care. Don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Hold up, stop CPR, who's responding?
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. Continue to follow the AED's instructions. Compression-only CPR is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. Most arrests involving children are secondary to the initial loss of an airway or breathing. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This child is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use an AED immediately if one arrives. Don't stop until the child shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Infant CPR is similar to adult and child CPR. Pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This infant is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Don't stop until the infant shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
And punch it out now, all the way in front. If you want a little bit more intensity, push with the palm. Keep those hands in the water. Now push, push. Lift up those knees, get those shoulders down and back. Let's go. Good job. Take it to the side. Same thing. This is a little bit easier. Palms a little bit harder. Get those knees up. Up that floor. Let's go.
Done. Done.
High-performance CPR not only requires high-quality CPR skills, but it also relies on the efficiency of multiple providers working as a team. It is common for multiple providers to respond to a cardiac arrest, but a resuscitation may start with a single provider. Other providers can be integrated as they arrive. When 2 providers are available to perform CPR, one performs chest compressions, while the other gives rescue breaths. For adults, the ratio remains at 30 compressions and 2 rescue breaths. The compressor pauses to allow rescue breaths to be given. Give breaths as quickly as possible to minimize the interruption. High-quality compressions are tiring. If an AED is not attached, switch every 2 minutes at the end of a CPR cycle. Clearly communicate the details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relieve the compressor while rescue breaths are being given to shorten the interruption. With 2 providers, use a 15:2 ratio of compressions and breaths for a child or infant. When 2 or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Yes. Our lifeguards are responding now.
Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
5, 6, 7, 8, 9, 30. 1, 2, 3, 4.
Yes, I hear the sirens. Oh, they're here.
Stop CPR. Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1,
Begin
2, 3,
CPR.
4, 5, 6, 7, 8, 9.
The team leader takes a general perspective to supervise and improve overall team performance.
What's the story? He was exercising in the water and then he collapsed. How long since you started?
Effective team communication is essential. Speak calmly and in simple terms.
2 to 3 minutes. Was it witness? Yes.
This person is also the main point of internal and external communication. If you are asked to do something, repeat it back to confirm and reinforce the instructions. Other roles may be filled as necessary. A second ventilator to help with the use of bag mask, or a scribe or reporter to document patient information, treatments, and intervention times. In the transition to more advanced care, additional roles for actions such as administering medications may be added. When an AED is attached, plan to relieve the compressor during the time an AED analyzes the heart. This typically occurs every 2 minutes.
Are you guys clear?
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, a facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is no longer necessary to pause compressions to give breaths. Provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute. Choking can occur when a solid object, such as a piece of food, or a small object enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen. obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. I need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange, the lack of sound, and the inability to speak or cough forcefully.
Chrissy? Are you choking? I can help, okay? Stand up. Try and get a breath. Try and get a breath. Let's sit you down.
A person without any air exchange requires your help to survive. If you suspect someone is choking, ask, "Are you choking?" If the person nods yes or is unable to speak, cough, or cry, act quickly. Stand behind the person. Kneel behind someone who is sitting. Reach around and locate the person's navel with your finger. Make a fist with your other hand and place the thumb side against the abdomen just above your finger and below the ribs. Grasp your fist with the other hand. Give a quick inward and upward thrust. Each thrust needs to be given with the intent of expelling the object. Repeat thrusts until the person can breathe normally. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate the emergency response protocol for the setting. Begin CPR starting with compressions. Look in the mouth for an object after each set of 30 compressions and before giving rescue breaths. Remove any object if seen. Continue care until the person starts to move or another BLS provider takes over. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try not to put pressure on the ribs. If you are choking and alone, try pressing your abdomen quickly against a rigid surface, such as falling onto the back of a chair. If one is not available, attempt abdominal thrusts on yourself. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. For a choking child, the approach is nearly the same for adults. It might be easier to kneel behind a choking child to deliver thrusts. Use less force on your thrusts. Because infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Lay the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. If not already done, have someone activate your emergency response protocol and begin CPR. Look in the mouth for an object after each set of compressions and prior to giving rescue breaths. Remove any object if seen. Abdominal and chest thrusts can cause internal injury. Anyone who has had these maneuvers used on them should be evaluated further to ensure there are no injuries. Opioid overdose can severely reduce or eliminate a person's effort to breathe. Naloxone is a drug that can quickly reverse this effect. The initiation of CPR, activation of your emergency response protocol, and use of an AED should not be delayed to administer naloxone for a suspected opioid overdose. One method of administering naloxone is through a nostril using a pre-filled syringe with an attached mucosal atomizing device. If you have reason to suspect the person's condition is related to an opioid overdose, administer naloxone without interrupting ongoing care. Take both parts of the pre-filled syringe out of the packaging. Remove both caps from the larger hollow tube and the cap from the smaller capsule with the medication. Gently slide the medication capsule into the hollow tube and fully screw the capsule in clockwise. Gripping the plastic wings of the atomizer, fully screw the tip of the hollow tube clockwise onto the atomizer. Insert the white cone tip of the atomizer snugly into a nostril. Give a short, vigorous push on the end of the medication capsule and spray about half of the medication into the nose. Repeat the technique on the other nostril to give the remaining medication. Continue CPR and the use of an AED if one is available. If normal breathing does not return, administer a second dose of naloxone using another pre-filled syringe. Calm and reassure someone who responds. Opioid withdrawal symptoms can occur and be unpleasant. The effect of naloxone is temporary, and breathing may become depressed again. Anyone given naloxone should have continued medical evaluation.
Hello po, good afternoon po. Um, regarding your certificates and IDs po, by Monday po namin isi-send yung soft copy po sa email na provide niyo po. If you want to avail hard copy po, pwede naman, ate, if you want to avail hard copy po, pwede naman po for only 200 pesos po. Free shipping na po siya nationwide. Kindly message your coordinators na lang po if mag-a-avail po kayo ng hard copy. Sa mga BLS only naman po ang in-enroll, pwede po kayo mag-attend mamaya ng ACLS po 1 PM po if want nyo po. Pwede po kayo mag-upgrade po anytime. Just message your coordinators lang po if want nyo po mag-upgrade. Yun lang po. Pwede na po kayo mag-take ng lunch nyo po. See you at 1 PM po. Thank you.
Thank you.
program. And I'll start with the General ACLS program of 2020. Although meron tayong interim guidelines ng 2020, still 2020, ang na-enhance lang naman is more on the COVID. So for those who were not in, what we call this, in BLS, so pag ginawa po ang isang programa ng 2020, hindi po ibig sabihin 2020 yan. Na meron tayong lag time na delay kasi una, usually 2018 or early 2019. So i-roll out nila 2020. So nakalagay 2020. Ganun po usually ang run natin. But this is the latest of AHA and ILCOR. So let me share the slide. So, pag sinabing ACLS, ang pangalan na yun or course name is from AHA. Although marami nang sumasama na programs like ASHI, no, yung program natin. Pero sila kasi yung researching unit together with the international liaison yung ILCOR. So ACLS, ang tamang pagbigkas kasi maraming sabi advanced cardiac life support. Hindi po tama yan. Kailangan mo plitohin mo kasi ang main problem is actually the vessel. So it's advanced cardiovascular life support. Para lang pag nagsalita tayo, lalo na gusto natin international yung peg ng Pilipino, ayusin natin yung mga maliliit na terminolohiya. Which minsan sa Pilipinas, hindi tayo very conscious, no? Or kumukuha tayo ng international guidelines, pero when it comes to, presenting in the international scenario, first and foremost is nakukuha natin. No? We have lots of, sorry, we don't operators, sana so operators. We have lots of doctors, scientists who are making it in the international arena. Mag-present doon, no? Maganda yung presentation kasi evidence-based. But when we go back here, marami tayong mga terms na minsan mali. Like kanina, nang binanggit ko sa BLS, yung understanding of the heat illness, yung heat stroke, the most abused word, na hindi naman heat stroke because heat exhaustion. Namatay because of MI, tapos namatay sa heat stroke. Pero bumulagta doon sa daan, pag i-autopsy natin, MI, heat due to heat insult. It's not yet heat stroke. And it's forgiven because wala naman tayong specialty kasi na environmental medicine. Siguro okay lang yun. So dito, sa ACLS, is the mother of all advanced life support. And for those who were not in BLS, so I'm Dr. Ted Esguerra. I'm formerly, so many years ago, I'm an instructor of American Heart, as in, sa California Registry. Hindi na ako nag-renew after 4 years because hindi naman ako naghanap ng trabaho. Na nakakapagod din. At saka medyo nagtampo ako sa AHA. Kasi may course sila dito. Tapos pag mapunta na sa US yung kababayan natin, pinaparitake nila. So parang naghanap buhay lang. Para ayaw ko ng gano'n. Medyo, sabi ko, bakit gano'n? Pinaaha mo rito, pumasa. Pagdating sa US, pagdating sa ospital, mag-aha ulit doon for that hospital. Mag-ACLS ulit. Hindi na makapalag yung Pilipino kasi siyempre tuwang-tuwa na siya, nasa US na siya. Para sabi ko, grabe, no? Ang galing ng style nila. So I did not anymore renew. But they keep on updating me. So because I have international affiliation on wilderness medicine, yung others are aligned with AHA and ILCOR, others are not. Kaya nakakakuha pa rin ako ng update. Plus, I'm teaching in other advanced life support schools. Dati nag-mentoring ako with University of South Wales on wilderness and expedition medicine. So I'm teaching also internationally. Tapos ngayong July, I'll be in Kuala Lumpur for the International Search and Rescue. Kaya medyo a little bit, I might not be as, like if you have specialty, IM or what, I will not deep dive into the whole picture of a cardiac anomaly or a cardiac pathology and how we treat it. Dito lang ako, ano ang binibigay ng ACLS. When I teach ECG, it's the pathological ECG na dapat natin makita. I will not be teaching bakit yung mga brugadas na yan, yung mga Wall-Parkinson-White syndrome na early take-off, hindi ko itatopic. So our objective is to describe what ACLS is, identify again the chain of survival, pabalik-balik tayo sa chain of survival. Pag nawala tayo sa chain of survival, wala tayong storyline, mawindang ang ating ACLS run. Tapos, how do we look at the pathological ECG? May kasabihan, we don't treat the rhythm. Yes, but we have to rely on the rhythm and we treat what's the presenting case. No? Identify yung pharmacology natin and then yung ating mga, supposedly, kung nag-face-to-face tayo, meron tayong mga stations. Airway station, intra-osseous station, code blue station. Since we are online, ako lang yung mag-station sa sarili ko, ang kausap ko, hindi ko alam kung sinong mga espiritu sa virtual. So I'm speaking alone, no? And you on the other side of wherever, no? And how do we perform the megacode? So kung hindi kayo familiar sa word na megacode, yan po yung term na ginagamit natin kapag nag-address tayo ng cardiac arrest. So megacode kasi yung code blue, no? Megacode tawag natin. Baka kasi iba ang terminolohiya sa inyo. So I would like to ask for forgiveness kasi nasanay ako sa institusyon pinanggalingan ko. We use code blue and we use megacode. So dito, let me use megacode. Okay. ACLS is a sort of intervention wherein we will use algorithms, no? Algorithms for shockable rhythm, cardiac arrest, for non-shockable rhythm sa cardiac arrest, algorithm for bradyarrhythmia, for tachyarrhythmia. And also for stroke, although sa stroke mababaw lang sa ACS, hindi tayo nagdi-deep dive, no, into understanding PCI, hindi tayo ganun. So mga more on the quick run, anong gagawin natin initially pag na-encuentro tayo ng acute coronary syndrome. So this is mainly a set of algorithms, no? Swerte nga kayo, hindi katulad nung panahon ko na not really a recent past, no? Na grabe yung ang aming tawag nito, yung aming algorithm, nakakatakot sa dami. No? So, ngayon, mas pinadali nila. Then we will also deal with pharmacology ayon lang dun sa ACLS. Hindi na ako mag-deep dive into treating hypertensive crisis. Ang hypertensive crisis, actually hindi siya napunta sa ACLS. Nilagay nila sa AMLS, Advanced Medical Life Support. No? And how we do like intraosseous, hindi po ako magtuturo ng intravenous kasi familiar kayo, magde-demo lang po ako ng intraosseous para makakita rin kayo ng intraosseous. Although ako kasi backgrounder ko is military medicine, medyo pag-doubt kami, mas marami akong intraosseous kaysa intravenous kasi ayaw namin ng kailangan ng maraming ilaw pag nag-ano ka. Parang ganito ang ilaw namin. Kasi itong ilaw na ganito, red, hindi nag-glare to pag nagbasa kami ng mapa, pag tumitingin kami sa gabi. Kung may kalaban sa nearby, halos hindi mapansin ang red light. Kinuha ko ng red light. So kung nahirapan ako hanapin ng vein, my option is always intraosseous. Kasi kahit nakapikit ang mata ko, alam ko saan ko i-drive, makukuha ko lang yung tactile, kung saan banda yung plateau or yung flat na nang sa medial surface doon sa proximal tibia, pwede ko ma-drive yung aking trocar. So anong scope natin? First and foremost, balikan natin yung 2020 protocol. Then ECG reading, tapos yung mga drugs, advanced airway management, no? Ang ituturo ko is, of course, ang ating pinakahuling plataforma ay this endotracheal tube, no? Laryngoscope aided. Sa combat medicine, sa mundo na ginagalawan, hindi kami ganong gumagamit ng gano'n kasi we don't like to carry laryngoscope. Although meron kami, usually naka-pack sa air medevac sa helicopter. Ako sa field, nagbibit-bit ako. As, ano lang, kung medyo sustained operation, nung nasa serbisyo ako. Pero karamihan ginagamit namin supraglottic. Nung hindi pa uso supraglottic sa Pilipinas, ginagamit na po ng expedition yan sa kanan ng combat medicine. And then, review tayo ano ang defibrillation versus cardioversion, tapos capnography kung hindi kayo sanay, transcutaneous pacing, dadaanan lang natin. Wala na yung machine ko, kinuha na sa akin, but I have pictures here of transcutaneous pacing. Tapos doing megacode, hindi na tayo mag-pulse kasi ACLS tayo, hindi na tayo PIDJA. So wala tayong pulse NRP. Hypothermia, I'll teach you how to run hypothermia, understanding hypothermia kasi siyempre hindi naman, although nagkaka-hypothermia sa Pilipinas, yung tinatawag na exertional hypothermia. Pero hindi siya common. At gusto ko lang maintindihan ninyo kasi baka makasagasa kayo ng hypothermia galing sa nalunod para hindi bago sa inyo. Kasi you don't see that every day. ACLS is the mother of all advanced life support. Pag magaling kayo sa ACLS, medyo kahon-kahonin na yung mga trauma, life support, management of obstetric emergency and trauma. Because all of the things that's gonna happen to human being, lahat yan hihinto sa puso. Kahit ano mangyari sa'yo, magkamit ka ng suicide, mahihinto yan, mag-a-arrest ka. Mag-inom ka ng lason, matamaan ka ng bala, bleeding to death ka, lahat hihinto yan sa puso. So, ang puso, pag magaling ka doon, pag-address sa arresting heart, medyo mataas na yung porsyento, makuha mo yung other advanced life support. So, ano yung mga kaso nakikita natin? First, of course, pinaka-common, particularly amongst pediatric population, yung respiratory cases, no, or emergency. And then yung cardiac arrest, na 4 na klase, yung ventricular fibrillation, tapos pulseless BTAC, asystole, saka pulseless electrical activity. Tapos yung mga pre-arrest emergency, ito suki ako dito. Lagi ako hinahabol ng SVT. Katulad ng mga tachyarrhythmia, tapos bradyarrhythmia, tapos ACS. Tapos lastly, yung stroke. Although yung stroke natin, mainly, dadalhin ko lang kayo sa a little bit sa world ko. Kasi I don't like to go into the circle of the stroke team. So sa ACLS, doon lang siya mismo transition between the pre-hospital care sa emergency doon sa ER. So balik ulit tayo, kaninang nag-BLS, ito ulit tinatakal natin. Ang emphasis natin sa patakaran ng 2020 is palakasin itong prevention at palakasin ang recovery. Kasi nakikita nila kahit gaanong galing magawa itong middle, kapag ang prevention ay mahina, number 1 killer pa rin, hindi gera, hindi nuclear war, hindi AI, hindi alien attack. Ang number 1 killer ng humanity ay heart and the vessels. So sabi ko, nakwento ko kanina sa statistics, ipunin ko namatay sa Aleppo, sa Ukraine, sa Marawi, partidahan ko lang ng 5 araw sa buong mundo ang pinatay kadahilanan sa sakit ng puso. Kaya WHO said, global scare siya. Ang dinagdag pang 6 chain of survival ay recovery. Dito sa Pilipinas, dito medyo mahina tayo dito. Ang bansa natin ay mahina tumingin sa mga, lalo na sa mga persons with disability, sa mga may kapansanan o may sakit. Dito lang ako nakakita na hindi pabor sa mga nagwi-wheelchair. Kung post-stroke ako, hindi siya pabor. Malayo tayo. Hindi, sabi nga ni Senator Magsaysay, malalaman mo pag ang bansa ay progreso kapag ang mga serbisyo ng pamahalaan ay nauuna doon sa mga taong may kapansanan, sa matatanda, sa kabataan, sa kababaihan, at sa mga katutubo. Ay medyo sa pag-ikot-ikot ko, no? Medyo, hindi ako gala, pero ikot-ikot ako kasi I've been lecturing across the country. Yesterday, I had a lecture with Bureau of Treasury. The other day, top-level security management because we will have a food problem because of climate crisis. By year 2027, we will have problem with water. Criminalities will rise, terrorism, tataas yan kasi taghirap na tayo. Plus, of course, grabe tag-init dito sa Manila, sunod-sunod na yan. Kaya ako, doon na ako sa gilid, nagkukuyakoy lang ako kasi although wala naman akong aircon, pero this is, we will suffer because of our misdeeds. Wala eh. Ang pagkalinga natin sa kalikasan, wala. Ang henerasyon natin, drawing. I will not say sorry. Kasi, segue konti. Nakulong na po ako sa pangangalaga sa kalikasan. Nagsunog na ako ng laging truck. Kaya, I bled for the environment. Tinanggal ako ng Greenpeace because violent ako. Kasi nung nasa serbisyo ako, nagkakaso-kaso ako. Violent talaga ako para sa kalikasan. Yun. At hindi ko siya kinakaya. If I will live again, uulitin ko siya. Kasi siyempre ako taga Mindanao, pinanganak ako, taong bundok talaga, katutubo. Sa amin, ang bundok sa amin ay altar yan. It's like an altar. This is where our gods are staying, and so when I look at the mountain, it's totally different from how you look at the mountains. I don't like people go up there and desecrate my altar. So balik tayo dito. Ang pagkakaiba lang sa in-hospital cardiac arrest, yung ICA sa OHCA, OCA, is dito, wala tayong prevention. Ang meron dito, tawag ka lang kasi may taong bumagsak, kunwari sa kalye, perform CPR, pareho lahat except na meron kang care while on transit. Yan. So ang care while on transit ay advanced life support grade. Nung nasa Turkey po ako, nag-responde sa Lindol, kasama po ako sa contingent. Ang mga ambulansya doon ang titikas. Wala pong basic, puro advanced. Silip lang ang mga paramedic nila can perform CRIC, can perform chest tube insertion. Napos Pilipinas, bilang lang sa kamay ko yung ALS grade ambulance unit. Karamihan dito, ang laman ng ambulansya, mungkin ng oxygen. No? Despite the fact na number 1 tayo sa aksidente sa Southeast Asia, number 1 tayo sa mundo sa World Risk Index according to 2022. As pinakamataas na bansa sa buong mundo na merong mga sakuna. Pero hindi pa tayo advanced level sa ating pre-hospital care. Wala tayong batas o pre-hospital care. Pero ito, katulad ng BLS saka ACLS, dinesign sila mainly how the person can be taken care of before the hospital. Gulat kayo, no? So, hindi dahil pre-hospital care provider ako at kayo in-hospital. Ginawa talaga to para ma-bridge yung accident site or incident site to the hospital. Ito yung gap. Gano'ng kalayo yan, anong time of the day, anong klaseng terrain, anong klaseng communication linkage in between. So, ang buhay ng tao ay nandoon sa in-between, doon sa pre-hospital care. Which our country has not yet put up a concrete law on EMS or emergency medical services. It's very sad. Pero maraming gumagamit na Star of Life. Nagulat ako sa DOH, pati Secretary of Health, gumagamit ng Star of Life. Alam niyo po, sa training ko sa EMS, pag gumamit ka po ng Star of Life, dapat po ay you must be fully trained on pre-hospital care. The logo that we use in the pre-hospital care is so much abused in this country. Tapos ginagamit nila, hindi naman sila pre-hospital care provider. No? Pag nakita tayo ng buong mundo, ang tingin nila sa atin, these people are like Mickey Mouse. They don't know what they're doing and using logos they don't understand. So nakakasama ng loob kasi siyempre lagi akong sa ibang bansa, nasasaktan ako pag they comment against my country. Damay ako doon. Damay ako pag nag-comment corruption sa Yolanda. Hindi naman ako nag-corrupt sa Yolanda pero maririnig ko I'm interacting with international humanitarian organizations. Nasasaktan ako. Particularly the usage of terminology. Tinawanan nga ako nung nagpakita lang ako ng ambulance sa ibang bansa. Ang pangalan ng ambulance natin, Patient Transport Vehicle. Naku, the only thing in the world lang daw, why are we reinventing the words? No? So parang nakakasakit na. Sa pediatric, the same. Except sa pre-hospital care, sa out of hospital, meron silang prevention. Ang prinsipyo nito is not medically supported. Pero ma-explain sa socio-anthropological perspective na ang tao mas nasasaktan siya pag ang bata ang tinamaan kaysa sa adult. Yun yung socio-anthropological difference.
Ito na yun. Exam kami tapos bagsak pa nga ni.
Pa-mute lang po. Pa-mute lang.
And then,
thank you. So, welcome to ACLS, ladies and gentlemen. At the outset, I would like to introduce you into the COR and LOE. Pag sinabing COR, ito yung class of recommendation. Pag nagbasa na kayo ng libro, whether soft copy or hard copy ng ACLS, magugulat kayo, lahat ng gagawin doon, including drugs, mayroong kaakibat kasunod na COR and LOE. Dati COR lang, or class of recommendation. Ngayon, 2020, nagdagdag ng LOE. Anong ibig sabihin ng COR? Halimbawa, nakita na, perform compression at no less than 120 or 100 to 120. Saan siya nabilong? Nabilong po siya sa class 1. Nakita nila ang benefit is 3 times greater than risk. And it's mandatory yun. So, ang tawag doon class 1. Ang pagbibigay ng oxygen sa isang nag-aares ng pasyente, magugulat ka COR doon, class 1. So, yun po yun. Nagbigay ako ng epinephrine or defibrillator, class 2A po yun. So, that's moderate. No? So, benefit is still greater than risk by 2 times. Yung class 2B, medyo lamang siya katulad ng pagbigay ng sodium bicarb sa isang fresh arrest because galing siya sa nag-arrest siya because nagkaroon siya ng hyperkalemia at nagwendang yung rhythm ko pero hyperkalemic. So pwede siya mag-2B. Binigay ko siya sa arrest. Hindi ko siya binigay dahil hyperkalemia. Nabigay ko siya ng time na nag-arrest, makakategorize siya sa 2B. Pero pag binigay ko bago nag-arrest, hyperkalemic pa lang, together with calcium gluconate, magiging class 2A siya. So mga ganon. You don't need to memorize this para makita nilang kasi ang ating maneuver is evidence-based medicine tayo. LOE naman is yung mga level of evidences according to randomized sa non-randomized approaches or studies. Parang dito sa Pilipinas, I am so sad and yet I am so angry when people and colleagues, doctors, telling me that the treatment of COVID, one is ivermectin. We're in this world that you don't have meta-analysis and you tell me that it's a treatment. Meron ka mang laboratory sa bahay? Sinamahan mo pa yung lintik na kongresista na akala mo genius. Na I pay my tax and these people, when he talks, it's like a talking rabbit with no intelligence at all. So it annoys me because I'm a man of science and here comes chit-chats of a drug intended for worms and you insist it's for COVID. Where is your evidence? Nabasa mo lang? Yung nabasa mo, how sure are you? It's right. Lahat ng binabasa niyan, parang history book yan. The history book is not absolutely right. It depends on who wrote it on the geopolitical perspective. Pati gamot kasama sa geopolitical perspective. May mga gamot na hindi talaga yan, pero binigay na lang for some reasons. For example, Viagra. Alam niyo ba yung Viagra? Hindi naman yan pampa-erect ng penis eh. The first intention of Viagra is for high altitude, maano mo yung high altitude pulmonary edema. Pangsundalo po yan. It was a military medicine. Nakita nila, in certain population, nag-erect yung penis. Binentangin sa civilian medicine. Sa medicine sa buong mundo, dalawa lang pong klaseng, at tatlong klaseng medicine. Military medicine, civilian medicine, which I'm talking to you now, civilian medicine. And the medicine other than that, I mentioned to, ito yung quack medicine na walang saktong ebidensya. Pero karamihang mga na-invento ng military na napakinabangan ng civilian medicine ay it's just because intended first for military. For example, X-ray. Yung X-ray na yan, tuwang-tuwa kayo, nakita ko yung buto, may fracture. Pero kung basahin nyo sa civilian na libro, nabigyan pa ng Nobel Peace Prize, Nobel Award si Roentgen. But the first intention of the X-ray is to create a radiation other than with the behavior of the gamma rays. Nagkataon na disgrasya, lumusot dito, nakita yung buto. Nilagay ngayon as a diagnostic tool. Pero my question is, what was first the intention? Binabalik ko lang kayo sa school. So yan ang problem ngayon. We don't know which is which. Kaya pag sinabi mo, okay, itong ivermectin pwede sa COVID, asan ang iyong meta-analysis? Asan ang iyong randomized? Kasi hihingin ko ano ang level of evidence. Because if I will not follow the level of evidence, ladies and gentlemen, I'm a quack doctor. Tandaan natin yan. At huwag tayong magmayabang sa Pilipinas, wala tayong researching unit. We are not like AHA. Sa COVID, military medicine nila, USAM rin sa US, United States Army Military Research Institute for Infectious Disease, ang titindi. Balangkasin pa, pati si Ebola, Hanta, Marburg, Lassa viruses. Tayo, wala tayong bio level 4. Tapos kung magsalita tayo, akala natin expert tayo sa COVID. No? That's very ugly. Ang unang sisingilin natin, saan ang LOE mo, level of evidence? Before you talk, someone was just whispering on your ear. Para na tayo, parang there's no honor on that. We have to create something. Meron tayong laboratory. Dapat meron tayong trials na ginagawa. Then we present it, ang lagundi pala ay pwede sa ubo. What kind of ubo? Productive or non-productive? Parang gano'n. So we were able to launch lagundi and others. Ito yung meron tayong mga LOEs, level of evidences. Okay? Anyway, I will not deep dive into this. Abbreviations, hindi na kailangan niya. So, kanina sa BLS, ito po yung lumang BLS. No? Kasi sabi ko sa inyo. Tapos, ito na yung bagong BLS with ACLS. Na, the bagong BLS with ACLS. So, bagong BLS with ACLS. Okay, dito ako. Klaruhin natin. Sa interim guideline of 2022, lagi kong isisiksyak yung interim guideline para ma-realize ninyo na hindi pa yan ang sinusunod ng ating mga teaching institution. Okay, interim guideline. Saan ko natutunan to? Last year po, pag-launching nito, doon kami sa Bali. Masarap doon yung Bali. Pero together with International Disaster Response Network, we had some sort of a training. Ay sa topic na tinuro ng isang taga-Texas at Singapore ito. Pag-launching nila ng but they were with ILCOR. So, sige, gamitin ko. Hindi naman siya rocket science para I'll just ipalakihin ko lang. So again, balik tayo sa BLS kasi tinatawag natin BLS primary. Ito yung picture ngayon. Ang pinakauna ngayon, sabi nga nila, kapag may exam, ito unang tinatanong. What is the first consideration, the utmost consideration in the algorithm at the box A? Dalawa ang sagot. Limit personnel and consider resuscitation. Don't PPE, consider resuscitation appropriateness. Ibig sabihin yung PPE mo naka bio level 4 or bio level 3, level 4, sorry, level 3, level 4, not bio level. Iba yung bio level. Mix up. And then limit personnel. Dati, ang optimum counting natin sa ACLS, 6. Ngayon po, ang mataas, 5 na lang. I will explain it later. Bakit 5 personnel na lang ang sagad na taas. Okay. So, yan yung sa box A. Pag na-down PPE, pasok ka doon sa ER kung doon nagka-arrest. Then, depende kung anong presentation. No? Pag sa CPR, sa BLS, check for responsiveness. Once the patient is responsive, activate code blue. Bago mag-CPR, ang emphasis ng BLS is protect the airway, the aerosolized expulsion of the expulsion of aerosols by covering it. Anong i-cover natin? Dalawa. Okay? Dalawa. Kung wala ka pang kasama, non-rebreather mask. Huwag kang mag-compress na walang non-rebreather mask. Hindi katulad dati, compress ka agad once nilagay ang cardiac board. Ngayon, hindi po. 3 delays po. The delay in putting down from the Trendelenburg, kung nakatrende, i-putting down doon sa CPR platform. 1, so few seconds delay, mga 2 seconds to 3 seconds. Pangalawa, umaabot ng 5 to 6 seconds, even 10 seconds delay ang paglagay ng cardiac board. Depende kung nag-iisa ka or dalawa kayo, malaki yung pasyente, may delay konti. So, yun ang delay. Ang third delay is paglagay ng non-rebreather mask kapag solo. Pero kung hindi ka solo, meron ka agad crash cart sa gilid mo na merong BVM, bag valve mask, or yung commonly tinatawag ng ambu bag. Well, you can put the bag before compression. The essence na hindi tayo mag-start ng compression is we don't like the aerosol to just, fly away. So yan po. So, In hospital, 30:2, pero merong hybrid. Ano yung hybrid? Pwedeng hindi mag-30:2 muna. Halimbawa, isang malayong ospital ka, wala ka ganong tao, yung crash cart, yung emergency cart mo, nandun sa kabilang ward. So, non-rebreather ka, CPR ka lang. Huwag kang huminto sa 30, tuloy-tuloy ka lang. Yun ang tinatawag na CCR, cardio-cerebral resuscitation. Hang pagdating, may airway ka na, dalawa. Tuloy ka lang. Okay? Stop. Lagay ako ng bagbal mask. Pag stop, remove si non-rebreather mask, bagbal mask on at 15 liters per minute. Start CPR ka. 30:2 na yan ngayon. Pero pag solo ka or compression, do not stop at magbigay ka ng hand. Hindi po ini-encourage yan. So, ganyan ang ating style. Okay. Ngayon, dito, habang nag-start CPR, so, do we have a team leader or not? So, assuming first to be on scene, ang style nito, habang nagsi-CPR ako, what's the return? So, kinakabitan ng cardiac monitor or pagkabit ng pads doon sa defibrillator, may nakalagay po. Lahat ng defibrillator may nakalagay na lead, L-E-A-D. Kahit gaano ka-high-tech yan, may lead. Ang default po doon ay lead Roman numeral 2. Okay? Lead Roman numeral 2. Bakit naka-Roman numeral 2? If I may ask, can somebody send me an answer sa chat? Bakit naka-Roman numeral 2? Pasagot sa chat. Walang sumagot sa chat. Ay, ay, ay. Walang sumagot sa chat. Okay. Naka-Roman numeral 2 yan kasi okay, tingin kayo sa akin. Tingin kayo dito sa camera. Assuming ito si heart, itong puti, kulay puti. Kulay puti para makita niyo. Kita niyo si puti. Yan si puti. Si black ako eh. dark background, puti. Ang left ko, okay, malito ha. My left, not your left, my left. Ang left ko, ang heart nasa center, papunta ang apex sa left. The apex, the dominant muscle, is from the left ventricle. Okay. Ito, kukulayan kong pula, ECG to, pero convert ko siya into a camera. Okay, may pula, nakita niyo pula. Oh, pula. So, ito si pula. Nakafocus dito. Okay? Blue na lang, si blue. Pag nakafocus dito sa gilid at 0, ang tawag dito 0 ha, mag-trigonometry ito, 0, 90. O, di ba? Trigonometry, naalala niyo? Kaya matakot sa numbers. Pag magaling kayo sa numbers, madali na kayo turuan ng ibang topic sa buong mundo. Pinaka-baseline numbers because the only constant thing on earth is the number. There are only 3 constant things in the world. 3 ha? Numbers. Pag sinabing 1 plus 1, hindi talaga pwedeng 3 yan. Tulang talaga. Number 2, mother's love. Number 3, death. Kamatayan. Those are definite. Death will find you even if you live in towers built strong and high. Okay. So ito 0. No? Dito 90. Ang limb leads ng ECG, yung Roman numeral 1, Roman numeral 2, Roman numeral 3, AVR, AVL, AVF, ay tumitingin sa side. Okay, tingnan natin to si 0 para makita nyo. Pula. Ganun ko para makita nyo pula. Okay, si pula. Tumingin dito sa 0. Ang tawag nito, Roman numeral 1, limb lead 1. Si limb lead 2, nandito at less than around 40 degrees, not 45, 40 degrees. Therefore, ang tinitingnan niya is mainly left ventricle talaga, ventricle, which is the most dominant muscle. Pag tiningnan mo ito, kasi dominant muscle, lahat ng depolarization ng area na babasahin ito, lahat positive yan. Kasi sa pinaka-influential ika nga, ang tawag dyan, dinosaurian complex or dinosaurian mentality. Kung sino yung pinakamalakas, siya yung hari. Yan. Tapos dito sa 90, si AVF, Augmented Vector Lead Pang-Foot. Dito si 3. Si 3. Dito sa itaas is AVL, dito si AVR. Huwag mo nang pakialaman taas. Si C1, C2. Si 2 kaya sa naging default lead, kasi halos makikita mo niya majority anong forma ng heart niya. Because si left ventricle, siya yung dominant. No? Ang tawag dyan, sa mentality, kung mag-aral tayo, hindi ko alam kung sociology yan, or psychology, or anthropology, is a dinosaurian complex. The biggest, the fiercest, is the leader. Yan. So leader ito, siya yung default kasi ang tinitingnan niya ay ang pinakamalaking muscle sa heart. Yan, ginawa ko ng simple. Oh, may sumagot. Dito only because it is a standard. Yes, it's a standard because of that. Okay? Tama ka doon, pero let's deep dive. Let's do a granular or molecular explanation. Because kung ito ang heart, ang pinaka-influential is the left ventricle. Siya yung pinakamalaking muscle kasi siya nagsusupply against even the gravity when it goes up. So, dapat malakas siya. Kaya dalawa ang innervation niya sa Purkinje. May anterior fascicle sa posterior fascicle siya. Para well-innervated pag-firing ng cardiac muscle. Kaya pag lahat, dahil siya yung mas muscular, ang tapon ng electricity ay mas pronounced sa kanya. Okay? So, siyempre, pag marami kang fibril sa muscle, mas marami kang cells, mas marami kang tubig. Pag marami kang tubig, mas marami kang ion. Pag marami kang ion, yung electrical influence mo ay mataas because your heart is also an electrical organ other than a mechanical organ and a chemical organ. So, heart is a display of 3 features: mechanical organ, chemical organ, and electrical organ. Okay. So, hinuk ko sa lead to, nakita na, nahook ko, kung manual tayo. Pagkita ko doon, ventricular fibrillation, so arresting heart yun, or pulseless ventricular tachycardia, so pwede ako mag-shock. Kung ayaw mo mag-automated. Nasa ER tayo, nag-override ka lang muna kasi konti tao, nag-automated mode ka. In-automated mo. No? So, ang machine magsasabi, analyzing. Huwag kang humawak sa pasyente, analyzing. Yan ang difference, ha? So, analyzing. Pero, kung ikaw mismo ang naghahanap ng rhythm, pwede mong gamitin yung lead. Ganito po yan. Kahit tingnan nyo ang defibrillator ngayon, ano siya sa lead to, naka-default. Pag pindot mo isa, lalabas po dyan sa upper left nyo, usually nasa upper left nyo. Lead 3, 3 guhit. Pag pindot niyo siya, makakita kayo ng square o makakita kayo ng pangalan paddles. Ibig sabihin, nagde-detect ng rhythm ang paddles o ang pads. Saan? Pag ilagay ko yung paddle sa dibdib, doon makikita mo yung rhythm. Ang paddles nagde-detect. Other than ang paddles nagbibigay ng electricity, meron din siyang kakayahan mag-detect. Pero kung hindi paddles ang ginamit mong pads, ang pads nagde-detect. Ngayon, pag ilagay mo sa 1, kung wala kang nilagay na mga cardiac monitor or cardiac leads or yung lines, paddles lang, walang magbabasa. Lagay ka sa 2, walang mababasa. Lagay ka sa 3, walang mababasa. Lagay ka sa paddle side, sa pad side, or yung square, nagbabasa yung pads. So, yan yung maganda sa defibrillator, yung mga bago ngayon. Although yung luma, ganun din. So, depende yan, sa rhythm, kung shockable versus non-shockable, kung ikaw ang nagbabasa. Now, assuming kasi hospital tayo, ako na talaga magbasa, sige, pakicheck nga ng rhythm. Sa paddles nga, so, chip mo paddles. So, titingin si team leader, titingin din si electrical therapist, titingin si compression. Hinto lahat Bentry, nabisaya ako, sorry, taga Davao Uy, BF, ventricular fibrillation. So, nag-agree lahat. Okay, let's shock the patient. BF, okay. Electrical therapist, go. Okay, charging to 200 joules. Charging now, 1 I'm clear. 2 you're clear. Clear si airway. Si airway, pinatay na yung oxygen. Clear. 3 everybody's clear. Sigaw lahat, clear. tingin sa screen, and shock. Boom! Pag shock noon, pag manual, ganito mangyari, sisilip muna lahat. May delay pag naka-manual kasi. Uy, BF para on screen. Continue CPR. So, lagay mo, CPR na, tapos bigay ka na ng drugs. Ngayon, ang pagkakaiba sa interim guidelines of 2022, prioritize si intubation. Habang nagre-resume si CPR, mag-intubate. So, larga mo na kasi siyempre, ano muna, magsasaksyon-saksyon ka muna. Pag ready ka na, hinto. Hindi katulad nung the recent past, ng mga 2015, 2016, nag-intubate kami na hindi uminto. Pabor din kasi makikita mo, bumubula yung bandang laryngeal opening eh. Doon mo na isuksok. May point na hindi kami huminto. No, ginagawa namin yun. Dati, hinto, intubate. Nung pagpasok ng 2012, may mga practices kami na hindi na huminto. Tuloy lang ang compression tapos intubate. No? Ngayon, hinto na. Bakit? Eh, siyempre, kawawa naman ang mag-i-intubate. Lipad ang aerosol sa kanya. So, ang nangyari, hinto, tapos intubate ka, be sure na makukuha mo siya sa tinatawag na first pass. Hindi first pass effect sa liver, ha? O, alam niyo ba yung first pass effect sa liver? Can anyone tell me what's the first pass effect sa liver? Nakalimutan ng ating ganong o gayton. Lahat ng kinakain natin, pati gamot, pag dumaan sa liver, sa cytochrome P450, hiwa-hiwain na yan. Sa terminology, hiwa-hiwain. Yung kanyang molecular configuration, bakbakan niya yan. So, ang kanya, kung gaano katindi yan, mababawasan pa. Kasi nag-first pass effect. Dito, sa intubation, pag sinabi natin first pass, sa unang intubate mo, pag silip mo, kuha mo na kaagad, hindi na pwedeng hindi mo kuha. Yan yung tinatawag ng first pass. So iba, wag kayo malito sa first pass ng kidney, ng liver, saka sa first pass ng intubation. Na-mention din itong first pass. Post chest compression for intubation. If intubation delayed, consider supraglottic. Connect to ventilator with filter when possible. Okay, hindi na-mention dito. Dito tayo titingin. Anong nangyari? Silipin natin, baka na-mention dito. Nabasa ko yun, na-mention yan eh. Okay, CPR. Advanced airway dito sa advanced airway. Ayun! So, palakihin ko para mabasa ninyo ha, para hindi nyo sabihin na nagmamarites ha. Sign natin. Ito ay minimize closed circuit disconnection, okay, as much as possible. Kaya pag nag-shift ka from non-rebreather to back valve mask, kung pwede, yung pinaka-port mismo, yun lang. Huwag na yung magpalit ka doon kasi maraming mga secretion ng pasyente na nadi-disturb natin. Ha? Use intubator with highest likelihood of first pass success. Yan, yung first pass success or first pass approach ay yung unang pagmalampati mo, mamaya explain ko sa malampati, anong malampati. Kuha mo na yung airway, glottic opening, insert mo na sa tube. Yan po ibig sabihin. Consider video laryngoscopy. Nagpa-order ulit ako kasi yung video laryngoscopy ko po, tinubuan ng paa, umalis, naglayas. Hindi na sinaulit so many years. Very good. Hindi pa na ang video laryngoscopy sa Pilipinas. Nagkaroon na po ako since 2005. I have a video laryngoscopy. Ngayon lang yan nauso sa COVID, pero matagal na po yung video laryngoscopy. Hindi lang maganda yung camera, pero malinaw na, medyo a little bit, hindi siya ganong colored katulad sa parang yung mga fiber optic na pero maganda yun. Na-enjoy ko yun siya. So, hindi na siya gumagana pangit na yung ginagawa ko lang, demo na lang to tell you that there is something pero during pandemic na uso dito sa Pilipinas, okay na. I'm not trying to, modesty aside, no. Nagkataon kasi, yung engagement ko sa trabaho ko, I'm a humanitarian doctor. I go in almost all continents for humanitarian action, lalo na sa hostile areas kasi yun yung training ko. Kaya yung exposure ko sa mga advanced na gamit ay nandoon. Gusto ko lang ipakita sa inyo or i-mustra sa inyo na medyo huli talaga ang Pilipinas when it comes to upgrades and updates of equipages. At mandatory dapat meron tayong capnometry which I will show you. Okay? Ano ang capnometry? Para malay mo, napunta kayo sa abroad, parang hindi na-abstract ang capnometry. Kasi napakaganda po ng capnometry. Mabilis siya kumuha ng respiratory status kumpara pag mag-rely lang ako solely sa pulse oximetry. Yan. So dito na lang ako sa mga boxes. No? So akyatin ko muna anong mangyari sa CPR. Kasi ito yung nadagdag. So sa CPR, halos pareho lang, nagbago lang sila ng linya, kinuha pa rin yung 2022, no? So dito sa box, first box CPR, no? Yan, basahin natin ha. Dati push hard, push fast at 100. Avoid interruption, adequate recoil, avoid hyperventilation. Ngayon binago pero nandun pa rin yung primary three. Push hard, no? At least 2 inches, no? And fast as 100 to 120 per minute. And allow adequate chest recoil. So yun ang number 1. Number 2, minimize interruption. Dati avoid interruption. Ngayon minimize kasi hindi talaga pwedeng hindi ma-avoid. 3, avoid excessive ventilation. Ito yung dinagdag sa 2020 para hindi mabugbog si ventilator, si compressor pala, is change compressor every 2 minutes. Every time kung mag-AED ka, analyzing, palitan na kaagad yun. Para hindi mabugbog. Kasi naka 2-minute run siya, nagkukompress siya ng dibdib. Ngayon, isa pang nanagdag, if na-introduce na yung advanced airway, ano na siya, asynchronous na. Pero pag hindi pa na-introduce, naka-BVM compression, 30:2 ang ratio. Pag na-insert na ang airway, kailangan may capnography ka or capnometry or yung end-tidal carbon dioxide detector. Anong ibig sabihin? Yung end-tidal carbon dioxide, sige, explain ko na lang pagdating sa airway. Tapos, intra-arterial pressure, kung pwede, no? Pag hindi, huwag na natin pakialaman. Tapos, sa ating energy, ang binibigay talaga is 200. Hindi na po tayo nagti-360 monophasic. History na po yan kasi pag mataas ang ating joules, mas nakaka-destroy siya ng cardiac cells, cardiac muscle. So binabaan into 200 joules, pero effectivity, ganun kasi dalawang pads ang sumisipa ng enerhiya. Kaya buy. Hindi katulad dati, isang paddle lang ang sumisipa at tatanggapin ng isa. Ito, in a sequence, fire siya, tanggap, tapos fire ang kabila, tanggap ng kabila. Ganon, palitan. So may mga delays yan in a millisecond. Okay? Then we go into drug therapy, still tatlo. EPI, dati 1:10,000 ang emergency dose. Ngayon, you can just give EPI, hindi na natin tinitingnan kung 1:1,000 or 1:10,000. Amiodarone is 150 times to pag emergency. Ang second dose niya, kung gusto mong second dose, is 150. Then Lido, at 100 milligrams yung available natin. Okay lang yun kasi ang kanyang dosing is 1 to 1.5. Bigla kang nagkaroon ng ROSC, return of spontaneous circulation, so pwede ka, titingnan mo ang pressure, titingnan mo pulse oximetry, titingnan mo ang PET ko kung umakyat na siya into more than 30, kasi ang normal end-tidal carbon dioxide pressure is 35 to 45 millimeters of mercury. Okay. Tingnan natin kung maganda ng hemodynamics, no? Intra-arterial monitoring, so on and so forth. Then, bantayan natin ang 6H. Dito kasi 5, 1, 2, 3, 4, 5. Tapos 1, 5 Ts. So, pwedeng 6H, 5H, or 6H, 5 Ts, or 6 Ts. So, ito yung ACLS. Ang buong ACLS is reversing this H and Ts. Okay? Question. Baka kayo na-shock na. Yan pa lang. Parang nahirapan na kayo sa ACLS. Question. So, anong pagbabago sa 2010? 2010 sa 2022. Ito lang. Usually, ito nangyayari dito yon. Nandito siya. Ngayon, inakyat. Halos, kung pwede, unahan mo si IV. Intravenous or intraosseous. Dito pa lang, prepare to intubate na eh. Yan. So, isipin mo, intubate mo na bago bigay ng epinephrine. Baliktad na ngayon, hindi katulad dati. Pero in reality, kung pwede mo pagsabayin dalawa, wala problema. Kung meron kang adequate team. So, it's not really black and white na do it in sequence. Pero ang emphasis, kailangan naka-integrate. Okay? So, same pa rin, no? Then, what do we do with, kanina, diniscuss ko lang to briefly. So, sa interim guidelines of 2022 ng American Heart, ito yon. Don't PPE before engaging. Pag code blue team ka, ito yon. Halimbawa, member ka ng code blue team, nasa meal ward ka, hindi ka naka level 1, hindi ka pwedeng rumispondi kasi ang expected humawak ng pasyente, pinaka-minimum is level 3. And 95 yun. Eh, nandun ka sa meal ward, naka-surgical ka. O, tapos, kailangan doon levels 3 and 4. Kung 4 ka, fully in caps, nakatago pati buhok mo, no? Naka-shield. So, hindi ka pwede. Yun yung ibig sabihin. Not because, even if you are pinaka-siga dyan sa ACLS, sa code blue, magaling ka. Pag hindi ka wala kang saktong PPE. Yun. Mag-PPE ka pa muna, bago ka tatakbo. O pagdating si air, mag-PPE ka, pero delay ka ng time. Limit personnel. So, i-discuss ko yan mga paano natin gawin na limit personnel. So, tinatawag natin Jaworski. Consider using mechanical CPR devices, yung tinatawag na CPR thumper, yung oxygen-powered na pang CPR. Okay? Then, gamitan natin HEPA filter, ang ating BBM, at saka yung ating ventilation, kahit naka-aircon tayo, pwede tayo maglagay ng HEPA filter. So, I will not really read like grade 1 or grade 5 students or on these changes na nilagay ko rin. Ito po yung bago. Ito po yung luma. Para makita nila kung saan, ano ang bariya. Ito yung luma. Ito yung ngayon, paano gagawin ang ACLS. No? So, luma to siya, pero gawin ko lang bago by prioritizing intubation. Pero halos pareho pa rin. So, ang unang drug na ibibigay natin, 1 mg, no? Or, ang pwedeng kapalit is amyo. Pinakamaganda talaga, epinephrine. Pwede mong bugbugin epinephrine siya. Pwede ka mag-epinephrine, amiodarone. Epinephrine, lidocaine. Pero kung gusto mo epinephrine, amyo. So, depende sa'yo. Wala tayong ano. Basta kailangan may max ka lang na, meron kang interval na every 3 to 5 minutes. Yan ang interval, bigay ka ng epi. Okay? Then, shock is biphasic, no? Ang default is 120, pero pwede mong iakyat pag naka-manual ka, ito 200. Meron akong special session with reversible causes, I will not be talking about. Ito yung iba-ibang klaseng AED. So, ito yung SOL. Yung military grade dito, yun yung meron ako personal. I hope na may mag-sponsor sa akin ng AED daw. Tingnan ko kung itutuloy nila. I'll start with tachyarrhythmia. So, ang tachyarrhythmia ay isang insidente, no, wherein your heart beats more than 150. So, mga baseline yan, 180 to 200. So, kung pabayaan ko ang heart nagbe-beat ng ganun kabilis at hindi ko siya i-reverse, you will be in your last 20 minutes of your life kasi mag-exhaust yung heart mo, mauubos yung metabolites. Parang muscle lang din yan. Na yung skeletal muscle. So, kailangan matugunan natin na, ma-reverse natin. So, titingnan natin paano natin i-reverse. Baka lang medyo abstract pa konti. Paano? Kasi hindi ko pa naturo yung ECG. Kasi meron tayong gagawin anong klase mga rhythm ang hinahabol natin yun. Although the most common one sa tachyarrhythmia is USB. So, titingnan natin ngayon. So, pag may tachyarrhythmia, ganito po yan. Pumasok ang pasyente, or ang pasyente admitted na, biglang nakita mo sa monitor, nagkaras-karas, ang tawag ito? Nagkaras, ang tawag ito? Sa Tagalog yun, sumirit. No? Sumirit yung return. Starting at 180. Assuming SVT. So, tingnan mo. Hook mo ang patient sa oxygen. Okay? Kuha mo blood pressure. Then, if you look at my cursor, hanapin niyo kung present to. Yung HASIA, H-A-S-I-A. Hanapin niya. Hindi siya rocket science. No? Meron ba siyang hypotension, meaning ang kanyang systolic is 90? And or, dahil kulang ang oxygenation sa brain because of karas-karas yung bilis ng ano, meron ba siyang altered mental status? And or, signs of shock, namumutla, or nagbubluwis yung lips? And or, kamag-anak nagsabi or ang pasyente nagsabi, may nakadagan sa dibdib niya, ischemic chest discomfort, parang masakit na may nakadagan. And or, may history ba siya ng acute heart failure? No? Or nakitaan mo ni heart failure? Pag yes, huwag na natin patagalin. I-sedate mo na yan para i-cardiovert. So, ituturo ko paano mag-cardiovert. Pilitin ko ituro na wala na akong cardioverter kinuha na. Pilitin ko siya, hindi available pictures on hand. Paano ginagawa? And habang nagsisedate ka, kunwari, ang ginagamit ko is midazolam. It takes time. Pwede ka mag-drive ng adenosine. Pero gusto kong ipaalala sa inyo guys, kasi ang adenosine ay ang pinakaunang drugs. Kailangan pag nag-intravenous tayo or intraosseous kayo, automatic po, meron kayong three-way stop ka. Kasi ineffective ang adenosine pag walang three-way stop ka. Kasi mamamatay siya sa red blood cells mabilis. Kailangan pag binigay mo si adenosine, masipa mo siya kagad, matulakan mo kagad ng NSS, mabilis. Kasi 3 seconds lang ang buhay niya. Ituturo ko yan. Kung hindi pa kayo nakadrive ng adenosine, kasi siguro pag may SBT, ang binibigay niyo, verapamil, kasi I will not be shocked kung sasabihin niyo, ayaw ko ng adenosine. Normal. Pero pinakamaganda po, adenosine. Ang ayaw lang natin sa adenosine, mahal. Maiksi ang shelf life. Pangalawa, pag binigay mo, komplikado kasi kailangan mabilis. So yan o. Pero, assuming na wala ka nakita na HASIA, wala ka nakita ng hypotension, altered mental status, shock, wala yun. Tingnan mo anong klaseng QRS. White QRS ba? Ibig sabihin, yung small boxes, pinaka-smallest no, sa ECG, lumampas ng 12 small boxes or 0.12 of a second. Kung hindi kayo nakakaintindi, mamaya pagdating sa ECG, papaintindi. Pag white QRS, pag yes, well, you can still give your adenosine. Adenosine pa rin. No? Sikat talaga si adenosine. Lalo na kapag regular siya at saka monomorphic isang forma. Okay? Kasi kapag polymorphic yan, mas maganda na si amio or si lido or ibang drugs, beta blocker pag hindi bagsak BP. No? Huwag tayo adenosine, lalo na pag polymorphic. I'll discuss what's polymorphic and monomorphic. Pero narrow QRS siya, well, adenosine is still kung walang adenosine, verapamil will do it. Verapamil pa lang, happy na ako. So, pwede mo baka pa ng amil. Tinatanggal ko lang, kasi ang hirap ng Zoom, may mga pop out. No? So, IV access, 12-lead ECG, vagal maneuver, kung marami pa sa atin, hindi tayo gumagamit ng ultrasound. No? Meron kasi ako nasa kabilang bahay. Subukan ko gamitin pag tayo bukas, pag nag-code blue, kunwari, gamitin ko yung ultrasound ko. Although portable siya. May portable ECG ako, may portable ultrasound. Yan na kasi yung stethoscope of the future. So, although pag hindi ka sanay, mahirapan ka maghanap ng kasi maganda ultrasound sa mga hollow viscous. When you, like the fluid filled environment. Kasi kung nagkadikitan yung mga muscle, halos wala kang makikita sa kanya. sanay ka lalo na mag-pericardiocentesis, which I will perform tomorrow. Merong ultrasound guided sa hindi. Now, where am I? Dito sa narrow QRS, pag nakakita ka SVT, no? Narrow QRS, yun ang si SVT. Anong tinatawag ng vagal maneuver? So yung vagus nerve po, mapapansin natin yan, may innervation yan dito sa carotid. Kaya meron tayong tinatawag na waiter syncope. Yung waiter, alam niyo mga waiter? Ang waiter, ganito yung kanilang collar, ganyan. Yung collar. So habang naglalakad yan, nagkikiskis yan sa leeg. Pag nagkikiskis sa leeg, nagkikiskis nila yung tawag nitong vessel na to. Carotid. Nandun po si vagus. Si cranial nerve number 10. Pag na-stimulate mo siya, ang nangyayari, binababa niya ang chronotropic action ng heart mo. Negative yun, negative chronotropic. Babagsak. Kaya ang pasyente nahihilo, ang tawag, mga pasyente, ang waiter nahihilo, kaya ang tawag doon waiter syncope. Because of that. So ngayon, imamassage ko yung isang side ng carotid artery to do a vagal stimulation. Pero ganito po yon, hindi po pwede pong gawin yan kung wala kang testing. Ite-test mo muna gamit ang stethoscope. Gagamitin mo yung bell, pakinggan mo, left and right. Pag nakarinig ka ng carotid bruit, huwag mo siyang i-massage. Kasi most likely baka aneurysm yun. Minasage mo siya, sumabog yung aneurysm, naku, Diyos mio. So, assuming negative, minasage mo, makikita mo yung SBT, bumabagal, as in. That is definitive of an SBT. So, ginawa mo yon. Pero it does not mean it will reverse. Siguro, for freak reason, baka pwede na. Pero sa tanang nagawa ko, hindi ako naka-reverse. Bumabagal lang. Bumabagsak lang yung rhythm. Tapos, maya-maya, babalik ulit. Bilis. Then, you can say, SBT nga. Yan. Then you can give adenosine or amiodarone or a beta blocker or a calcium blocker like verapamil. So yan yung tachyarrhythmia. Okay? Question. Before I will move out. May tanong? Kung tachyarrhythmia? Wala. So I'll move to the next slide, which is the opposite. Yan lang yung gamot. Sorry, itong gamot. By the way, pag nag-cardiovert tayo, guys, ito pala yung breakdown. Pag nag-cardiovert tayo, meron tayong mga certain joules na umubra. Kapag napakaganda, narrow siya, tapos isang forma lang, regular, you can even cardiovert it starting at 50 joules. Mare-reverse mo na yan. Pag narrow, pero irregular siya, 120 to 200 joules. Pag wide QRS, ibig sabihin more than 3 boxes, small boxes, we can start at 100. Pag wide irregular, defibrillation na po yun, hindi na po cardioversion. So adenosine, ang ating dosing, no, para siyang vial, amber vial, is 6 milligrams. Second dosing is 12. Follow with NS plus as in. Yung NS plus ko, napakabilis dapat. Pag may mga anti-arrhythmic infusion, no, assuming stubborn siya, you can go into procainamide. Pero, tingnan niyo ito, 20 to 50 mg per minute until arrhythmia is-suppress, tapos merong hypotension. Yan lang yung ayaw ko sa procainamide kasi meron siyang hypotensive effect. Okay? Now, amiodarone, 150 ang ating dosage. Sotalol, ito yung mga third tier, parang procainamide, third tier namin to, third or fourth tier. 100 milligrams mo over 5 minutes. Now, let's go into bradyarrhythmia. Ang bradyarrhythmia, nangyayari yan kapag meron kang heart block. So, katulad ng second degree heart block, type 2, tapos pangit siya, bagsak ang BP, bagsak ang pulse ox, yan na yun. So, kailan tayo pag pumasok yan, less than 50 ang heart rate natin, tingnan natin ano ang presentation ng patient. So, ilagay natin siya, lagay natin ng oxygen muna, may isang kanila, tapos cardiac monitor, lagyan kagad ng IV. Ganon din sa tachyarrhythmia. Tapos 12 lead ECG, minsan nagre-request pa kung may time, may x-ray pa. Alamin natin kapag may hasiya ulit, is there hypertension, is there altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Pag wala naman, i-monitor natin anong dahilan, bakit bagsak ang ritmo. No? Pag yes, we can drive atropine 1 mg. So si atropine, pwede mo siya ibigay hanggang 3. So bigay ka, wala. Bumagsak, umakyat, wala ulit. Bigay ka ulit. Pag nakapangalawa, hindi ka pa rin happy, mag-isip ka ng ibang drugs. Pwede ka, kung ayaw mo mag-transcutaneous pacing kasi wala kang capability ng ganon, pwede ka mag-dopa. So dopamine at bago na ngayon ang dosing, 5 to 20 microgram per kilogram per minute. Hindi katulad dati, meron kami tinatawag na 1 to 5, which is the renal dose, 5 to 10, which is the cardiac dose, and 10 to 20, which is the vasopressor dose. Ngayon, hindi na po, tinatitrate na lang natin kung paano natin paakyatin ang rate. Sorry, I have questions. Well, yung modified Valsalva, yes, other cardio, they want to do it. Sa ACLS kasi, hindi. Kasi kailangan sustained ang you have to stop it right away. Kaya mainly, dalawa ang ginagawa mo. It's either chemical cardioversion or electrical cardioversion. Yung modified Valsalva is some sort of a parang mechanical cardioversion, hindi tayo doon. No? So, yung program lang is mainly chemical and electrical. So, kung gusto niyo ng electrical cardioversion, explain ko bakit tawag sa kanya cardioversion. I will discuss it pagdating natin sa electrical therapy. But that's a very good question. Kasi may mga gusto mo na mag-perform ng modified na Valsalva. Saglit meron lang emergency call. TBI. Traumatic brain injury. Saglit guys, saglit lang. "61 years old. So again, sorry, sana ba ako? Sa bradyarrhythmia. Okay, balikan ko lang yung kanina. So, sa ACLS, hindi gaano natin yan. How about itong modified Valsalva? Kasi una, medyo tedious kasi gawin yan No, you have to instruct patient. Kung meron siyang, sabihin natin, may altered mental status, hindi maka-cooperate, signs of shock. Kasi meron yan mag-recumbent ka, tapos mag-force, parang i-force exhalation mo, tapos position kaagad supine, leg raise pa, mga ganun, na masalimot. Pero, it does not convert it in a manner na tuloy-tuloy siya na hindi na siya mag-SVT. Hindi. So, kung gusto mo talaga para hindi mapagod na yung heart, diretso mo na. It's either chemical cardioversion ka or electrical. Because Valsalva is called a mechanical cardioversion. Yan. So I hope I answer. So balik tayo sa bradyarrhythmia. Sa bradyarrhythmia, ayan, upamin tayo, titrate tayo, pwede ka rin mag-epinephrine, pero I'm not comfortable with epinephrine kasi isang beses na ako nakakita, ginawa ng South African saka Egyptian doctor na nag-epidrip sa isang brady. Pero hindi ako naka-hands-on. Nag-assist lang ako. Kaya hindi wala akong confidence. Ang nagawa ko lang sa tanang buhay ko is nag-pace ako, nag-pace ito, I will discuss pacing. Nag-dopa. So, depende yan kung anong klaseng presentation mo, kailan ka mag-NOR-E, NOR-A, noradrenaline, NOR-epi pala, NOR-epi, kailan ka mag-DOBU, DOPA. So, doon at sasagutin natin konti yan doon sa pagdating sa pharma. Okay? Dito, pacing. Pacing is considered sa class of recommendation as type 2 kapag in-address natin siya sa cardiac, sa heart block, second degree heart block type 2 or second degree or third degree complete heart block. So, naging 2A siya. Pero pag transcutaneous pace ka dati kasi pinipace nila yung asystole. Ngayon, hindi na po kasi class 3 na po yun. Or class 4, kung may class 4. The worst talaga na. Hindi na po. Dati, 2010, pinipace po ang ang asystole. Now, no. So, paano natin pinipace? So, ang pasyente pinapatulog ulit. It's either nilalagyan natin ng pads dito, apex, sternum, or anterior posterior para sa pedia. So, pinipace natin siya. I will describe it doon na sa electrical therapy ay ito i-preempt. Okay, so yan lang ang ating bradyarrhythmia. Then we go into return of spontaneous circulation. Hindi ibig sabihin na buhay natin, okay na yan. Ano ba ang kanyang hemodynamics? Mabagsak pa ba ang kanyang pulse oximetry, ang pressure, hindi maabot ng 90. Kailangan ang saturation natin, paakyatin natin ng above 90. Tapos, pwede ka, kung hindi ka naka-airway, pero nabuhay ang tao, pero parang binggit nasa dulo, nasa edge pa rin siya, you can still perform advanced M. Okay? And kung hypotensive siya, pwede ka mag-fluid challenge, no? NSS can do the job. Pwede ka mag-vasopressor infusion. Okay? Tapos hanapin mo si HMTs, yung tinatawag na treatable causes. Tingnan natin, baka merong MI, hindi talaga, kung cause niya ay post-MI ka, kung nandun pa si STEMI mo, kung malayo ka pa sa ospital, katulad ko, na may STEMI ako, unstable siya, napilitan ako mag-streptokinase. Although, pinaka-lowest of its kind siya among pang-kontra sa clot, pang-tanggal dun sa ano. Pero yun lang yung kaya kong dalhin. Kasi medyo mahaba ang buhay niya pag nasa labas siya ng ospital. I mean, walang ref. Straight, katulad ng ibang fibrinolytics na pag hindi ma-refrigerator, laglag. Patay ka agad yung gamot. So, tingnan natin, no? Although itong area na to, usually nasa ICU na to. Kaya si ACLS sa manual, ay sa libro niya, hindi siya nag-deep dive dito. So, anong ginagawa natin? Kailangan ma-achieve natin ang 92 to 98 oxygen saturation. IV bolus, normal saline or like LR, 1 to 2 liters. Ito, naging 2A, 2B to, induced hypothermia. So, nag-freeze ka po ng NSS at 4 degrees centigrade. Tapos, i-drive mo siya sa pasyente mo, lalo na post-stroke. So, may nakitaan silang study na nagpe-preserve yun at nakakatulong sa recovery. Pero, naging 2B siya. Kaya ngayon, halos hindi makapagsalita wala ganong literature si ACLS 2020 on this. Hindi siya gasing haba. No? Dati na medyo sumikat to sa US. Epinephrine infusion, I'm not so comfortable with this because I haven't done it personally myself. Ang nagawa ko lang is DOPA and NOR-E. Sa Pilipinas, meron din tayong DOBU. Sige, isama ko. Pero sa ACLS, hindi halos gumagamit ng DOBU. Now, let's go into stroke. Nabanggit ko kanina sa BLS, Cincinnati Pre-Hospital Stroke Scale. Sagutin ko lang konti. Yes or no lang. Okay, sorry. So, Cincinnati Pre-Hospital Stroke Scale, itong FAST. Pero nag-revise sila, hinalo si B-FAST. So, parang hindi lang monopoly ni Cincinnati. So, B is the patient may nawalan ba ng balance biglaan and or nag-brain fog ba siya and or nag-behavioral change biglaan na and or eyes, nag-blurring of vision and or may facial asymmetry and or merong arm and leg weakness or drop or droop and or speech difficulty or tinatawag natin slurring of speech. Pag out of hospital ka, please bring it to the hospital directly. Ang hinahabol natin, ma-preserve natin yung mga brain cells na nabarahan. No? So, ganyan. Pero pag in-hospital, activate stroke team. So, anong ginagawa natin? Okay? Dahil ang American Heart Association, ang emphasize niya is mainly pre-hospital care. Mapapansin nyo, critical EMS assessment. EMS stands for ambulance, emergency medical services. Yan po yung mga ambulance logistics ninyo. Tao gamit ambulansya. So anong mangyari? Doon pa lang pagkuha sa bahay, meron tayo dito sa kaliwa, ito yung time goals natin. Pag pick up, takbo na ang metrohan. Tumawag ka, that's the start of the problem. Okay? Pero, dapat 10 minutes nasa ER ka pag nasa ambulansya. Huwag 10 minutes galing sa bahay nyo. Malabo yun. Eh kung yung ambulansya malayo pa, it takes 10 minutes. Tapos 10 minutes to hospital, 20 minutes, kawawa naman si ambulance. So, ang tick-tock of the ambulance to the ER must be 10 minutes ideal. Yun yung dapat, which does not happen in the country. Sa loob ng ambulansya po, bigyan na natin siya ng oxygen, mag-perform ako ng Cincinnati Pre-Hospital Stroke Scale, kuha ko ng glucometer, tingnan ko yung glucose para make sure hindi to hypogly. Tapos tatawagan ko po yung stroke team or stroke center, kung hospital stroke center po siya indoors. Tapos, yan, alert yung stroke team. Ngayon, pagdating sa hospital, ang ideal, tingnan nyo rito, 10 minutes. Pagdating sa hospital sa ER, 10 minutes again. Grabe no? Grabe ka stricto, ang tindi ah. So sa 10 minutes, kailangan na oxygen siya ulit, 12 lead ECG, nakunan ng dugo, lahat na perform to, check glucose, RBS, nagawa to lahat. So may 20 minutes ako nangyari. After that, dapat within 20 minutes sa ambulance saka sa accident and emergency department or AED or ER, kailangan ay mahatid natin siya to CT scan. Ayan. So pagdating sa CT scan, ayaw mag-roll. Ayan. Titingnan natin kung siya ba ay may hemorrhage o wala. Pag may hemorrhage, ayaw nyo. Kasi mas pangit. Dito tayo sa no hemorrhage. So, i-contemplate natin for fibrinolytic therapy or merong fibrinolytic inclusion. Baka may mga traumatic brain injury to dati. May recent lang. So, yan mga kinoconsider. So, candidate ba siya for fibrinolytic therapy? Now, ang ina-achieve natin, bakit natin na CT, tapos happy tayo pag kasi within 1 hour, papunta rito, dapat na-desisyon na natin ang tinatawag na 3 hours na nakapagbigay tayo ng mga antiplatelet treatment or RTPA kung depende. So, candidate siya, 1 hour max. And 1 hour to 3 hours dapat biniibigay tayo after the stroke assessment. So yan lang po ang programa ng stroke. Pero pag hemorrhage, medyo maraming dadaanan siya sa stroke pathway. Kailangan matransfer sa ICU pa. Although ito lahat ICU naman, maraming pwedeng gawin dito. Mas masalimuot pag sumabog kesa sa bumara lang. Now let's go into ACS, acute coronary syndrome. Acute coronary syndrome ay sumakit yung puso, tapos makita natin sa ambulansya ulit ginamit yung MONA. Ano yung MONA? Morphine, oxygen, nitroglycerin spray or sublingual tablet of 0.4 to 0.5 mg or aspirin 3 to 5, chew it. Chew. Yan ang hindi ko po gayang gawin, ang mag-chew ng aspirin kasi nung maliit ako, mahuhuli niyo na edad ko. Pag nilagnat po kami, wala pa po kaming paracetamol. Aspilet po pinapainom namin. Diyos mio, pag pinapainom sa akin, dinudurog nila, nasusuka ako sa pait. Ayaw ko siya. Kaya, masama ang paningin ko pag aspirin. Ngayon, nandito ako sa ambulansya. Two things will happen. Pwedeng dumaan sa ER, pwedeng bypass sa ER, diretso sa cath lab. So, depende yan. So, sa cath lab, doon, diretso, kung ano ang gamot meron sila, bala na yung cath lab specialist. Pag dumaan sa ER, ito yung mga gagawin. No? Siyempre, walang x-ray. So, magdadagdag silang x-ray. Okay? Kuha ng cardiac enzymes or yung cardiac markers. Tapos, tingnan natin, ano ang ECG? Ay, bakit ganun? ECG. So, ano titingnan ko sa ECG? ST elevation MI ba yan? O kung ST elevation MI, mas makakaporma ako. Meron uling time frame. Pag unstable angina, non-ST elevation MI, marami pa akong pwedeng gawin. No? And then ito yung low intermediate risk na ACS. Series of evaluation to prove na hindi siya cardiac in origin. So dito ako sa ST elevation MI. Pag less than an hour, no, from the time na nagreklamo siya hanggang time na sa ospital siya, pag less than 12 hours, kaya natin i-reperfusion goal, submit for PCI. Okay? Pero pag more than 12 hours, i-consider natin siya as unstable angina. Ito yung ating gagawin sa kanya. Depende sa neurosurgeon kung ano, neurosurgeon sa cardiologist kung ano pwede gawin dito. Vis-a-vis ano yung presentation sa x-ray plus depende sa status ng pasyente. So, meron tayong mga selection of mga what to do. Ngayon, 2020, emphasis nila CPR. So, pansinin natin, good CPR. While the cold blue, darating. Na-hook mo sa capnometer. Ganito po yung capnometer. Ang minimeasure ng capnometer is yung part ng tidal volume yung panghuli. Kaya ang tawag is end-tidal carbon dioxide. Bakit po end-tidal carbon dioxide? Okay, ganito yan. Ha? Imagine niyo ang kwento ko sa inyo. Ha? Ang minimeasure niya is carbon dioxide. Kailan ang totoong carbon dioxide? Ang totoong carbon dioxide lalabas doon sa end part ng tidal volume. Nasaan si tidal volume? Kung maalala niyo yung respiratory physiology ninyo, meron tayong total lung capacity. Yung nasa gitna, na TB, tidal volume, ito inspiratory reserve volume, dito naman expiratory reserve volume, residual volume, ganyan, no? Functional residual capacity, FRC. Yung gitna doon, merong wave. Yan po yung tidal volume. Yan yung hinga, inhale, exhale mo. Yung usual. Hindi ka nag-deep inhalation. Yung usual lang. Ngayon, kayo nakikinig kayo sa akin. Pag inhale ninyo, yung oxygen, ilang percent ng oxygen available sa atmosphere? Pakisagot sa chat. Hindi tayo mag-snap. Hindi nyo sagot. Kahit magalit si Ma'am Joy sa atin. Sagot. Huwag kayo mahiya. Kung mali, ilang percent ng oxygen ang ini-inhale nyo ngayon? Ha, 20, 22, 21, 21. So, sa 21 na yan, kaya nang bumuhay ng tao. Pag nag-exhale ako, ilang oxygen percent ang in-exhale ko? Ang inhale ko 21, ang in-exhale ko ilan? O, sagot. 16, very good. Ang tanong ko ngayon, 23. Ikaw talaga naman, niloloko mo. 21 ininhale ko, tapos 23 ang ilalabas ko. Paano nangyari yun? So, 16, tama. Ang tanong ko ngayon, ito talaga yung tanong ko. Akala ko ba carbon dioxide ang ilalabas ko? Bakit ako mayroong 16? Why o why? Yes, sagot. Bakit? Ako lang sumagot. Okay. Sige. Nawa naman ako. Sige. Wala nang sumagot. Ganito yan ha. Tingnan nyo ako. Nag-inhale ako ng hangin. Tingnan nyo ako sa video. Tingin. Huwag kayong mag-ano. Nag-inhale ako. Ang air na inhale ko pumunta sa alveolus. Alveoli kasi marami. Yung pumunta sa alveoli, kinuha ng blood vessel by virtue of passive diffusion. Kinuha niya. Paano yun ngayon yung oxygen nasa bronchus, nasa trachea? Paano yun? Wala. 21 pa rin. Ang nangyari doon sa alveolar area, may carbon dioxide na. Pag exhale ko ngayon, ang unang lalabas ay yung nasa trachea. Oxygen pa rin po yun. Pero siyempre, maghaluan lahat in a very fast manner. Mahaluan siya ng carbon dioxide, kaya bumagsak siya ng 16. Ang tawag po niyan is anatomical dead space. Ibig sabihin, walang nagpalitan. So the last part of my tidal volume, okay, huminga ako. Umakyat, pag-isip ko siya. Yung last part ng tidal volume, galing na po yun karamihan sa, doon na po mainly galing yun sa alveoli, carbon dioxide na po yun. Yun po yung minimeasure ng capnometer na presence of carbon dioxide. Kaya ang tawag sa kanya, FCO2, end tidal carbon dioxide detector. Yan, maintindihan nyo. So ngayon, dito, kita natin, uy, wala pang intubation, so hindi ko makabitan ng ano. Biglang nag-intubate ako, kinabitan ko ng capnometer. So pumalo siya ng during CPR, 10 to 12. CPR ko, magandang CPR ko, akyat siya ng 12.5. Biglang nabuhay siya, so akyat siya ngayon ng 30 plus. Pero sige ka CPR, ganito pa rin, 30 minutes ka ng CPR, ganyan pa rin. Huwag mo nang i-CPR, patay na yan. Ibig sabihin, yung mga cells cannot anymore produce carbon dioxide. Ibig sabihin, ladies and gentlemen, according to American Heart Association, ang taong patay ay hindi tinitingnan yung mata, yung gano'n-gano'n natin, naalala natin, yung gano'n, kung tinitingnan natin ang patay sa konteksto ng American Heart ACLS ay capnometer. Pag hindi na umakyat yan sa 10 to 12, ibig sabihin wala ng carbon dioxide. Ano ang ibig sabihin? Bakit may carbon dioxide? Ha? Ano ibig sabihin? Sagot. Carbon dioxide. Sige, sige. I-guide ko kayo. Ano po? I-guide ko kayo. Krebs cycle. O, anong nangyari? No exchange, wala ng air exchange. No. No. Ang carbon dioxide, guys, ang presence of carbon dioxide, binigyan ko na kayo ng clue sa Krebs cycle po. Di ba naalala natin, noong tayo'y college pa, yung Krebs cycle ay nangyayari yan sa mitochondria. Di ba? Sa Krebs cycle, isa-summarize ko lang, yan po yung parang it's a cycle eh. It's a circular series, no? Kung saan nagre-react yung tatlong kinakailangan niya. Ano yun? Yung oxygen 21, yung sugar, yung glucose, CHO, at yung water, H2O. So, kaya tayo buhay, kasi merong H2O kang kinukuha, may oxygen kang kinukuha, plus meron kang glucose na kinakain. So, glucose is just available in all foods that you eat. So, ang nangyayari dyan, meron tayong metabolism, no? Yung acetyl-CoA, yung AC-CoA. Oh, saglit, may sumasagot. Krebs cycle releases CO2. Yeah. That's true, no? So, explain ko lang. So, yung mitochondria, mini-metabolize yung acetyl-CoA. Ang nangyari sa acetyl-CoA na yan, magpuproduce siya ng dalawang CO2, molecule ng CO2. Hindi mangyayari si CO2 kung walang O2. Okay? So, carboxylation po yun. Ma-attach yung carbon, kaya carbon dioxide. No? So, ang mangyayari si CO2, meron siyang resultant production ng isang molecule of GTP. No? Yung GTP, yan yung kasama sa GTP ay yung NADH mo, tatlong molecules ng NADH, isang molecule ng FADH, no? So ito yung kaya kayo ay buhay ngayon at ngayon ay nakikinig sa lecture na gumugulo sa isipan nyo. Bakit pinag-uusapan natin si acetyl-CoA, si GTP? Si GTP po, ang equivalent po niya is si adenosine triphosphate, no? Doon sa when we talk about energy. Kaya tayo nakikinig, kaya ka nakikinig sa akin ngayon at ako'y nagsasalita because nagpo-produce siya. Gumagana ang Krebs cycle ko. Ngayon, pag nakita natin si capnometer, wala nang mabasang carbon dioxide, ibig sabihin, Krebs cycle is not happening in my body anymore. It means to say that I am already dead, ladies and gentlemen. Kaya kung gusto nyo malaman ang tao buhay patay, i-capnometer mo siya. So, ibig sabihin, yun yung ACLS, American Heart Association Protocol. So, ito, dito ngayon sa cursor ko, diyan siya na-maintain, ganyan lang siya, intubated, CPR, epinephrine, shock, CPR, nag-flatline, CPR. Naku, Diyos mio, 30 minutes na ganyan pa rin. Hinto ko na. Lahat ng HMT, tinugunan ko na, i-reverse ko, ganyan pa rin siya. Oy, ladies and gentlemen, let's give respect to the individual. He is tired of living. Ibigay na natin the honorable death. Wala nang umakyat sa millimeters of mercury day. Hindi na umakyat ito 10 to 12. Ayaw nang mabuhay ng cell. Ang pagkain po ng cell ay oxygen, water, and glucose. For the carboxylation, ang tinatawag nating Krebs cycle. O, naalala na si Krebs cycle sa mitochondria. Pagod na si mitochondria, patay na siya, patay na si cell. Pag patay na si cell, patay na si tissue. Patay na si tissue, patay na si organ. Patay na mga organs, patay na tao. O, di bigyan natin ng karangalan ng kamatayan. Ibig sabihin, the best si capnometer kasi siya yung magsasabi. Oops, halt na. Okay? Ayan si capnometer. Ganyan lang siya kaliit at sobrang mahal yan. Ganyan ako ipakita sa inyo, sinira ng kaibigan ko. Eh, nainis ako. So ngayong panahon, may capnometer ka na, meron ka pang HEPA filter. So ako, ang nilagay kong HEPA filter ay dito para hindi madumihan sa capnometer ko. Dito ko siya ilalagay bago yung tube. So humaba ngayon. So yan si capnometer. Ito yung ACLS training ko na kung saan ina-accredit ako ng US. Okay? So that's that's the main element there. Ngayon punta tayo sa hypovolemia, sa H. Pag hypovolemia, anong gawin natin? Fluid resource ka. Bigay ka ng blood pag may loss of blood. Okay? Pag hypoxia, airway management ka. Taasan mo si oxygen, taasan mo FiO2. Pag hydrogen ion, karamihan sa Pilipinas, nagsosodium bicarb. ACLS po, airway management din. Pagandahin mo yung oxygenation mo, magre-reverse ang metabolic acidosis mo. Hypoglycemia, bigay tayo ng D50-50 or IV dextrose. Hypokalemia, pwede tayo mag-IV magnesium or potassium chloride. Hyperkalemia, marami-rami, calcium gluconate, calcium chloride, kayexalate, pwede tayo mag-insulin glucose, no? Tandem. Of course, pinakamaganda is dialysis. Hypothermia, external, corporeal rewarming. Pag tension pneumothorax, ituturo ko tomorrow paano mag-needle decompression, cardiac tamponade, paano mag-pericardial synthesis, toxins, anong mga antidotes, hindi ko maturo kasi sa napakaraming toxins. Thrombosis, kung yan ay pulmonary, anong fibrinolytics, kapag ACS, pag cardiac, anong gamot ang binibigay natin, lalo na sa STEMI. So, ganyan lang po tayo. Ngayon, ito sa hypoxia. Ma-maintain lang natin, partial oxygen 75 to 100 mm per mercury. Okay? So, pwede tayong hypovolemia, i-discuss ko yan pagdating natin sa IV lecture. Hydrogen ion, IV pa rin. Airway pa rin. Although, pwede tayong mag-sodium bicarb. And yung ibang H and T's, i-discuss ko na lang. Sa H and T's mismo. So, ito po ang ating code blue. Dati, 1, 2, 3, 4, 5, 6. Ngayon po, ang allowed po ay 4 to 5. Sinong mawawala? Mawawala po si documentation, which is indigo. Mawawala po to. Ay, sorry. Mawala. Anong nangyari? Okay. Mawala to, nawala to, mawala to. So, 1, 2, 3, 4, 5 pa rin. Ni 6. Kung 4 lang, ang team leader mawawala. Kasi si team leader is either IV siya or electrical therapy siya. Pag electrical therapy siya, ang magpapalit si IV, saka si compressor palitan. Pero pag IV siya, ito magpalitan. Huwag mong ipa-compress si team leader. Tandaan niyo yan. Kasi team lead siya yung oversee. Kailangan ng team leader, ideally, nasa paanan. So, dito siya banda. So, pinaka-ideal is, kung minimum ka, ang tawag po dito, Jaworski. Anong Jaworski? Playing coach. Dati si team leader, wala siyang hawakan. Mag-i-instruct lang siya dito sa 5. Ngayon, dahil minimal 4 tayo, siya yung mag-IV, IO. Or siya yung defibrillate, green pala. Siya yung defibrillation, si compressor sa si IV, palitan lang yan. Si IV maging compressor, si compressor maging IV guy or drug guy. Okay? Pero kung umabot ng 5, okay pa rin. Wala lang to, si team leader nandyan. Wala siyang gagawin. Ito, naglilibuter lang tong tatlo na to kung sino. Okay? So, I'll give you break for a while bago ako mag-lecture ng ECG. So, we will have, the next topic is ECG. Okay? Alam ko, medyo mabigat na. Tiisan nyo lang ngayong araw sa first few moments in the morning kasi puro lecture siya bago tayo mag-practical. Unless you have any question. Kung walang question, break tayo. I'll give you around 7 minutes break. Tapos, magle-lecture na ako ng ECG. Kasi alam ko dito sa ECG, medyo graveyard to ng karamihang tao eh. Okay? Tapos, after sa ECG lecture, kung may exam, tapos may lecture ulit ako, depende, baka fluid or oxygenation, so depende. Tingnan na lang natin. Sige? 8 minutes break.
8 hours bago to. Ano, alas 8 to, yun yung ano, IV. Alas 8
Tinapang. So our next topic is one of the Waterloo in ACLS. Kasi ideally, tatlo po yung exam. No? Pag American Heart, tatlo po yung exam ng ACLS. General ACLS yung nilecture ko kanina, tapos ECG, tapos Megacode. So yung Megacode actually is not exam, it's a practical one. Practical, ano ba? So dalawa yung written, yung General ACLS, saka ECG. Tapos naabutan ko yung sa training namin, 20 ECG reading, pag nagkamali ka isa, yun lang yung allowed. Sa 30, nagkamali ka dalawa. Pag nagkamali ka ng tatlo, meaning 27 ka lang, uulit ka sa ECG yata, ECG and ano? Ano ba yun? Nagkamali ka sa Megacode, ulit ka sa Megacode. Magkamali ka sa General ACLS program, ulit ka sa buong ACLS program. Mali ka sa ECG, you cannot perform Megacode, ulit ka sa ECG plus your Megacode. Magkamali ka sa Megacode, Megacode ka lang. Parang ganun din sa amin. But anyway, so welcome to ECG session. Kahit 2003 yung slides ko, wala naman nabago sa ECG. Machine lang nagbago. So ano klase, paano tayo magbasa ng strips? Although kayo, ang binabasa niyo plate na, no? Hindi na, ano. Hindi katulad sa amin na strip talaga na napiprint out using the thermal paper. Kayo, computerized na lahat, pwede na sa cellphone lumalabas. Ako nga, pag tinatanong ako sa ECG reading, pinipicturean lang, binabasa ko dito sa bahay, yun, ang ganun na, no? Hindi katulad dati na, wow. So things are quite easy right now. Since your heart is an electrical organ, meron siyang electrical pathway. So the primary pacemaker of the heart is called the SA node. Tapos sa SA node, merong AB node. Saglit, sorry saglit. For a while. Okay, grabe. Difficulty of breathing na. Tapos yung isa, inayos ko lang yung nag-reinsert ng NGT. Ay. Hirap ng doktor sa barangay. Sorry for the interruption. Okay. So, may electrical pathway tayo, SA node, then AB node, bundle of His, Purkinje system dito. Ito ang posterior fascicle, dito sa left, meron anterior fascicle. Dito sa SA node at sa AB node, merong connection. Ang tawag noon, internodal tracts. Tatlo po yan. Internodal tract of Bachmann, internodal tract of Torel, internodal tract of Wenckebach. Mayroong wire papunta sa right, papunta sa left. Para pag nag-fire sa SA node, magkocontract din si left auricle. So ito lang yung main highway. Meron pa yung mga maliliit. Si internodal tracts, tatlo yan, si Torel, Bachmann, and Wenckebach. Meron siyang delay of up to 1.20 of a second. It is made so to allow filling of your ventricles once you are contracting your auricles. So pag contract ng auricles, pasukan ng dugo. Yun yung 0.20 of a second. Okay? Kaya siya may delay, yung internodal tract travel. Okay. So I hope naintindihan para pag nag-progress tayo, makuha natin So ang SA node, ang kanyang firing rate is 60 to 100. Pag hiwalay ko sa SA node, yung primary pacemaker, si AB node, follow siya ng 40 to 60. Pwede siya mag-accelerate. Si bundle of His, 40 to 60. Si Purkinje system, or Purkinje fiber, is 20 to 40. Pero, pag ventricular rhythm na lang, tapos si Purkinje nagpa-fire, huwag kayo matakot na 20 to 40, hindi kayo mabuhay. Mag-accelerate po yan, babawi po yung katawan. Mag-accelerate yan. Pero, the normal firing sequence of the Purkinje is only 20 to 40. Why is it like that? Because the cardiac cell is the only cell in the body which is meron siyang tinatawag na cell automaticity, meron siyang automaticity na. Hindi katulad ng muscle, tanggalin ko yung muscle lang siya, kagano no, nakabulagta sa harap mo. Pero pag tanggalin ko yung heart mo, ilagay ko sa harap mo, nagbi-beat yung heart. No? Kasi meron siyang self-firing mechanism. No? May automaticity siya. Hindi katulad ng ibang muscle na wala silang ganon. But of course, it will not beat. When it's outside the body, it will not beat forever. Hanggang mauubos siya, mamatay na kasi ubos na yung metabolites. So sa ECG, anong kailangan natin makita? Siyempre si rate, makita natin kung regular rhythm, makita natin kung yung conduction time, tapos abnormal conduction patterns kung mayroon. Sa ibang mga trained eyes, nakikita rin kung mayroong hypertrophy. Although hindi ini-encourage na isama basa sa ECG, pero pwede siya para sa isang talagang magaling na mata or pwedeng kapartner ng para sa cardiothoracic ratio, partner ng x-ray mo. So, kaya natin siyang basahin. Nakikita niyo ba slides ko? Yes or no? Salita-salita lang ko, hindi na nakikita slides. Nakikita ba?
Yes.
Okay. So, ECG defines, the ECG looks at the heart and it represents the the activity of the heart in its electrical sense, no? Kaya ang tawag ay ang heart, ang kanyang feature is isang electrical organ. So nire-record natin siya, katulad sa amin noon na naka-strip siya sa isang thermal paper. Ngayon kasi computerized na lahat, no? Pwede mo na ma-Bluetooth, no? Grabe. So ito yung pinaka-simpleng slide na gagawin ko, i-lecture ko. Dito muna ako sa first slide, first picture. So ang tawag nito, tingnan niyo ang cursor ko, ang tawag ng linya, baseline. Kapag merong waveform, parang merong tawag nito, deflection, positive deflection pataas, negative deflection pababa. Okay? another waveform in between the waveform called the segment, which is, it can be along the line of the baseline or it can be elevated, parang sa ST. S and T. Kung na-elevate ST segment, so ST segment elevation siya. Okay? So segment in between waveforms. So again, ang waveform, pag mataas, positive, pag pababa, negative. Pag meron kang waveform pababa, biglang meron pataas at pababa, ang tawag po dito flex is the ventricular depolarization. Kapag meron kang waveform plus a segment, ang tawag niyan interval. Katulad ditong PR interval. Pero may magtatanong sa akin, saan magsisimula? Pero bago magsimula ang Q. Pero bakit tawag PR interval? Bakit hindi PQ interval? Okay. Sa totoong ECG, bira ka makakita ng Q kasi pag nakakita ka ng Q, may reading po yan. Ano? Hindi siya man nakikita. So, hindi siya ang ating cornerstone. Ang cornerstone natin is the R. Bakit? Because among all wave initial, bakit ko sa dinosaurian, siya ang susundin. So, pinakamalakas si R, yung kanyang waveform ang lakas. So, parang, kung if there is one guy, if we will name this guy, one guy in one letter, this can be Q, and this angle here. Okay. Kaya, PR interval. Because R is the dominating waveform of the complex. Yan ha, para although mahirapan yung hanapin yan sa libro. Merong mga ganong explanation. Hinanap ko talaga yun yung pinaka-nearest explanation na nakuha. So, PR interval. Yan, baseline, bantayan natin. So, yan yung forma na P, Q, R, S complex, and then T, which is the repolarization of your heart. Ito yung resting phase. No? Segundo lang ang pagitan. Tapos, babalik ulit sa PQRST, PQRST. Okay. Tapos na tayo sa forma, pupunta tayo sa highway na dinadaanan. Yung highway na dinadaanan niya ay merong mga grids. Vertical sa horizontal. Dito muna tayo sa mga horizontal vertical grids na very prominent. Ito yung big squares or big box. Yung big box, no? Papansinin natin siya, horizontally. Kasi mas maraming basa horizontally kesa basa pataas. Yung tinatawag nating mga millivoltages. Ito yung electrical, yung voltage ng sipa mo, pataas yun. That's the vertical. Karamihang ECG reading is always on the seconds. Kaya mas marami tayong babasahin, ilang boxes ang na-involve sa horizontal read. Okay. So dito tayo sa big boxes muna. Itong big box na to, pag tumakbo to versus time, kailangan kakain siya ng 5. Bakit? Kasi ang big box na to is 0.20 of a second. Yung layo niya. Segundo ha, horizontal ako, hindi ko muna ako mag-vertical. So isa, 0.20, 0.20, 0.20, 0.20, 0.20. Yung 5 big boxes is equivalent to 1 second travel time. So bawat pitik ng isang relo mo sa seconds niya, bawat pitik may 5 big boxes or big squares ang tumatawid kung pinapatakbo mo yung ECG strip. So check, 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 check. Yung ECG, bumabiyahe yung ECG strip mo. Within 1 second, 5 big boxes ang dinadaanan niya. Okay. So yan yung big box or big square. Ngayon, i-excavate natin si big box or si big square. Ito tayo ngayon sa kanan na picture. So si big box or si big square ay merong 25 small squares. Pero hindi ko papakialaman yung 25. Papakialaman ko lang yung 5 horizontally again. Kung siya ay 0.20 of a second, therefore, this small box is 0.04 times 5 is 0.20. Papakailaman natin to kasi dito tayo magsusukat ng complexes if they're wide, ng if there's first degree heart block. Okay? Yan. Yung pataas na yan, ginagamit na lang natin yan kung anong size, no? Katulad ng ST segment elevation, katulad ng nagpe-pacing tayo, kung ilang voltage, nakikita natin dito. Pero hindi siya as popular when you want to read it horizontally. Okay? So, naintindihan lahat. The big square is 0.20 of a second. The smallest square, the small square or small box is 0.04 of a second. Yan. Babalik tayo dyan. Okay, dokso ako dito. Boxes. Kasi 0.04, 0.04, 0.10, merong half of the small. So, 0.10. Ang kanyang length, ang haba. Pag tumaas yan, dalawa, it's either high voltage yung ECG mo, or, although hindi ko ini-encourage, parang unique na mataas to, yung iba naman hindi gano'n, pwede tayo mag-consider na atrial hypertrophy. Okay, mga ganyan. So, ito yung forma, P-wave, depolarization of your atria. Merong 0.12 to 0.20 of a seconds delay bago siya sisipa. Ito, 0.12 to 0.20 of a second, hindi 1 second, less than 1 second delay bago siya mag-QRS. Pag QRS is your depolarization of the ventricle. Pagpitik ng ventricle muscle, no, lalabas to. Kailangan itong QRS ko ay hindi lalampas tatlong small square. Kaya sabi ito, 0.12 of a second, measure less than. So it's called a narrow complex. Kapag lumampas siya, it is already called a wide complex. So saan ko kinuha si 0.12? Tatlong small squares po or less. Tatlo or less. Kailangan hindi lumampas sa tatlong small squares. Okay. Then, meron akong T-wave which is the ventricular repolarization. So walang activity ang cardiac muscle, pahinga siya to prepare for another run. So anong titingnan natin dapat sa ECG? Basahin natin. So 5 lang ang kaya na ang turo sa ACLS. Heart rate, basa ng rhythm, kung irregular rhythm, irregular rhythm, irregularly regular rhythm, or regularly irregular rhythm. Okay? Tapos presence of P wave to signify it's a sinus rhythm. And then the PR interval which is hindi siya priority. And then ano ang forma ng QRS complex. So I'll start with 1. So una is heart rate. Hindi po tayo nagdi-division method. Para matamaan natin si atrial fibrillation, ang ginagamit natin is a 6-second method. Balik ulit tayo sa squares. Di ba sabi ko kanina, isang big box is 0.20. So 1, 2, 3, 4, 5, that's 1 second. Okay? That's 2 seconds, that's 3 seconds. Every 3 seconds, makakita kayo ng broad marks. Okay? So every 3 seconds. So 1 second, 2 seconds, 3 seconds. Kukunin natin ito at hanggang doon, ang tawag dyan 6-second lead. Bibilangin natin si R, 1, 2, 3, 4, 5, 6, 7, 8 times 10, that's 80 beats per minute. Okay? Yan ang tinatawag na 6-second method. Yan lang ang gustong ituro ni AHA. Ayaw na niya ng mga division. Para mabasa mo talaga lahat ng ECG rito. Kasi division method, pag meron kang AF, atrial fibrillation, hindi obra si division method. Ngayon, sa heart rate, ito. Okay? So, isang broad mark, 6-second lead, bibilang 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So, that's 100 beats per minute. The next, kita mo, dali lang pala ng ECG. So, okay, mataranta. Dali lang pala. So, the next thing that we have to learn is what we call the rhythm. So, sa lumang panahon, ang rhythm, binabaliktad ko lang yung long strip. Minimeasure ko to at doon at isusukat ko sa next kung equidistant siya. So, ito sa isang tingin, nakikita natin equidistant. Ang tawag ko dyan ay regular rhythm. Biglang ito ay lumayo konti, tapos balik ulit. lumayo konti, bumalik ulit. Ang tawag dyan is irregular rhythm. Ganun lang. So ito, anong rhythm ito? Regular rhythm. So meron na tayong rate, meron na tayong rhythm. Okay? Then we go into P wave, presence ng P wave. Ano ang presence ng P wave? Okay. So titingnan ko yung ECG, P, Q, R, S, T, P, Q, may P wave siya. Therefore, ang tawag nito, sinus, hindi pa naman siya takin, o, normal sinus rhythm. Pero kung lumayo to konti, tapos balik-balik ulit, lumayo to konti, balik-balik ulit, ang tawag dyan, sinus arrhythmia. Nothing is wrong, the patient can still play football. Okay? Nangyari yan sa mga teenager, even athletes, nagsa-sinus arrhythmia. Ano pa? PR. PR interval, makikita natin mamaya, na sa PR interval, humaba lang ng more than sa Sa PR interval, makikita natin na merong P wave pero mahaba ang PR interval na more than 5 small squares. So it's a heart block. Matatamaan natin yan. But not our concern. Mapapansin niyo sa artifact, very pointed yung mga ano, yung supposedly baseline. Akala nyo atrial fibrillation, pero super pointed siya. Yung pagka-super point niya, then disturb ang electrical activity. Pero may nakapansin kayo na QRS. Tingnan yung QRS ko narrow. Equidistant. Therefore, it cannot be atrial fibrillation. So, ang ibig sabihin yan, artifact po yan. Kailan nagkakaroon ng artifact ang ECG niyo? So, pag ang ECG no ay sira, loose leads, or what do you call this? What else? Gumagalaw ang pasyente. So, mag-artifact talaga yan. Kasi siyempre, may mga muscle movement. So, pag during muscle movement, may mga ions na yung during movement, siyempre, electrical activity happens. It follows suit, no? So, yun ang mechanics. Kaya nagkakaroon ng windang yung ECG mo, yung reading mo. Okay? So, tingnan nyo ang artifacts ha, kasi mamaya, pag nakita tayo ng atrial fibrillation, baka magkamali kayo ng basa. Okay? So, yan. Pag tinaas ko lang yung aking electric traffic. Yun. Sobrang init dito sa Manila.
Hello, sir.
So, yes?
Sir, relation po dyan sa atrial, ano nyo, may significance.
Yes po. Parang napuputol kayo.
May significant changes po ba sa ECG pag may mga coins or singsing, ikaw?
Saglit ha. Hindi kita parang nag-garble ka. Can you repeat your concern again, please?
Kasi sir, prior sa ECG, pinapatanggal yung mga metals like coins or singsing,
Yeah. Okay,
pigs.
yeah. Ganito po yan. Sige. Now, you're asking me like that, why it is so? Ganito po yan. Alam niyo po, ang electricity travels in a line. Ang electricity, nagsesegue yan kapag meron siyang dinaanan na isang lugar or sa doon sa, di ba, sa physics, electricity travels in accordance to time in a space, in a line. Kung meron kang travel pathway, kunwari, kuryente, or katulad ko, ang tao, bumabiyahe ang elektrisidad. Not because bumabiyahe siya sa skin, sa tissue. Bumabiyahe siya sa tao, sa akin, o sa iyo, dahil tayo ay 70% water. Ang water sa atin ay ionized. Pero kung tanggalin ko ang water, kung hindi naman tayo mamatay, pero tinanggal ko ang water, para lang tayo, if we will behave like a wood or a rubber, hindi tayo makakuryente. Hawakan mo yung kuryente, wala kuryente. Kasi hindi siya conductor. Ang conductor, katulad ng tubig, kasi kaya siya ionized, mga metal, yung relo na metal, pinapatanggal, kasi ang ECG, pag pitik ng heart mo, bumabiyahe yan all over the body. Kaya, kung titingnan nyo ako, tingnan nyo ang video ko, no? So, bakit nilalagay ang limb leads dito, kinakabit? Pero heart ang kinukunan. Bakit di na lang doon sa heart? Naglalagay sa limb leads. Bakit? Kasi bawat pitik ng heart, tumatakbo ang electricity all over the body. But it is not significant that it can alter the electrical whatever also in the brain. Kasi tayo we are a multicellular organism which is charged. Ngayon, nilagyan mo ako ng relo. May influensya na yun. Kasi, conductor yun eh. Naglagay ako ng metallic belt, naghawak ako sa metal, nakaka-influensya. So, pag ilagay ko sa ECG, gugulo ang reading niya. Yun. Pwede siya mag-artifact kasi merong linilikuan ang electricity. It is not anymore a definitive straight line. Meron siyang pit stop na nawendan siya. Pero it is so minimal that you cannot even feel it at all. Wala lang. Wala lang, hindi ka na-electrify. Yung mga na-electrify naman, na ginawa ka bilang nag-spark, hindi naman galing sa heart yun. Nanggaling yun because of humidity. No? Biglang, nagulat ka, hinawakan, bakit ganun? Charge ka, pero ang environment mo, ang molecule sa air, charge din, nadagdagan sa air, kaya nag-spark. Ganyan, that has something to do with humidity. Kaya tinatanggal, para wala akong artifact. That's a very good question. Okay. So, patient movement, loose defective electrodes, improper grounding. Nung panahon ko po, para malaman ko, hindi ko kinakahiya. Mag-ECG kami, lalo na ang pasyente gilid ng hospital bed. Tapos merong bintana na metal. Meron po kami alligator clip na may wire, kinakabit po namin ang tawag po doon ground. Gina-ground namin para lang hindi gaganda yung ECG display. Okay, yan. I hope I answer your concern, but I understood it. I don't know if I explained it so well. Sometimes I have to ask. Kasi ang reklamo sa akin ng tao, minsan nagsasalita daw ako mabilis, or yung accent ko, hindi ko po talaga maiwasan na yung accent ko, minsan hindi naintindihan. Usage ko ng Tagalog, nagalo-halo minsan ng Bicol, Tagalog, Bisaya, Ilonggo ko, no? Nahihilo mga tao sa akin. I cannot do anything about it. No? So, that's the nearest thing. For you not to be confused with electricity, anything basta conductor ka can influence the electrical current. Isang example, pag ikaw ay naabutan ng lightning storm, nasa gitna ka ng open meadow sa Bukilin, ngayon meron kang relo at may cellphone ka, likelihood tamaan ka ng lightning. Bakit? Kasi may conductor ka sa katawan. Parang ika nga ang electricity, liliko siya papunta sa iyo. Or bumilid ka sa kahoy. Yung kahoy basang-basa na sa tubig. Tubig is a conductor. doon kasi ilalim niya, mataas siya, tinamaan siya, kuryente ka rin. Kaya pag gusto mo sa survival ng ng lightning storm, huwag kasi ilalim ng puno na solitary. Huwag ka rin sa bungan ng boulder. Pwede siyang tamaan, makuryente ka. Kung may cave, pwede kang pumasok. Kung wala kang choice, nasa open space ka, magtanggal ka ng metallic, ilayo mo. Kung meron kang tent na metallic na mga ilayo mo lang siya. Tapos nakatipto ka lang para pag tumama sa ground yung lightning, yung travel ng electricity, hindi dramatic na dadaan sa katawan mo kasi napakalakas na voltahe yan. That's thousands of voltages. So, yan mga. So, once you are metallic, tatamaan ka. Yung mga aeroplano, meron silang lightning arrester na pag in-arrest, hindi magbabago yung avionics. Kasi maraming metallic areas sa aeroplano, pero meron silang lightning arrester. Mga bahay, usually pag ginagawa yung bahay, mga buildings, nilalagyan nila ng lightning arrester. Tumating yung mga kuryente na bahay, lightning arrester yan. So, ganun din tayo. So, hindi naman tayo pwede maglagay ng isang electrical arrester para gumanda ECG, tanggalin na lang natin yung metallic. So, kailan tayo magtatanggal ng metallic? Tayo ay nasa ECG at kapag tayo ay mag-submit for MRI. So, ang MRI is nothing to do with electricity except that it utilizes strong magnets. Pag meron kang doon, meron kang mga bakal, baka dumikit ka doon sa sensor. So, ayan. So, let's go now. Types of rhythm. So, sa rhythm natin, tingnan natin ngayon. We will note its bradycardia if it's below 60. Pag tachycardia, it's above 100. Ang allowed na sinus tachycardia is 100 to 150. Pag above 150, it is not anymore sinus in origin. The origin is somewhere na in the auricles or even in the ventricles. Ang sinus firing, ang max niya is only 150. Hindi niya kaya mag-exceed. Okay? So, saan manggagaling ang ating firing mechanics ng heart? Can be sinus or SA node, sinoatrial node, which is signified by the presence of P wave. It can be atrial, ipapakita ko nga. It can be junctional, sa junction ng atrium saka sa ventricles. It can be interventricle. Okay? Or it can be artificial pacemaker kung meron ka. So, sa sinus rhythm, 4. Normal sinus rhythm, sinus arrhythmia, hindi niya sinama, sinus brady, sinus tachy. Okay, so i-review natin. Hindi ko rocket science, okay, intimidate. What is the rate? So, titingnan ko si broad mark, bilangin ko. Sama ko to 1, 2, 3, 4, 5, 6, 7, 8. So, I have here 80 beats per minute. Go, 80 beats per minute. What is the rhythm? Hindi ko na kailangan tupiin yung ECG ko. Titingnan ko lang equidistant ang R2, 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 R. So, ang tawag dyan, regular rhythm. Is there P wave? Okay, kita ko may P wave, may P wave, may P wave, P wave. QRS narrow, PR interval within normal range. Ang tawag niyo normal sinus rhythm. As simple as that. Anything na meron P wave, you have to use the word sinus in honor of sinoatrial. Punta ako sa brady. Bilangin ko 1, 6-second lead, 1, 2, 3, 4, 40 beats per minute. Rhythm, equidistant to each other. So therefore, it's called regular rhythm. Regular rhythm niya. P-wave, ayan si P-wave, may P-wave siya. QRS narrow, PR interval within normal range. Ang tawag sa kanya is sinus bradycardia. Huwag kayong magsabing bradycardia. Kompletohin nyo kung anong klaseng bradycardia. Pag mayroong P-wave, ang tawag ay sinus brady. Now let's go to the next. Six-second lead again. Ayan o. Tatlong broad marks. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So that's 120 times 10, 120. Next question. What is the rhythm? So titingnan ko yung RR interval, R2, 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 R. Most likely it's regular rhythm. may slight lang irregular, pero regular yan. So, I can still call it regular rhythm. Is there P wave? Absolutely. Ayan si PO. PQRST. 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 May P wave siya. PR interval with normal range is called sinus-static. Sinus arrhythmia is like this. Pwedeng lumayo yan. Lumayo. Tapos balik ulit normal. Lumayo. Balik ulit normal. Lumayo. Yan. So it's called sinus arrhythmia kasi may P wave, QRS narrow. Okay? So yun ang ating sinus rhythm. Let's go to the atrial rhythm. So ang atrial rhythm ay tatlo lang. Sometimes it's called atrial dysrhythmia. So meron akong atrial flutter, atrial fib, at saka supraventricular or atrial tachycardia or supraventricular tachycardia. Atrial flutter, question number 1, what is the rate? Balik ulit sa rate. 1, 6-second lead, nasaan ang 6-second ko? Hindi ko makita ang broad mark. Ayan, broad, 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 broad. So 1, 2, 3, 4, 5, 6, 7, 8, that's 80. What is the rhythm? Equidistant to each other, regular rhythm. Is there P wave, ladies and gentlemen? You cannot say anymore the P wave. Because you don't know if this is the P wave, is this the P wave, di mo alam. But you know na merong QRS response. So QRS ko, narrow pa rin. Therefore, wala akong PR interval kasi wala akong P wave, so walang PR interval. Importante QRS narrow. Pag makita ka ng ganito, tapos itong ganyan, parang lagari, ngipin ng lagari, it's called sawtooth in appearance. It's called flutter, atrial flutter. So, saan ang gagaling ang kanyang firing mechanics? Hindi na sa SA node, kung hindi in some areas in the atrium, pwedeng sa wall. No? So, merong definite type doon sa part ng wall, doon nagpa-fire, pero kinakain pa rin ni AV node. O, kinain pa rin. Let's go to the next. Ito yung nakaka-intriga. 6-second lead. 1, 2, 3. 6-second lead. Bibilangin ko 1, 2, 3, 4, 5, 6, 7, 8, 9. So 90. What is the rhythm? Can somebody chat? Bigay nyo sa chat. Anong rhythm? I-chat niyo. Isulat sa chat. Rhythm. Anong tawag sa rhythm? Grabe, isulat ka lang sa chat. Hindi pa may tulat. Oo, nunod lang close. Ginagalitan daw. Sige. Ano pa? Sino pa ang gustong sumagot? Anong atrial flutter? Ang hiningi ko lang anong klaseng rhythm. It's an atrial fibrillation. Yes. But what do you call yung rhythm niya? Regular, irregular, anong tawag? Yun ang tanong ko. Irregular. Okay, may pangalawang sumagot irregular. Wala na. Yun lang. Okay. Ang sagot po niyan Ang tamang sagot po ay hindi irregular rhythm. Ang tamang sagot po ay irregular rhythm. Bakit? Pansinin po ninyo, yung ritmo niya, ang QRS niya, minsan maiksi, minsan humama, minsan sobrang haba. Okay? Tingnan nyo ang ating cursor. Tingnan nyo ang cursor ko. Maiksi. Mahaba. Ay, sobrang haba. Bumalik sa iksi. Mahaba. Sobrang haba. Maiksi. Humaba. Konti. Sobrang haba. Walang pattern. Ang tawag sa kanya, irregular rhythm. Yan lang po yung ritmo sa buong mundo na irregular rhythm. Okay? Pag nakakita kayo ng irregular rhythm, wala na kayong ibang isaksak sa inyong kukote kung hindi yan ay atrial fibrillation. Kailan nagiging problematic si atrial flutter saka si atrial fibrillation? Kailan? Balik ko kay flutter. Kapag isang pitik, dalawang pitik, pumitik na yan, or isang pitik, pumitik na ulit, ang tawag ng rapid ventricular response. Ganon din si atrial fibrillation. Pag dumami na, ganyan, parang pitik na, puro na QRS, dumidikit na sa QRS, ang tawag dyan RVR, o rapid ventricular response, yun na yung ayaw ninyo. Okay? So, iniiwasan natin. Now, let's go into the third ventricular rhythm. It's called SVT. So, bibilangin natin. Huwag ko nang bilangin. Sasakit ang mata natin sa bilang. Ang tawag dyan, nasa 180 up to 200 na. Okay? So, yan ang kanyang speed. Ang kanyang rhythm, ang tempo, equidistant, regular. P-wave, wala na pong P-wave yan. Ano pa? May QRS niya narrow. So, isang katangian niya, ang QRS narrow. So, therefore, ito yung presentation ng heart mo na kung saan iwanan mo lang ang pasyente na nakaganyan, maya-maya, mahaba na siguro 20 minutes yan. Maya-maya ka-cardiac arrest yan. Mapapagod yung heart yan. Pumapalo ko yan ng 200 plus per minute. Tandaan nyo. So, it's not a joke. Your heart will get tired. Okay, now, so let's go into ventricular rhythm. So, yung ventricular rhythm, wala na po tayong SA node, hindi na po sa atria galing yung impulse, nanggagaling na po sa ventricle. So, it does not mean independent sila. Sila lang. It means meron kang NSR, pero meron kang ventricular rhythm, like a premature ventricular contraction. So, ito yung iba-ibang ventricular rhythm. May PVC tayo, may BTAC, monomorphic BTAC, polymorphic BTAC, and these are extrasystole also. Meron ding makikita kayo na PVC, sunod-sunod. So, ang tawag doon, ensalmo. PVC ensalmo. Matatakot na kayo kasi papunta na ng BTAC yan. Ang unang katakutan nyo, kunwari, normal PQRST, biglang merong PVC. Normal QRST, PVC. So, ang tawag doon, by Q speed. So yun, pasunod-sunod na yung pwedeng pasunod-sunod, bantayan nyo yung pasyente. Pwede kayo mag-lidocaine drip, depende. But that's not ACLS topic. Mahuhulog yan sa AMLS. May tanong ako, kailan magiging normal tama yung Tagalog ko. How many PBCs ang acceptable? So kanya-kanyang libro. So meron dito sa ACLS, ang sabi nila na percentage na if there are more than 10% to 15% of a person's heartbeat in 24 hours, so nakakabit tayo, kinabitan tayo ng cardiac monitor. So excessive yan. So ito yung potentially can cause, pag sige ka kasi PBC, mabubugbog yung heart mo, magka-cardiomyopathy ka. So doon siya pag may 10 to 15%. So how to make it simple, ganito. Pag ikaw may PBC, medyo normal occurrence siya pag may ilan lang. Pero pag sumilit-silit, ako nang lumitaw sa akin nung nag-coffee ako, nung nagbitaw ako ng coffee na wala PBC. So PBC can increase, can contribute to a sudden cardiac arrest, kung lalo na pag sunod-sunod siya. So frequent siya, and at the same time, ideally, pag lumampas ng 12 PBCs per day. So potential, ha? So, nakakatakot. So hindi na ako nagkape. Pero minsan nagpapasaway. Grabe kasi ako nagkape. So ayan. Then we go into BTAC. So bibilangin natin sa 12 second, lampas, lampas 160, lampas 160. Walang P-wave, wide QRS na. Tingnan mo, wide QRS na siya. Pero ang forma niya isa. Ang tawag sa BTAC na to ay monomorphic BTAC. Buhay pa ba pasyente dito? Yes or no? Pag may pulso yan, BTAC lang siya. Maya-maya, pag nawala na yung pulso, pulseless BTAC na siya. Yun na yung arresting heart. Dinidefib natin yun. So, ang dinidefib natin, yung sa carburetor, dalawa, ventricular fibrillation, saka pulseless, ventricular tachycardia. But talking about tachycardia, ito isang forma, pag isa, meaning mono, forma, form, morpho. Monomorphic BTAC. Meron din tayong tinatawag na polymorphic BTAC. O ito, medyo maliit, lumiit, lumaki, yan. Ito, polymorphic yan. Meron din iba-ibang forma, tulad ito, yan, iba-ibang forma, polymorphic BTAC. Dito, mostly, arresting na yung heart dito. Pag meron kang nakita ganito, dinilipid natin, kasama sa emergency meds na bibigay natin, ay magnesium sulfate. Lumilitaw ito kapag ang pasyente ay may hypomagnesemia. Then we go into the most common arresting heart rhythm, which is the ventricular fibrillation. So ito po si BF, wala po siya windang. Windang ang kanyang pattern, no pattern siya. Pag pinabayaan mo yan, magpa-5 BF yan hanggang magpa-flatline. Okay? So both of these, dinidefibrillate natin. 5 BF saka force BF. Then we have asystole. To correct it, this is not the real asystole. So siguro para mag-come up lang ng ECG na may asystole, pinuon nila ang ECG, hindi nakakabit sa tao. Kasi ang totoong asystole ay hindi ganito. Meron kang makikita na may mga umaangat konti pa, no? Para galing sa abdominal. Pero anyhow, flatline is asystole, and we do not defibrillate about flatline kasi merong isang school noon, nursing school pa naman, na nakapicture sa TV, flatline, dinefibrillate na buhay nila, ang galing naman. Ngayon, nakita ko sa pasyente, arresting patient. Sa lead number 2, anong next gagawin mo? Ang gagawin mo, pindutin mo yung lead sa lead number 3, tingnan mo kung flatline ulit. Tapos, paddle side, pindot mo lead number 1, flatline ulit, balik ka sa lead number 2, flatline. Saka ka mag-declare, the patient is having asystole. Huwag ka mag-declare asystole na ang pasyente, isa lang na flatline ang sinilip mo. Okay? So, before you say it's flatline, na-check mo ang 3 limb leads. 2, 3, and 1. Balik sa 2. Naintindihan, ha? Yan. Ito, tinanggal ang lead ng flatline. And then, there is a rhythm what we call pulseless electrical activity. Ano yun? Hindi siya ventricular fibrillation, hindi siya pulseless beta. Meron siyang mga movement sa ECG pero walang pulso. Kaya tawag doon pulseless electrical activity. May electrical activity, merong umaangat sa ECG mo pero weird siya. Pero walang pulso. So it's called pulseless electrical activity and you have to treat it like it is asystole. So pag manage ng PIA, pulseless electrical activity is the same as how you manage asystole. Okay pa? So we go into heart block? Ayos pa? Or masakit na ulo? Sisiw pa, sisiw? Hello, hello. Hey, okay. Hindi ko alam kung ano nangyari sa inyo. Are you still okay? O sumasakit na ulo? Naintindihan ba? Wala akong kausap. Twenty-nine of you, wala man lang sumagot if you're okay or not. Saan? Okay pa? Yan. Fights. Okay, let's go into heart block. So there are fights. Easy lang ang ECG. Kaya nga tinawag na ECG kasi siya ay easy. Easy lang, madali. Kaya ECG. So there are 4 heart blocks. First degree, second degree Mobitz, type 1, or when kebab, second degree Mobitz type 2, and the complete heart block. So let's see the heart blocks. Why it's contributory? Contributory, why it's part of ACLS program. So first degree heart block, balik ulit tayo sa tanong. What is the rate? So makikita natin yung broad markers. Ayan, broad markers. Tingnan nyo ang cursor ko. Bibilang ko 1, 2, 3, 4, 5, 6, 7, 70. Normal rate siya. Ang rhythm, equidistant to each other. Kita nyo, equidistant ha, sakto ang distansya. So, regular rhythm. Normal rate, regular rhythm. Is there P wave? Ayan, si P wave, P wave, P wave, P wave. QRS, narrow siya. PR interval. Ay, sa PR interval ng kalokolo. Lampas po ng 0.20. Nasa 0.20, 0.28. Therefore, prolonged PR interval, the patient has first degree AV block or heart block. Is the patient okay? Yeah, no problem. No problem with that. Let's go into type 2. Okay? Bilangin ko ang rate. 1, 2, 3. Lumayo. 1, 2, 3. So 60. Normal rate, what's the rhythm? Equidistant, biglang lumayo. Equidistant, biglang lumayo. Ang tawag nito, irregular rhythm. Habaan ko yan, regularly, irregular rhythm. Pero regular siya, pero meron siyang pero pinaka-safe is irregular rhythm. Is there P wave? Yes, ayan o, P wave. P wave, P wave, P wave, pero walang QRS. Is there QRS? Normal looking except for some P waves, P fire na walang QRS. No? It occurs 3:1. Every 3, may lumalabas na isa. Na walang QRS response. But one definite thing makikita niyo is the PR interval. Okay, tingin sa akin. PQRST, PR interval, sakto lang. Pagdating dito, humaba na. Pagdating dito, lalo pang humaba. Pagdating dito, may P pero walang QRS. There is a gradual lengthening of PR interval until it reaches a point that there is no concomitant QRS response or QRS complex. So yan nangyari. And babalik ulit siya sa ganung cycle. So ang typical na second degree heart block type 1, Mobitz type 1 ay gradual prolongation of PR interval until there is atrial firing with no concomitant QRS response. Ang worst case scenario pa nito ay so not really worst case because the patient, the patient will can still live medyo okay. Hindi pa ako matatakot dito. Kasi pwede humaba siya. Kung makikita niyo humaba, babae natin. Pwede maiksi. Tignan niyo rito. 1, 2, 3, 4, 5, 6, 7, 70. Irregular rhythm to. P, QRST, P humaba, QRST, P wala. P, QRST, normal. Biglang humaba, biglang wala. So, ang tawag dito 2:1. Kung kanina 3:1. Meron din 4:1. Dito ang 4:1. P, QRST, P humaba na, QRST. P sobrang haba na, QRST. P sobrang haba na talaga, QRST and then P. Ang tawag dito 4:1. Again, this is not an emergency. Pero pansinin nyo, may gradual lengthening of PR interval until it reaches a point that there is no more QRS response. Now, let's go into second degree type 2. Itong si type 2, dito na tayo matatakot. Bakit? Dito kami bradycardia. Tingnan mo, 1, 2, 3, 4, 5. So, minsan ito, irregular siya, pero minsan naging irregularly, somehow irregular, depende kung kailan sumusuport. Si QRS complex. But this is in the house of irregular bradycardia. Irregular ito, tapos bradycardia. Ang maganda nito, may P-wave, QRS, good looking na, except mayroong P-waves na walang QRS. Katulad nito, P-wave, walang QRS. P-wave, walang QRS. P-wave, may QRS. P-wave, QRS. P-wave, QRS. Bigla ka namang na Q-wave, pero walang QRS. So, ganito, ang pasyente dapat ilalagyan mo ng pacer. Kasi, pag sumunod-sunod to na wala ng QRS response, bubulagta na yung pasyente. Okay. Then, let's go into the third degree AV block. Super bradycardic, 30 na lang. Tingnan mo si P-wave, tingnan niyo cursor ko, gano'ng distansya, equidistant ang P-wave. Si P-wave, nasa T-wave, oh. P-wave, 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 nandito sa QRS. Equidistant siya. Si QRS naman, equidistant to each other. Nagkanya-kanya silang trabaho. Si P-wave nagko-contract ng kanya, si QRS nagko-contract ng kanya. Hindi nagkakatugmaan. Paano itulak ang blood sa QRS? Kaya, ang pasyente dito dapat dalhin agad sa ospital. Hindi na pwedeng palimili ito. Kasi baka maya-maya, bagsak yan. But, this is where we can transcutaneous space the patient. Anyway, I teach you like that once we study pacing. O, pansinin nyo, walang definite QRS, biglang mayroong QRS. So, na-exclude ako lang, NSR siya, with ST depression na. Preceding, ito pa ka, sorry ha. P-wave, ito lang si P-wave, 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 tapos P-wave. Ito yata, P-wave, 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 P-wave. Si P-wave may kanyang beat, si QRS may kanyang beat. 30 degree heart lock. Meron din dito, P-wave, 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 nandito sa T, P-wave, P-wave, nasa QRS, P-wave, P-wave. Si QRS mo, 30 na lang. So, ipe-pacer natin itong tao na. Pag hindi, mamamatay yan. Pag nakakita kayo ng pacer, lagi kayo makakita ng guhit, tapos mayroong capture. Ang tawag dyan, capture. Okay? Dapat ang capture, nakukontak ng muscle mo, dapat nakakasipa ng dugo. So, yan ang pacemaker. So, practice tayo. May sagot yan. So, let's have an evaluation, guys. Any question before we have our test, online test? Kuha mo na ako ng isang slide. Mag-exam tayo, okay? Ganito gawin natin. Huwag nyo lang sabihin ang rate, ang return. Diretso nyo i-diagnose anong klaseng ECG dito. Ngayon, isusulat nyo talaga. Pag sinabi mong cut off na, huwag na kayong magsulat, cut off na yun. Tapos i-assess natin kung ilan ang ano, kung sino sumagot, bahala na si Ma'am Joy. Okay? So let's go number 1. Chat box lang nga, pag sinabi kong time's up, wala na maglalagay. Oh, ito ano to? May lumabas ba wala? Parang wala. Ayan. Kita na. Nakita niyo yung ECG? Yes or no?
Yes po.
Okay, count 12 seconds. Anong ECG yan? 1,000, 2,000, 3,000. Next time, kompletuhin niya, pero okay. May sumagot dito, tingnan natin kung tama. Okay, close. So, ang sumagot dito, tama siya. Mobile side to po yan. Galing, galing. So, second degree heart block, mobile side to. Next slide. Number 4. Sulat lang kasi minomonitor natin sa internet. Sino yung sumasagot? Depende kung paano ipasa. Okay, so ano to? Yeah, it's a sinus brady pero may mapansin ka. Okay, close. Close na. So this one is a complete heart block. Makikita mo yung P-wave, oh. Yung huling P-wave nasa QRS, eh. So hindi yan first degree. Daming P-wave, oh. Next. Number 6. Close. It's not deepak, narrow. That's not normal. Wala siyang P-wave. Irregular. That's an atrial fibrillation. Not BTAC. Ang BTAC is wide complex. Next. O yan. Hindi pa makuha. Grabe. Okay. Close. NSR. Okay. Ilan ang sumasagot. Paano natin mapasa? Next. O ano yan? One, two, three, four. Wala nakasagot. So, number 8 is sinus tachycardia. That's not A-wave. May P-wave po ako. May P-wave. O, nakuha ang dalawa. Next slide. Ano yan? Okay, wala na ako ha. Wala, mali po. Mali lahat. Grounded, tama. Okay, close. Artifact po yan. Kita mo may mga QRS complex. Grounded yan. Okay, sige. Okay, close na. Pero sige, consider natin may humabol. Next. Makapasa man lang, dagdagan natin. Sagot kayo para pumasa kayo. O, ito. O. Okay, next. Madali lang yan. O, ito. O, marami na ako. Ito bata si hapon. Ito. Slide number 14. Ano yan? Ang pacemaker, letter P, hindi letter F. Okay, pacing or pacemaker, very good. Next. Huwag niyo na pansinin yung high voltage mo. Very good. Complete heart block. That's not a PVC. This is a third degree heart block. Oh, it's P wave, P wave, P wave, P wave, P wave, P wave. Equidistant to each other. That's a complete heart block. Galing, galing. It's not PVC. Yeah, third degree habol. Okay, ito. Close. Close, close, close. That's NSR. Very good. Diyan naman mga pangalan yun. Minomonitor yan. Next. Okay, 1, 2, 3, 4, 5, 6. Okay din. NSR. Good. It can be Brady. NSR yan. Brady is less than 60. Next slide. Ano yan? Okay, close. Ang tawag dito, polymorphic ventricular tachycardia, kompletuhin nyo. Kasi pag hindi nyo i-mine yung polymorphic, hindi kayo magbibigay ng magnesium sulfate. So, kailangan dyan, polymorphic ventricular tachycardia. Okay, next. Ito, ano to? Number 24. Sinus tachy. Paano yung sinus tachy? Wala akong P-wave. Okay, close. It's an SVT or atrial tachycardia. Wala na, hindi na po yan sinus. Okay, close, close, close. Number, huwag yan, madali yan. 30, ano to? Ano yan? That is already a ventricular fibrillation. Ayun, kita mo. BF na po yan. Course BF. So ano to? That's not a third degree. That is simply a PVC. Okay, next. O, pambawi, ano to? Okay, close. PVC. Yan ang tinatawag na by Gemini. So ito, by that's a PVC. O ito, dalawa sagot. Tingnan niyo to, ano tong rhythm? Ito, ano to? Itong guhit. So, dalawang sagot dyan. Okay. Ang tawag dito, ventricular fibrillation, tapos ito ay defibrillation, defibrillate. Hindi ko na alam anong mangyayari sa written dito. So, nag-defibrillate siya. Hindi, BF, hindi kinakardioverт ang BF unless may pulse. Unless pulseless. Sorry, pag pulseless, ventricular fibrillation, hindi kinakardiovert. Inaano siya. Dinidefibrillate. Okay. Ito ano to? 40. Okay, close. This is called atrial fibrillation. Okay, for our last slide, ito ano to? Anong rhythm yan? 49. So ito po, third degree AV block yan. So bahala na sila Ma'am Joy ang sumilip kung sino hindi nag-participate, walang points. Okay? So any questions sa ECG? Hirap talaga na, mahirap. Now, sige, consider natin. So let's go into another topic unless you want to have a 418. Mag-isa siguro, bilhin siguro kang dalawa. So next topic natin, pilitin lang natin matapos ko ngayon para tomorrow ilan na lang. So may first topic is on oxygen. Medyo maiksi lang to para makita niyo lang paano tayo na bibigay ng oxygen in times of emergency. Okay, on oxygen. Sa pre-hospital, meron mga sizes of oxygen. So we call it the E, D, C, depende M9, M6. So ayan siya. Tapos per oxygen, depende sa rate namin, yung flow rate, depende ganun siya katagal. So I'm not gonna discuss so much about that. Dito tayo sa oxygen mismo, pati paano siya i-deliver. So colorless, odorless siya yung unang kailangan sa katawan natin. And it becomes a treatment, no, sa cardiac arrest, carbon monoxide poisoning, and lots of things. It is a prescribed drug, kaya kailangan i-prescribe ng doctor. I mean, i-order niya sa chart. So, may nasa tangke siya, kulay green tank, kailangan meron siyang reduction gauge, and the reduction gauge has flow meter. Tapos yung flow meter, kailangan ang pinaka-max na ma-achieve ninyo is 15 liters per minute. Meron na ngayon mga 20 liters per minute para makapagtrabaho siya sa cardiac arrest. Tapos pag medical oxygen siya, lalagyan natin ng humidifier. Ganun ang ating assembly. Okay, paano po? Pa-mute lang. So ayan ang everyone, so familiar with that. So lukso tayo dito sa we give the adjunct. So, in emergency, 15 per liters per minute sa non-rebreather mask. So, ito kanila. So, titingnan natin paano tayo nag-ayos. So, one, may isang kanila, adult, saka child. Ang maximum FiO2 ma-achieve natin ito mababa lang. Ang kanyang flow rate, ang percentage, no, 24 to 44, depende kung ilan. So, 24 to 44, maglalaro lang from 2 liters to 6 liters per minute. Pag 4 liters, ida-dry niya yung nose mo. So, mga chest pain, binibigyan natin ng so, pwedeng magbigay tayo ng kanila, pwede rin plain mask, pwede non-rebreather. So, ayan. Tapos, paano natin malalaman ang FiO2? Depende sa flow rate. Kung 4 liters, nasa 36%. So, ayan ano, kailangan tingnan lang to. It's not rocket science to understand it. So, I will not talk about advantages and disadvantages of nursing intervention. I'll go into the mask. Ito yung tinatawag na Hudson mask or plain mask. Pag nagbigay ka, ang delivery percentage is 30 to 40%. Pero you can have a flow rate up to 10. So ito lamang ka kasi makapag 10 liters ka, magastos sa amin. Ang maganda nito, mataas ang oxygen percentage niya sa body. That's your plain mask. Okay? Next is Venturi mask. Ginagamit ang Venturi mask sa COPD. Set siya pag binili mo mahal kasi color-coded yung jet. So blue, pag ginamit mo yung blue kasi gusto mong i-achieve ang 24%, kailangan ang flow rate mo nasa 2 to 4 liters para makuha mo si 24. Pag white, 4 to 6, so on and so forth. So binili mo siya, kompleto sa color code yan. Ayan o. Now, we go into non-rebreather mask na ginagamit tayo sa emergency. So, ang maximum delivery niya, umabot sa 90 to 92. Pero kailangan 15 liters per minute. Okay? So, ang forma niya, ayan, ito siya. Non-rebreather mask merong quart. Ito wala. So, ang exhale niya, hahalo sa hangin galing sa oxygen. Kaya mas mababa ang FiO2 ng partial rebreather complete kumpara to sa NRB or NRM. So, ayan ulit. So, yan lang yung sa ating oxygen. Actually, hindi talaga siya kasama. Pero, inano ko lang para lang somehow maintindihan nyo ano ang importance ng non-rebreather mask. Let's go into fluid. Mabigat konti itong fluid eh. After sa fluid, pwede na tayong pahinga muna. Bilisan ko lang itong fluid. Tapos pahinga na tayo, 8 o'clock tayo tomorrow bago mag-ano. So, why we have to study fluid? Kasi maintindihan natin kailan tayo magbibigay, bakit natin binibigay ganito, bakit LR, bakit blood for blood, ayan. So, gagawin ko lang mabilis, para hindi kayo mahirapan kasi bugbog na kayo. So, we know that our body is like Mother Earth, 70% water. Mas matindi ang sa ratio, mas mataas ang sa infant, sa baby, sa newborn, kasi growing sila eh, development years nila yun. So, ang requirement sa metabolism mataas, kaya mataas ang tubig nila. Kaya pag nawalan sila ng tubig, grabe ang drama kumpara sa adult. Pero meron tayong demarcation, kunwari, blood ko is 5 liters. Pag nawalan ako ng 20%, it is 1 liter. Doon na yung physiological drama. Pag nag 1.5, pwede na akong mamatay. Pero depende, pag magaling ang hospital, kaya pagbuhayin. Pero pag nag 2 liters na nawala sa akin, wala na point of no return. Ngayon, meron tayong intracellular sa extracellular fluid compartment. Ang dominant cation sa extracellular is sodium, sa intravascular ko, sa extracellular ko sodium. Ngayon, hiwain ko yung extracellular outside the cell. So intravascularly, ang influencer ko is plasma kasi siya yung mag-retain ng fluid or mag-aalis ng fluid sa atin. Kaya binabantayan natin yung total protein albumin globulin ratio kasi para malaman natin ano ang protein ng katawan ng tao, lalo na yung malnutrition, paano holding power. So in terms sa certain pathology, kung saan hindi nakakakuha ng tubig is because ang protein natin kulang. Another thing is the interstitial. Ang interstitial space ay what is in between the two cells or the cells. So naging reservoir po siya, backup as a backup fluid na kailangan ng intracellular. Ang purpose ng fluid is to end up in the cell talaga, intracellular. Another is transcellular. Ito yung cerebrospinal fluid, nandun sa bursal in between bones, para ang bones natin hindi banggaan. Naging shock absorber siya. Ang tawag doon, transcellular space. Ngayon, ang influencer ng mga fluids para mag-move ay osmosis. Osmosis is water potential, movement of water through a selectively permeable membrane from an area of low solute to an area of high solute concentration. No, lilipat siya doon until ma-achieve ang equilibrium. Kaakibat niya is diffusion. Ang diffusion is solute potential. Ang osmosis is water potential. So si diffusion naman, pag maraming solute sa isang lugar, ililipat niya doon sa area na mababa ang solute. Pag mababa ang solute doon, magpantay sila, magpapantay din ang water. Yeah, they occur at the same time. Osmosis and diffusion. No energy requirement. Nagkakaroon ng energy requirement kapag active transport na. Ano yun? Sodium-potassium pump is one example. We have the insulin-glucose regulation. Kapag ito ay kumain ng high glucose content, mag-release na ang beta cells in the islets of Langerhans sa pancreas mo ng insulin para gagamitin transport of your glucose papunta sa cell. Yan. And sa fluid requirements sa katawan, meron tayong osmolality para ma-check natin kung sakto yung fluid. It can be measured primarily in the urine and of course in the serum. So may mga normal values tayo dyan. No? So I will not discuss kung kailan tataas ang serum, osmolality sa serum, no? Sa mga sakit na to. Katulad ng kapag meron siyang diabetes insipidus, na kung saan nauubusan ng fluid sa serum dahil kailangan mong iihi. Okay? Free water loss siya. Pag mababa naman, iyon yung syndrome of inappropriate release of antidiuretic hormone. Sa urine, baliktad din sa serum. Pag mataas ang osmol, baliktad naman doon sa serum. Not really, face-to-face like a mirror image. Pero may pagkakaiba, konti. Ganun din kapag decrease osmol, no? Pag decrease osmol, parang diabetes insipidus, para sa urine, diabetes insipidus. So, may fluid volume excess. So, ADH acts on water. So, ma-aakto ang antidiuretic hormone secreted by your posterior pituitary gland. Doon siya mag-aakto sa collecting duct at saka sa distal convoluting tubules ng kidney. So why do we prescribe fluids during cardiac arrest? Mainly, ang prescribe natin ay NSS. Unless doon sa reversible HLTs, pag meron kang hypovolemia, nagbibigay tayo ng crystalloid like NSS because nagpapaakyat siya. So paano natin nalalaman? But anyway, ganito po ang fluid replacement. Replace blood with blood, replace plasma with colloid, resuscitate with colloid, papataas ng BP pag sinabi ko resuscitate. Replace yung interstitial mo with saline. And then, rehydrate with dextrose. Kasi si dextrose is sugar, para naman maano si cells ko. No? So, paano natin ayusin ang sa loob ng ating, I will not discuss the isotonic, hypotonic. So, paano natin ayusin ang hydration sa loob ng katawan? Okay, tingnan natin sa slide. Meron ka dito sa pinakakanan mo, Yan po yung vessel. Sa pinakakaliwa mo, yung 30 liters, yan po yung cell. Sabi ko sa inyo, ang pinakamaraming fluid ay sa loob ng cell kasi doon siya kailangan. So, paano ililipat natin? Ano mangyayari pag nagbigay tayo ng fluid? Okay, tingnan natin ha. Tingin kayo sa slide. 3 liters ang vessel ko sa loob intravascular. Nagbigay ako ng 2 liters of blood. Anong mangyayari sa 2 liters? Magiging 5 liters of blood. Simple. Nagbigay ako ng 2 liters of colloid, kunwari dextran, or plasma sterile, or sterile. Anong mangyayari? Akyat siya ng 5 liter. Pero ang problema, dahil highly saturated siya, like a protein, i-absorb pa niya ang tubig na nagmumula sa interstitial space at saka sa intracellular space. Therefore, mas tataas pa konti. Kaya mabilis mag-resource kapag ginamitan mo ng colloid. Ang problema lang, minsan nakakakos ka ng allergic reaction. Nagbigay ako ng 2 liters saline, anong mangyayari? Tataas siya ng 5 liters, pero pupunta siya sa interstitial. Ang pinakamaganda sa saline, may maiiwan pa doon sa loob ng intravascular space, kaya pwede nakapagpataas siya ng BP. Pangalawa, mura siya. Pangatlo, pwede siya paglinis ng sugat. Kaya si NSS, sikat na sikat. Bigay ako ng dextrose. Si dextrose, dahil kailangan sa katawan, diretso po siya pupunta sa cell. Kasi doon siya kailangan. Okay? So, ladies and gentlemen, that's how we do it. No? So, I will not discuss anymore except, ano na lang, itong bakit kailangan natin i-correct yung mga hyper sa hypo. No? Hindi ko na pakilaman si sodium. Doon ako kay potassium kasi nagkakos ng cardiac arrest. Okay? So, dito si potassium, in both sides, pag mataas siya, magkakaroon ng heart problem. Pag mababa siya, heart problem, yung reversible age ng cardiac sa ACLS ko, yung hypokalemia, hyperkalemia, yun yung sinesete natin. So, sa hypokalemia, magkakaroon tayo ng cardiac arrest. So, paano natin tinitreat? Bigyan natin ng potassium chloride. Okay? Nag-hyperkalemia ka, mas maraming gamot. Kung may kidney, or may rhabdomyolysis, hyperkalemia ka. Makakita ka ngayon ng 50 waves. So, iti-treat natin ng 10% calcium chloride or calcium gluconate. Bigyan natin ng sodium bicarb at 1 mg per kilogram. Tapos, bigay tayo ng glucose plus insulin. Pwede tayo magka-exhalate para sa inima. Ang pinakamaganda, mag-dialysis tayo. So, yan lang. And then, isa pa, doon tayo sa magnesium. Kapag magnesium ang problema, pag kulang siya, magkakaroon tayo ng polymorphic ventricular tachycardia, no? PVCs, no? BPAP. So, bibigay tayo ng 1 mg IV na magnesium sulfate or hanggang 1 gram hanggang 2 grams. No? So, yun lang. Or else, hindi ma-resolve ang ating polymorphic. So, with that, ladies and gentlemen, I know it's tough for you already. I will let you rest. So, see you tomorrow at 8 o'clock unless you have questions regarding our topic. Nabubog na utak niya. So, walang tanong. So, with that, guys, see you tomorrow for continuation. So, I think dalawang lecture na lang ako. Electrical therapy sa drugs. Yun na lang. And then, cold blue na tayo. Then, in the afternoon, proceed. So, I will not apologize. ACLS is really tough. Kaya, kailangan eh. So, see you tomorrow at 8 o'clock in the morning. Okay? Kumain kayo mamaya ng masarap. Meron pa bukas. You're welcome. See you tomorrow.
Hello po, good afternoon po. Wait. Good afternoon po. Regarding po sa shirts and IDs niyo po, by Monday po namin siya isi-send yung soft copy po sa email po na provide niyo po. If you want to avail hard copy po, pwede naman po. For only 200 pesos po. Free shipping na po siya nationwide po. Kindly message your coordinators na lang po kung want nyo po mag-avail ng hard copy. Yung continuation po ng ECLS tomorrow po, 8 a.m. po yung start until 1 p.m. po. Then yung first aid po, 1 p.m. to 4 o'clock p.m. po. If you don't have any questions po, pwede na po kayong mag-leave po. Thank you po.